very important for every doctor. So now presentation is on, and I request Dr. Arvind Kumar to go ahead. Thank you.
Good morning, respected teachers, and good morning to all of you. Today, topic of my presentation is gemcitabine versus cisplatin concomitant to radiation in locally advanced head and neck cancer. First of all, introduction. As we all know, head and neck cancer is the 6th most common cancer in the world, and it's the most common cancer in Indian population, being most common in male and 4th most common in females. Head and neck term include oral cavity, pharynx, larynx, nasal, paranasal sinuses, nasal cavity, salivary gland, and external auditory canal. Head and neck cancer is named after their primary site of origin. As we all know, head and neck cancer represents approximately 14 lakh new cases and over 9 lakh deaths annually worldwide, and in India, the data is approximately 2.5 lakh cases and 1.38 lakh deaths in year 2022 as per Globocon 2022 data. Aims and objective. The aim of the study was to gemcitabine versus cisplatin concomitant to radiation in locally advanced head and neck cancer, and objective of the study was to compare survival and loco-regional control in these two schedules of the chemoradiation in locally advanced head and neck cancer. And second is to compare the treatment-related toxicity and tolerability of these two chemoradiation schedules. Now the study design. The study conducted in Pandit Bhagwat Dayal Sharma PJMS Rohtak with a 1 year of time period. Patients selected by the randomized control trial and population include histopathologically proven locally advanced head and neck cancer. There were 2 groups of the patient. Each group contained 30 patients. In group 1, that is the study group, these patients received standard fractionation with a total dose of 64 gray 32 fractions 6.2 weeks with intravenous gemcitabine 30 mg per meter square on weekly basis. And in the second group, that is the control group, all patients received cisplatin 40 mg weekly with the standard fractionation schedule. The inclusion criteria of the patient with histopathologically proven squamous cell carcinoma of head and neck AJCC stage 3 and 4, and the exclusion criteria include distance meds, prior radiation or surgery or chemotherapy received by the patient, poor general condition, KPS score less than 70, pregnancy and lactating females were not included, history of any allergy to gemcitabine or cisplatin. Now these are the results. There were acute skin and acute mucosal reaction during the treatment and at the completion of treatment. The maximum grade of the skin reaction at the completion of treatment were 3, which is seen in the study group 6.67% patient, and in the control group it is 3.33% patient. The mucosal reaction at the end of treatment maximum with the grade of 3 seen 13.33% in the study group and 10% in the control group. Now these are the 2 tables showing the disease status at the completion of treatment and disease status at last follow-up. The complete tumor response in the study group of patient having stage 3 is 9 out of 12, that is 75% response in stage 3 and 55.56% in the stage 4A in the study group, and that it is 72.73% in stage 3 in the control group and 68.42% in the control group. Stage 4A patients. The nodal response, complete nodal response were 75% in the stage 3 patients of study group and 55% patient in stage 4A and 72.73% in the control group and 63.16% in the stage 4A of the control group. Now this is the disease status at last follow-up. In the study group, 30 patients in stage 3, 9 out of 12 patients have the complete response and 3 patients have the residual response, and in stage 4A, 11 patients have the complete response and 6 patients out of 18 have the residual disease. And in the control group, in stage 3, 8 patients out of 11 have the complete response and 3 patients have the residual disease. And in stage 4A, 12 out of 19 patients have the complete response and 6 out of 19 patients have residual disease. Now the conclusion. This study was conducted on 60 treatment-naive patients of histopathologically proven locally advanced head and neck cancer. The aim of the study was to compare efficacy, tolerability and side effect profile of gemcitabine with cisplatin for concomitant chemoradiation in locally advanced head and neck cancer. At completion of treatment in the control group, 8 patients of stage 3 and 13 patients of stage 4A has a complete response, and the complete nodal response was seen in 8 patients of stage 3 and 12 patients of stage 4A. At the completion of treatment in the study group, 9 patients of stage 3 and 10 patients of stage 4A has a complete tumor response, and 9 patients in stage 3 and 10 patients in stage 4A has a complete nodal response. At the end of 6-month mandatory follow-up period, disease status was assessed. No evidence of disease was observed in 9 patients, that is 75% in stage 3, and 11 patients, that is 61.11% in stage 4A in study group, while 8 patients, that is 72.73% in stage 3 and 12 patients of stage 4A in the control group. In this study, response rate with concomitant chemoradiation with gemcitabine group was slightly better as compared to cisplatin group, but not statistically significant. The toxicity profile was comparable in both the groups. Hence, a large-scale study, randomized study, is recommended in future to establish the results.
So, what is the you recommend after your study?
Sorry?
Which one is better? Of course, there were no
gemcitabine-
statistically different. But
Sir,
what you are the main conclusion of your study? Which one is better?
so gemcitabine is slightly better. It is a
No.
short study.
So, have you started following this protocol after your study? Change your protocol in department or not?
Yes, sir. Sir, the standard treatment is cisplatin, which were given 3 weekly or weekly basis. Now we are comparing gemcitabine, which is also a radiosensitizer agent. So to compare the effect, both side effect and their tolerability to the patients. And the result shows that gemcitabine is well tolerated by the patient.
Which one had more toxicity? Which
Sir,
group?
Sir, cisplatin, if we give cisplatin 3 weekly, then it have more toxicity. But in my study, I was giving it weekly basis, so toxicity is less. But the comparable of both the groups is almost same. And the gemcitabine has a slightly better response than the cisplatin group.
Okay, thank you. So may I now invite the fourth presenter, Dipanshu, to assess the role of thoracic trauma severity score in predicting outcome of the patients following blunt trauma.
उसका अपलोड नहीं हो रहा है, पर योगेश को बोला उसका अपलोड होने में टाइम।
Achha, okay. So there is some problem with the uploading of the presentation of Dr. Dipanshu. So may I now call upon Dr. Yogesh for his presentation to complete the incidence of post-operative dry eye with respect to effective phaco time during phaco emulsification. Dr. Yogesh.
सेवन तो डेट
आपकी इस पेन ड्राइव में है ना ये कौन सा ये दीपांशु इस फोटो में आपकी
ठीक है, योगेश के नाम से चला, योगेश के नाम से चला दो भैया। प्रेजेंटेशन भी, प्रेजेंटेशन
प्रेजेंटेशन मोड में भाई साहब शिफ्ट का सेट करें
Good morning, everyone. Myself, Dr. Yogesh. I am presenting on a study done on comparative study for the incidence of post-operative dry eye with respect to effective phaco time during phaco emulsification. And my mentors are Professor Ashok Rathi and Dr. Jyoti Deswal. So, introduction: phaco emulsification is a modern day cataract surgery that employs ultrasound energy to emulsify the cataractous nucleus and vacuum to catch the nuclear material, and irrigation and aspiration mode for the cortex and viscoelastic removal. Another aspect of my study is dry eye disease, which the dry eye is a multifactorial disease of ocular surface which is characterized by loss of homeostasis of the tear film and accompanied by the ocular symptoms in which there is tear film instability and hyperosmolarity along with ocular surface inflammation and neurosensory abnormalities which play etiological roles. So, after the cataract surgery, the pathophysiology of dry eye disease occurrence can be numerous causes. One is the use of post-operative medication after the cataract surgery. The cataract surgery leading to corneal surface irregularities, leading to goblet cell reduction. There is also diminished corneal sensation post-cataract surgery, and there is also cataract surgery leading to surgical microscopic light exposure. So, aim of my study is to study the correlation between the incidence of post-operative dry eye with respect to effective phaco time or phaco energy given during the phaco emulsification cataract surgery. So, objective of my study, we are estimating the incidence and also correlating the incidence and severity pattern with respect to effective phaco time which is used during the phaco emulsification cataract surgery. So this is a prospective observational study done at PGMS Rohtak. We have included 70 patients with uncomplicated cataract. So mostly the patients included in this cataract surgery, they are the cataract patients with various nuclear grade with normal tear film and no pre-existing dry eye disease who have given their due consent. We have excluded in this study the patients with any pre-existing ocular disorder or any history of trauma, ocular surgical history leading to tear instability. They are excluded from the study. So we have done dry eye workup on the patients pre-operatively and noted their effective phaco time during the surgery, and then post-operatively dry eye tests are performed at follow-up at 1 week, 1 month and the 3-month interval. These are the 4 criteria we have used, the 4 dry eye parameters. First is OSDI score. We have made 2 groups based on the phaco time. The phaco time taken during the surgery, if it is less than 2.26, we have placed in group A, and if phaco time more than 2.26 minutes, then we have placed in group B. So first parameter we have seen is the OSDI score. This is a questionnaire. 12 questions are asked both pre and post operatively, and as we see in this table, in this chart, the post operative day 1 week, these OSDI score parameters, they are increasing, suggesting the dry eye post-operatively more significant at post-operative 1 week. Same, the findings in the tear breakup time. Tear breakup time is observed as we place the patient on the slit lamp and then apply the stain and then check for the tear film status. The same findings are observed at post-operative day 1 week. We are showing significant dry eye symptoms. These are more significant in the patients with phaco time more than 2.26 minutes or more phaco energy. The same in the Sharma's test. We use the Sharma's strip. That can be Sharma's 1 or Sharma 2. The significant findings are observed in the post-operative 1 week, more in the patients with phaco time more than 2.26 minutes. In the other is the corneal fluorescence staining. There is no significant finding observed in this. So summary or conclusion of my study is that pre-operative measurements of the dry eye symptoms were similar between the 2 groups, but in the post-operative, the results were more highlighted in the group B, who have taken more phaco time more than 2.26 minutes in terms of OSDI, Tibet and Sharma's test, while corneal fluorescence staining shows similar results. Thank you.
Hello.
Yes, sir.
Dr. Yogesh, it is in a
Yes, sir.
study, and you have divided it into 2 groups. One is phaco time less than 2.26
Yes, sir.
minutes and more than 2.6.
Yes, sir.
2.26.
Yes, sir.
So what is the criteria exactly? Can it be 3 minutes or something? Why 2.26? You have chosen this criteria.
Sir, actually, after taking the whole, after
Okay.
Sir, after giving data of the 70 patients, we get the phaco time, and then we have segregated into 2 groups so that we can compare based on this is average phaco time, 2.26 minutes, based on the study data of 70 patients.
What is the implication of your study? The message you want
Message,
to
more, as we see in the hard cataract, we have to apply more phaco energy. And as hard cataract take a lot of time, more effective phaco time to cut or remove the nucleus. So it will result in more dry eye symptoms on the post-operative 1 week. If we give more phaco energy and apply, give more effective phaco time during the cataract surgery.
What was your average time in more than 2.26 minutes? Average time.
Usually NS2 to NS3 grade cataract take less than 2.26 minutes. During
So what, Dr. What is your maximum range? What was the minimum time and what was the maximum time?
No, sir. During the cataract surgery, we can take as much time, but
For this phaco machine?
harder cataract, yes, sir.
For this
Yes,
comparison?
sir. Yes, this phaco machine.
So what the standard literature says, how much time it should be taken to avoid the complication of dry eye?
We use less energy, less than 1 minute, probably.
Okay, thank you.
Okay. Thank you, sir.
Hello, Dr. Pratima. She will be presenting topic correlation of cerebroplacental ratio in women with reduced fetal movements.
Good morning, everyone. Today I will be presenting the study on correlation of cerebroplacental ratio in patients with reduced fetal movement. Fetal movement suggests the normal integrity of cardiovascular and neuromuscular system of the fetus. So if there is any change in the pattern or frequency, it is alarming and it is known as reduced fetal movement. It is considered an easy, inexpensive and a valuable screening method. The incidence is 6 to 15% in normal pregnancies and many causative factors are associated with it. Reduced fetal movement is the first sign of placental insufficiency. It is associated with adverse perinatal outcomes like asphyxia, neurodevelopmental impairment and stillbirth. And due to placental insufficiency, cerebral redistribution can occur, which can be studied using ultrasound for fetal growth and color Doppler of umbilical as well as the fetal vessels. Cerebral redistribution can be measured using cerebroplacental ratio, which is the ratio of pulsatility index of middle cerebral artery and the umbilical artery. So the aim of the study was to evaluate cerebroplacental ratio in patients with reduced fetal movement. It was a prospective observational study conducted over a period of 1 year. Only singleton pregnancies with more than or equal to 36 weeks of gestation were taken. Patients with multifetal pregnancies, medical disorders, intrauterine demise and fetal anomalies were excluded. Total of 200 patients were taken and were equally divided into two groups, group 1 with reduced fetal movement and group 2 with normal fetal movement. So patients underwent ultrasound for amniotic fluid index, biophysical score and color Doppler. They underwent management as per the departmental protocols. Cerebroplacental ratio was calculated using the pulsatility index of middle cerebral artery and umbilical artery PI. Further subgroups were divided for normal and pathological CP ratio in case of reduced fetal movement. So here is the normal umbilical artery waveform and the normal middle cerebral artery waveform. So I observed that the demographic parameters such as maternal age, socioeconomic status were insignificant. Even parity and gestational age at admission had no statistical significance. Amniotic fluid index also did not have any statistical significance. Biophysical profile had statistical significance. In Doppler studies, only the cerebroplacental ratio had statistical significance. Various fetal-maternal outcomes were studied. The mean gestational age at delivery was more in group 1, that is the reduced fetal movement group. Distribution of onset of labor, we studied that many of the reduced fetal movement group were induced, which was statistically significant. In reduced fetal movement group, there were more chances of cesarean delivery. Even presence of knuckle cord, meconium stained liquor and fetal distress were more in reduced fetal movement group. Mean birth weight was less in reduced fetal movement group, and NICU admission was more in favor of reduced fetal movement group, most likely due to low birth weight. Regression analysis was done, which found out that the CP ratio was only significantly predicting the NICU admission parameter. Subgroup analysis done for normal CP ratio versus pathological CP ratio in reduced fetal movement group found out that the pathological CP ratio had low mean gestational age, low mean AFI and low mean birth weight. So reduced fetal movement is a link to range of pregnancy complications including reduced placental function, FGR, low birth weight and stillbirth. So placental dysfunction which causes fetal hypoxia will lead to the fetus to preserve its energy. And there will be an adaptive response causing cerebral redistribution. Increased induction of labor, cesarean deliveries were significantly more common. Meconium stained liquor and presence of knuckle cords were due to chronic fetal hypoxia. Even low birth weight indicated that fetal growth restriction was there in antenatal time. So these studies, Inaugural PR et al. And Ishragi and et al. Found similar findings. Whereas IOB et al. Found out that the CP ratio is not a good predictor of poor neonatal outcomes in reduced fetal movement group. However, they found out that there was increased incidence of meconium stained liquor. Lastly, I would conclude by saying that CP ratio can be incorporated to detect fetuses at risk for timely intervention among the patients who are supposed to be low risk but were having reduced fetal movement. It will help in risk stratification, optimizing perinatal outcomes. So these were the references I used, and thank you.
It is a nice presentation, and an important parameter has been calculated so as to predict the risk of various adverse outcome during delivery.
Yes, sir.
So what is your clear-cut message of this study?
Sir, the message can be that the cerebroplacental ratio can help in prediction and risk stratification. Like, I will take more care. The high risk, I will consider the patient to be a high risk. Generally, reduced fetal movement is ignored few times.
So what can be, from your study or you consider clinical practice, what a normal gynecologist can do to reduce this fetal rate?
Sir, general awareness can be done. The main adverse effect we worry about is stillbirth. So in increasing awareness, like after 32 weeks, we should ask the patient to maintain a fetal kick chart and then report to the emergency as soon as possible. And as an obstetrician, we should also be keen towards the patient and get an basic investigations done. And for that, I have said that cerebroplacental ratio can predict poor adverse outcomes as well.
Thank you.
Thank you, sir.
Now I invite Dr. Dipanshu to present his paper to assess the role of thoracic trauma severity score in predicting outcome of the patient following blunt trauma. Dr. Dipanshu.
Hello. Good morning to one all present here. I am Dr. Dipanshu, PG third year from General Surgery Department. Now my paper. My topic is to assess the role of thoracic trauma severity score in predicting outcome of the patients that sustain blunt thoracic trauma. My guide is Dr. Sanjay Marwa sir, Senior Professor and Head, Unit 4/2. Introduction. Chest trauma accounts for around 10 to 15% of total trauma cases, and the trauma-related deaths are around 25%, which are almost double. Now among chest trauma, blunt thoracic trauma is far more common than this penetrating chest trauma, and this in blunt thoracic trauma, road traffic accidents are the most common cause. What I mean to say is proper assessment of the trauma severity is very critical, especially at the time of admission. Now, research problem and the rationale of my thesis. There has been many thoracic trauma severity assessment scores like abbreviated injury score, injury severity score, pulmonary contusion score, revised trauma score, but none of them could accurately predict the outcome of the blunt thoracic trauma patients. This thoracic trauma severity score, though, is a very promising tool, but there has been very limited studies to validate its accuracy. Aim of my study was to determine the utility of the thoracic trauma severity score in predicting outcome of the patients that sustain blunt thoracic trauma. Primary objective was its correlation with the development of complications in the hospital stay like pneumonitis, empyema, ARDS, multiple organ failure and sepsis. And the second aim was to assess its accuracy in predicting the mortality in the patients. Now secondary objective was whether it can predict the duration of ICU stay, need for ventilator support or need for any surgical intervention. My study is a prospective observational study done in the Department of Surgery, PGIMS Rohtak for over a duration of 1 year. Sample size was 105 patients that sustained blunt thoracic trauma. My inclusion criteria was very wide that included all the patients that sustained chest trauma that required hospital admission. And the exclusion criteria was all the patients that sustained penetrating chest trauma or the patient who went left against medical advice. Now regarding this trauma severity score, it consists of 5 parameters. That is age, the ratio of partial pressure of oxygen in the arteries divided by the partial pressure of the oxygen in the supplied oxygen, number of rib fractures that patient sustained during the trauma, whether there is a pleural involvement or not, that is presence of hemothorax, pneumothorax, tension pneumothorax, and the last one is lung contusion. That out of these 5, lung contusion is very important in telling the mortality of the patients. When the thoracic trauma severity score was higher, it means that the severity of trauma was very high, and that resulted in the poor prognosis. Now regarding my results, mean age in my study was 44.71 years, and the most common age group affected was 30 to 41 years. And as road traffic accident was the most common cause, and mainly youngsters are involved in the RSAs, that's why most common age group was more of younger age group. And there was also male predominance also in my study. There was 80% of the cases. Most common mechanism of injury was roadside accidents, and the majority of the patients at the admission had normal heart rate, but more than around 50% had tachypnea. And the blood pressure, most of the patients at the time of admission had low BP, and the low blood pressure was significantly associated with the mortality. P-value was 0.001. Now regarding GCS at the time of admission, patients with lower GCS were significantly associated with mortality. Now regarding the score and outcomes, majority of the patients had low thoracic trauma severity score. Maximum score that a patient could get was 25, and the low thoracic trauma severity score means score 0 to 10. Only 7.61% of the patients had thoracic trauma severity score more than 10. High TSS, this thoracic trauma severity score accurately correlated with the increased duration of hospital stay, need for ICU stay, need for chest tube insertion, and higher mortality. Now ROC curve analysis. Area under the curve of my study was 76.9%. That tells us that it has a very good predictive ability. Now the optimal cutoff for mortality was come out to be more than 7. Now regarding predictive values, positive predictive value was 18.2%, and the negative predictive value was 98.6%. That means if a patient is scoring less than 7, that we can easily tell the patient will not going to die. But if the score is more than 7, then patient may or may not expire during the hospital stay. Now conclusion of my study. This thoracic trauma severity score is an effective tool for predicting outcome in the blunt thoracic trauma patients. Higher thoracic trauma severity score accurately correlated with increased mortality, in need for ICU admission, need for ventilatory support, and the prolonged hospital stay. The rib fractures when especially more than 3, and lung contusions when involving more than 2 lobes could significantly tell mortality of the patient. Now majority of the cases can be managed with simple conservative managements like chest tube insertion. As in my study, none of the patients required this thoracotomy. It is accurate to tell that around 90 to 95% of the patients of the blunt chest trauma, however severe, can be managed with this simple conservative managements or with simple tube thoracostomies. But as this study is a single center study and the limited number of cases could be taken, the larger multi-center studies are needed for its validation. Thank you.
This is an important topic, thoracic trauma, and in current scenario, many patients, they come with blunt trauma, penetrating trauma, gunshot injury, etc., etc. So it is an important study to determine the severity of the chest trauma by having these 5 criteria. And I think this study clearly shows that more the score, there is higher morbidity and mortality. But in your study, you have told that these patients, no patients required thoracotomy.
Sir,
why so?
Sir, my inclusion criteria was that I included only patients with blunt thoracic trauma, sir.
But blunt thoracic trauma also they require the surgery.
Yes, sir. They do require, sir. But what I'm trying to tell, sir, that there are very few patients that require thoracotomy, sir.
So
majority of the patients we can manage with simple tube thoracostomies or conservative management, sir. Oxygen supplementation.
So what are the indications for thoracotomy?
Sorry, sir.
What are the indications for thoracotomy?
Sir,
blood loss, and second is air leak. So do you know these two criteria? How much blood loss
yes,
and air leak?
After the chest tube insertion, if there is a stat more than 1 liter blood in the ICD bag, then it's clearly an indication for this emergency thoracotomy, sir.
And air leak,
Sorry, sir.
air leak, after putting the tube, air leak.
Air leak. Sir, presence of air leak do tell us that there has been bronchopleural fistula, but sir, I don't know for how much duration after how much duration it becomes the need for thoracotomy. Sorry, sir.
Okay.
I request
I think
all the
next is, I think they have uploaded Piyush.
आई रिक्वेस्ट जितने भी छात्र यहाँ बैठे हैं कृपया तालियों के साथ हर प्रेजेंटेशन पर इन स्पीकर्स का हौसला बढ़ाएं। कल इनकी जगह आप होंगे अपने गुरुजनों के सामने ये प्रेजेंट करना जस्ट लाइक योर फर्स्ट ईयर एग्जाम वाइवा। तो इनकी फीलिंग्स भी यही है, कृपया तालियों के साथ इनका हौसला बढ़ाते रहिए।
Okay, so his topic is comparison of efficacy of tapentadol nasal spray with parenteral diclofenac sodium in immediate post-operative pain, thoracic control following laparoscopic surgeries.
Good morning, everyone. I am Dr. Piyush, and I am presenting on my topic of presentation is comparison of efficacy of tapentadol nasal spray with parenteral diclofenac sodium in immediate post-operative pain control following laparoscopic surgeries. My guide is Dr. Senior Professor Dr. Sanjay Marwa sir, Unit Head 4/2. The management of pain.
फर्स्ट पेज है। सेकंड स्क्रीन ऑन।
Good morning, everyone. I am Dr. Piyush, and topic of my presentation is comparison of efficacy of tapentadol nasal spray with parenteral diclofenac sodium in immediate post-operative pain control following laparoscopic surgeries. My guide is Senior Professor Dr. Sanjay Marwa sir, Unit Head 4/2. So, as we know that management of pain after surgery is a humanitarian right and a basic need. Adequate pain relief results in better patient satisfaction, less morbidity, and early discharge from the hospitals, which also reduces hospital cost. Approximately 1/4 of the patients undergoing daycare surgery experience moderate to severe pain, and the pain is often undermanaged. Although pain following laparoscopic surgery is less than the open surgeries, but the early discomfort and pain is more in laparoscopic surgeries, that is in early first 24 hours. This origin of pain in the laparoscopic surgeries, it is from various sources. First of all, somatic, that is at the site of surgery. Then peritoneal and visceral pain caused by the phrenic nerve irritation due to pneumoperitoneum and the tissue destruction caused during the surgery. And although the new treatment modalities and pain techniques have been documented and practiced, the post-operative pain control continues to be undermanaged. The various modalities of drug administration have been used for better patient-controlled analgesia, that is PCA. That is, patient can manage their pain on their own, but still, after surgeries, the pain continues to be an undermanaged thing. The NSAIDs, though commonly used, have their own limitations due to their side effects like gastrointestinal side effects like bleeding or ulcers, and that limit their recurrent use. Then tapentadol nasal spray. Then talking about the opioids. They have other gastrointestinal side effects like constipation and vomiting, nausea that limits their use. The tapentadol nasal spray is a novel analgesic agent with a rapid action due to its rapid absorption because it is given through intranasal mode of route and it is rapidly absorbed in the circulation. And also it has dual mechanism of action which increases its efficacy. The goal is to provide adequate pain relief with minimal side effects and reduce the need of action time for pain control. So the aim of the study was to compare the efficacy of tapentadol nasal spray with intramuscular diclofenac sodium injection in immediate post-operative pain control following laparoscopic surgeries. The primary objective was to compare the pain scores and rescue analgesia requirement in both the groups. And the secondary objective was to compare the satisfaction scores, side effects, and the time of mobilization and oral feed after the surgery. How early the patient can start to resume his or her oral feeding and was able to mobilize or move on his or her own without any support. So my study was a prospective randomized control study, randomized observational study. Around 60 patients were taken, of which 30 patients were put in group A, that was assigned as tapentadol patients receiving tapentadol, and group B, that is patient receiving diclofenac, intramuscular diclofenac. Computer generated random numbers were generated and patients were put in two separate groups. Obviously the consent was taken and patient was informed about the whole study first hand, and it was all done after taking ethical clearance. Data was collected and it was entered, and ANOVA was done, and p-value was calculated for each comparative value, and data was here are the results of my study. The tapentadol provided faster pain relief in initial doses with significant difference up to the 5th dose. So the first doses was taken as 0 dose was given on intra-op table, and the first dose was given as soon as patient comes in post-op room, and thereafter around 8 hourly the doses was given. By the 5th dose, that is by the next day afternoon. Usually the surgeries were elective surgeries, so the surgeries were done in morning only at the time of 9 to 2. So by 5th dose, that is next day evening, the tapentadol had a significant faster pain relief, but thereafter no significant difference was noted. Tapentadol required fewer supervised doses. Here supervised doses means that patient was first dose and 0 dose. Patient was told how to take the tapentadol nasal spray, and thereafter patient was able to take the medication on his own with pain requirement. If the patient felt pain was severe enough, the patient was able to take analgesic on his or her own. But in case of diclofenac sodium, there was a lag between the patient telling that pain and providing the analgesia. So this thing was excluded in tapentadol nasal spray. Tapentadol group had lower pain scores on post-operative day 0 evening, post-operative day 0 night, and post-operative day 1 morning, and the p-value was significant. It was less than 0.05. No difference was seen in POD 1 afternoon onwards. So tapentadol group had significant higher satisfaction score. The patient was given after the time of discharge. Both patient satisfaction score and surgeon satisfaction score was calculated. and it was significant in case of tapentadol nasal spray. Patients found that they were easily able to relieve their pain on their own. Around 86.85% of the tapentadol patients required no analgesia on follow-up, and it was seen that the main reason was that patient did not prefer tapentadol nasal spray because due to some of the one side effect, that was local burning. Otherwise, patient was able to take the medication on his own. The common systemic side effect in both the groups were nausea and vomiting. Tapentadol showed significant drowsiness and headache initially, and diclofenac was associated with occasionally dry mouth. Conclusion: in present study, tapentadol nasal spray was found to be more effective than diclofenac intramuscular injection for post-operative pain control in providing faster pain relief with lower visual analog score, required lesser rescue analgesia, and most of the patients were able to use the spray without any supervision. This led to a better satisfaction of the patient as well as surgeon. The overall recovery rates in form of acceptance of oral feeds, time to mobilization, and duration of hospital stay, and even the systemic side effects were comparable among the two groups, and no one was found to be superior. Thank you.
So, do you think these two modalities are comparable in our own circumstances, in our institute? Although this has been tried internationally also, so what do you suggest? Is it possible in our institute?
So post-operative pain is undermanaged in lot of places, and NSAIDs and opioids are the only modalities available with us for managing the post-operative pain. In case of opioids, that due to the side effects or due to dependence, we usually avoid giving patient opioids because we have seen patients coming to us with demanding more opioid-related analgesia for their day-to-day pain also. And NSAIDs, we know patient can abuse NSAID. It is available on the over the counter.
Okay.
So patient abuses.
Why not a study comparing the injectable versus injectable? Because the diclofenac you was giving intramuscular, and this is the nasal spray. So, what the literature says injectable tramadol versus diclofenac?
Sir, in comparison of injectable tramadol and injectable diclofenac, both are comparable. Injectable tramadol is better, but the adverse effects are not avoided. Mm-hmm. We wanted to compare with intranasal mode of action because in our hospital settings, we wanted to compare the easily accessible, that is intramuscular diclofenac sodium, and tramadol, to compare which one is better. If both were intravenous, sir, the same thing would have happened, that the lag between the patient providing the pain and healthcare giving the analgesia was still there. So intranasal mode of administration provided patient care analgesia, so patient was able to alleviate the pain on his own.
Okay, thank you.
Thank you.
Now I call upon Dr. Anjali. Dr. Anjali, evaluation of role of arterial spin labeling in detecting perfusion changes in dementia or mild cognitive impairment.
Good morning, one and everyone. My topic is evaluation of role of arterial spin labeling in detecting perfusion changes in dementia and mild cognitive impairment. First is, what is dementia? It is a syndrome occurring as a result of disease of brain, which is usually chronic and progressive in nature. It consists of impairment of several higher cortical functions, which include memory, thinking, calculation, etc. Alzheimer's disease is the most common form of dementia. Neurodegenerative disorders affecting cognitive functions is causing a huge burden to society, approximately with 50 million cases worldwide, and it is expected to triple by 2050. My aim of study was to assess the ASL potential in detecting the perfusion changes and characterizing the dementia and its subtypes. So what is the role of imaging? Structural MRI detects the atrophy, but it lacks the early diagnostic accuracy. So changes in cerebral blood flow, it can be more dynamic, and it can provide greater sensitivity to early disease and help in assessing the response to therapy. Several imaging modalities are suitable for measuring the cerebral blood flow, like PET-CT, SPECT, bold functional MRI, and ASL MRI. But both SPECT and amyloid PET scan are costly, and it requires the IVSS and radiation exposure to the patient. Arterial spin labeling is an emerging non-invasive MRI technique for assessing the cerebral perfusion. Important benefit of ASL perfusion is the lack of requirement for an exogenous tracer. It uses the magnetically labeled water protons from arterial blood as an endogenous diffusible tracer. It is an attractive perfusion imaging modality, especially for children and for patients with contraindications or adverse reaction with contrast, and patients who are not able for contrast administration, like in renal failure patients, and those who need the repeated follow-up imaging. Since MRI scanners are more widely available than PET scanners, ASL might become an alternative for FDG PET, allowing a higher throughput of patients. Research objective of my study was determine the cerebral blood flow changes in different brain regions of dementia patient. Second, correlate perfusion changes with disease severity using the MoCA score. Third is the evaluate ASL as a diagnostic tool in differentiating the dementia subtypes. Material and methods included, this was a prospective observational cross-sectional study. It included the 30 dementia patients and 30 healthy controls performed on a 3 Tesla MRI. Different ROI region of interest were placed in the different areas of brains, like in the bilateral cerebral hemisphere, frontal, temporal, parietal, occipital, hippocampus, precuneus and posterior cingulate cortex. Cognitive assessment included the MoCA score. We assessed the patient using the MoCA score. Key finding and result of the study was the different distinctive pattern of hypoperfusion in the different areas of brain specific to the different disease. Like in Alzheimer's disease, we find out the marked hypoperfusion in the posterior cingulate and the precuneus. This image is showing the marked hypoperfusion in the precuneus region. This is the image of an Alzheimer's disease patient. Next is the vascular dementia. Perfusion deficit in the frontal and subcortical regions were found out, will link to the white matter ischemia. Next is the frontotemporal dementia. CBF in the bilateral frontal areas were significantly low in the frontotemporal dementia. So here I conclude, ASL MRI is an effective non-invasive tool for detecting the early perfusion changes in dementia. It can assist in differentiating the dementia subtypes based on the distinct hypoperfusion patterns. Clinical application is, it could serve as a screening tool before the PET-CT. It can reduce the cost to the patient and specifically radiation exposure, which is more beneficial. Future scope of my study is if we can standardize the ASL protocols, it can be used in the wider clinical adoption in dementia diagnosis. Thank you so much.
So, Dr. Anjali, I just want to ask, is it only of diagnostic value, or is it of also to monitor therapeutic interventions? Can it be used for those also? So the patient is of dementia and we have put him or her on a treatment. Can it be utilized for those also?
Yes, sir. We can assess the cerebral blood flow, like using the CBF maps. We can assess if blood flow is increasing or not.
Okay. And can you compare it with just like other modalities of just diffusion?
Yes, sir.
Diffusion in scanograms and all those. Those are also non-invasive MRI.
Yes,
have you
sir.
compared with those also?
Yes, sir. We compared with the PET-CT of some patients which were available, and it was like the similar areas of hypoperfusion were described in the PET-CT, and similar areas of hypoperfusion we found out in the MRI scan.
So it is a low cost,
yes,
good alternative to PET-CT.
Yes, sir. It can be used as a screening tool and can monitor the response to the therapy.
Thank you.
Next presentation by Dr. Bhaswati Bhardwaj. The topic is the incidence and management of anastomotic stricture in operative case of esophageal atresia with tracheoesophageal fistula.
Good morning, everyone. I'm Dr. Bhashwati Bharadwaj from the Department of Pediatric Surgery, PGIMS Rohtak. Here I am to present my paper on the incidence and management of anastomotic stricture in operated cases of esophageal atresia with tracheoesophageal fistula, a prospective study at a government tertiary care center of North India. Okay, so coming to the introduction, the strictures following surgeries in patients with esophageal atresia and tracheoesophageal fistula are common, and understanding the incidence and management of anastomotic strictures in such patients is very crucial to improve the post-operative outcomes in those patients. So the aim of our study was to assess the incidence and the management of these strictures in operated cases at a tertiary care center. The method was, the study period for the study was 8 years, and it was conducted in PGIMS Rohtak, and it was a prospective observational study, and the sample size was 67 patients that were operated for type C esophageal atresia, and the inclusion criteria was the patients with post-surgical complications of anastomotic stricture. The patient demographics, anastomotic tension if any, intraoperative complications, post-operative ventilation need and complications like infection were noted, along with the present complaints, clinical features and subsequent management. And the diagnosis was done by esophagogram followed by esophagoscopy in all the cases, and calibration was done subsequently in cases of obstruction, whether clinically, radiologically, and signs of strictures were present in these patients. So these are the diagrams that is used for management. These are the rigid esophagoscope that was used, and the guide wire and the light source, and with the dilators that were used in our cases were the Savary-Gilliard dilators. Coming to the result, total number of patients that were operated primarily was 67. Out of that, 18 patients had strictures, that is around 26.9%, that is the incidence rate in our study. And the age range was 8 months to 1.5 years, and male-female ratio was around 2.5:1. So the strictures, anastomotic strictures were divided according to severity into mild, moderate and severe, and it was seen that 33.3% of the patients were of mild stricture, whereas 44.4% were moderate and 22.2% were severe strictures. These are the contrast diagrams showing the normal esophagus post-surgery, and this second picture is the mild stricture, third is the moderate stricture, and last one is the severe stricture. So some risk factors which were found in our study, that is the low birth weight, prematurity, increased duration of ventilation post-surgery, then anastomotic tension, associated anomalies like vectoral anomalies, and hyperproteinemia, improper technique of anastomosis, infection in the post-operative period, and age at the time of surgery more than 7 days. These were found to be some factors associated with the incidence of anastomotic strictures post the primary surgery, and the p-value was found to be significant, and most importantly it was seen that anastomotic tension was the main culprit. Coming to the calibration success, so in these patients we went for esophageal calibration using the esophagoscope and then the Savary-Gilliard dilators. So in 17 patients, that is 94.4% of the patients, successful calibration was possible, and in only one patient it was not possible. So here we had to go for a redo thoracotomy. And in post-operative period for 1 year, it was seen that multiple calibrations was required in some patients. That is 2 patients, more than 3 sessions were required. So coming to the discussion, we had an incidence of 26.9% in our study, which was comparable to other studies. And risk factors, mainly the surgical technique and anastomotic tension was found to be significant mainly. Coming to the management, so esophagoscopy and dilatation was successful in 94.4% of the patients. So this was consistent with the studies in the published literatures. And only in one patient we had to go for a redo thoracotomy, which was also seen by a journal, that was Zai et al. In 2017. So the limitations of a study, it was a single center study, and also there was lack of long-term follow-up as suggested by Gonzalez, Cruci et al. And Liu et al. That they emphasized the need for continuous monitoring as strictures may recur. So coming to the conclusion, anastomotic strictures remain a common complication in esophageal atresia and tracheoesophageal repair. Calibration is effective to mild to moderate strictures and also majority of the severe strictures, but some of them might require surgical intervention. So further research with larger multi-center cohorts and longer term follow-up is required to optimize the management strategies. These are my references. Thank you.
It is a very good study, and
Thank you, sir.
the study has been done to assess the surgeon also, the
Yes, sir.
anastomotic technique.
Yes, sir.
and the tension.
Yes, sir.
Both things, they can contribute significantly for formation of esophageal strictures.
Yes,
So what you will suggest that how a surgeon can decrease the incidence of these strictures? Any change in future?
Yes, sir. So, there are few factors like we can prepone the surgery. Like if we keep the patient waiting for more than 7 days, it was seen that the post-operative outcome was like stricture incidence was more. So we should try to operate the patient as early as possible. And during the surgery, previously silk sutures were used. So nowadays vicryl sutures are used, and that is advocated so that later chances of strictures are less. And during the anastomosis also, we should intraoperatively decide if the gap is more between the upper and the lower esophageal segment. So in that point we have to decide and also take the help of other surgeon if we are not able to for a backup, for a second opinion also. If there is a surgeon available, we can take the opinion of his or her also, so that to decide whether to go for an anastomosis or we can go for esophagostomy and feeding gastrostomy, and further later on we can go for the primary anastomosis, the repair of the esophagus, replacement of the esophagus later on. So that can be done. And the anastomosis technique also, sir, if primary single layer anastomosis are preferred, so that has lesser chances of stricture formation. Yes, sir.
Okay.
Thank you, sir.
Thank you very much. So it was a very nice session, and I thanks the organizer, Dr. Pushpa Dayal, Dr. Varun, Dr. Umesh, Dr. Preeti for such a nice session. Thank you.
So, thank you for all the presenters. And as all of us know, this, you can say, research conclave is to learn also. So, I congratulate all the presenters, but a few words of advice. Always use a template which is visible to the, you can say, audience, even if the lights are on. 1. 2, don't overcrowd your slides. Third is, if you want to highlight something of your study, highlight it in bold or in some other color, so that audience gets a message directly from your team. So thank you, and thanks organizers for giving us the opportunity to judge these papers. Thank you.
Thank you, sir. I thank all the presenters and respected chairpersons for their valuable time and their presence. May I now request Dr. Dhruv Chaudhary, Dean Academic Affairs UHS, and Dr. Pushpa Dayal, Senior Professor and Head Gynae Department and the organizing chairperson, to please come on the stage and felicitate our respected chairpersons. I request the students to please come forward with saplings so as we can felicitate our chairpersons. Audience, please give a loud applause to your teachers and to your fellow presenters who have done such a great job. I congratulate all the presenters. The results will be announced post-lunch session, so please be around during that time. And like Dr. Umesh earlier said, it's not easy to stand here and present your work. It takes a lot of courage. So congratulations, and I think it should be motivating to rest of the students to do the same in future.
Done.
तालियों में कमी नहीं होनी चाहिए. It's a proud moment. It's time for felicitation of our chairpersons. We thank you, sirs, for your valuable time early in the morning.
The four stalwarts of our University of Health Sciences, Rohtak. Thank you.
Good morning, everybody. My request to the students and the audience is that this is the future, actually. This is what you need to learn, how to do a presentations, how to present your paper, how to speak, how to do it. So probably you must be wondering that why we have asked for the undergraduates, and I'm extremely thankful to our Dean, Director, as well as the Principal Dental College. So please look at it. This is what the future will be, and you will be presenting these things next year or a couple of days. So take that way and enjoy the session, and you will be learning quite a few things which may stand to you in the coming times in the future. Thank you.
So we proceed to our first talk of the day. Ladies and gentlemen, it is now time for a stimulating talk that we all have been waiting for by our esteemed guest, Dr. Simi Tiwari.
May I first kindly invite the chairpersons for this session. I invite Dr. Dhruv Chaudhary, Dean Academic Affairs, University Health Sciences, Rohtak, and Senior Professor, Head PCCM Department. I also invite Dr. Sanjay Tiwari, sir, Principal Postgraduate, Institute of Dental Sciences, Rohtak, to please come on the dais and take their places.
Big round of applause, ladies and gentlemen. I feel honored to introduce Dr. Simi Tiwari. She has done MBBS, DNB, MBA in HCA, and she is currently serving as the Joint Director Public Health and Head of the Center for One Health at the National Center for Disease Control. मैं आप सबको बताना चाहता हूं, जब आपने कोविड का नाम सुना था तो जितनी भी पॉलिसीज़ थी, जितने भी डिसीजन थे, उसमें NCDC का थिंक टैंक एक बहुत बड़ा रोल प्ले करता था, जिसमें मैडम का भी बहुत बड़ा योगदान था. अ बिग राउंड ऑफ अप्लॉज फॉर मैम फॉर स्पेयरिंग योर वैल्यूएबल टाइम. With over 2 decades of experience, Dr. Simi brings a robust combination of clinical and administrative expertise to her role, with extensive experience spanning key national health programs, including the Integrated Disease Surveillance Program, famously known as IDSP, Pediatric HIV Care under NACO, and the National Programs for Tuberculosis, RCH, which we now know as RMNCHA, Polio, and Mental Health. A recipient of prestigious 2020 Sir Louis Pasteur Oration Award for her contribution to rabies control. A big round of applause for her awards.
Ma'am has been awarded Young Epidemiologist Award by Indian Association of Epidemiologists for her significant contribution in the field of infectious disease, zoonosis, epidemiology and outbreak investigations, and One Health. Dr. Simi plays a pivotal role in outbreak investigations, research and development of national guidelines, just like Sir told. Today, she will be speaking on NCDC's role in One Health, bridging human, animal and environmental health. This topic has become even more relevant after the COVID-19 pandemic.
Ma'am, we request you to please come on the dais and enlighten us all with your knowledge and experience. I request everyone to please welcome her with a big round of applause.
नमस्कार, सुप्रभात, आदरणीय चेयरपर्सन्स ऑन द डायस और मेरे प्रिय स्टूडेंट्स, young generations and upcoming leaders for the country's public health and overall leading the health towards 2047, that is Viksit Bharat. I am honored, I express my extreme gratitude to the organizers for giving this opportunity to me to interact with the young students. मुझे अत्यधिक प्रसन्नता हो रही है आप सभी स्टूडेंट्स के बीच में इस एक वाइब्रेंट टॉपिक के बारे में डिस्कशन करने के लिए, जिसको हम वन हेल्थ के नाम से जान रहे हैं. वी अंडरस्टैंड दैट वन हेल्थ इज़ नॉट अ न्यू कॉन्सेप्ट. इट हैज़ बीन देयर सिंस सेंचुरीज, सिंस डिकेड्स in our ongoing efforts for public health or overall health efforts for a country. आप लोगों ने सभी ने एल्मा एटा डिक्लेरेशन का नाम सुना होगा. मैं कम्युनिटी मेडिसिन की ब्रांच से आती हूँ, जो सबसे बोरिंग सब्जेक्ट माना जाता है. सो व्हाट एग्जैक्टली वी आर डूइंग इन कम्युनिटी हेल्थ. कम्युनिटी हेल्थ में शुरू से पढ़ाया जाता है एल्मा एटा. जब डिक्लेरेशन हुआ था USSR में, जब हम सब लोग बात कर रहे थे हेल्थ फॉर ऑल. हेल्थ फॉर ऑल का मतलब ही ये था कि वी नीड टू थिंक हेल्थ फ्रॉम अ wider perspective wherein we are concerned of health of not only human but also other people around us. Health for all, that was having an imbibed principle of having health of human beings, health of environment, health of our surrounding animals, and health of plant and biology. So this is what the health for all was concerned. And second, the greatest principle which was talked in Alma Ata Declaration to strengthen the intersectoral collaboration. उसके बाद हमारे सर जोसेफ बोर ने एक कमेटी कॉन्स्टिट्यूट की थी 1946 में, सर बोर कमेटी, जिसमें प्राइमरी हेल्थ केयर को एक बहुत ही रोबस्ट मैकेनिज्म के तौर पे बताया गया था कि अगर हमें इंडिया का हेल्थ स्ट्रक्चर को सुधारना है तो हमें बिल्कुल ग्रास रूट लेवल पे जाकर के काम करना पड़ेगा. तो ये पब्लिक हेल्थ वालों का, या आई मस्ट से इट वाज अ combined effort for all the speciality with the public health principles overriding, wherein we were thinking कि हमें infant mortality rate को कम करना है, हमें maternal mortality को कम करना है, हमें स्वच्छता के बारे में ध्यान देना है, vaccination programs को आगे लेके जाना है. तो that was the thing how the intersectoral coordination, the importance of intra and intersectoral coordination, now commonly known as a One Health approach, that was kept in the root of a health principle of our country. अब इसके बाद क्या हुआ कि जूनोटिक डिजीज़ की बहुत सारी आउटब्रेक्स आती गई कंट्रीज़ में ग्लोबल लेवल पे, तो वन हेल्थ प्रिंसिपल और ज़्यादा रेलिवेंट हो गया. इंटरसेक्टर स्ट्रेंथनिंग इंटरसेक्टोरल कोऑर्डिनेशन को एक और नया नाम दे दिया गया वन हेल्थ के नाम. नाउ दिस concept has gained a momentum even more after the COVID-19 pandemic, when we got to know that this SARS-CoV virus 2, that is somewhere has origin from the wildlife species. तो ये concept तो शुरू से है, but now it is gained a little more moment. So I would be speaking on few of the slides about One Health, that what we are doing at National Center for Disease Control. सो आई हैव ऑलरेडी टोल्ड वन हेल्थ की डेफिनेशंस बहुत सारे लोग देते हैं, लेकिन अभी आजकल ये वाली डेफिनेशन ट्रेंड में है. अभी भी WHO के पेंडेमिक अकॉर्ड के बहुत सारे नेगोशिएशंस चल रहे हैं. वो शायद यू आर टू जूनियर्स टू अंडरस्टैंड दोज नेगोशिएशंस, बट इट इज़ बीइंग डेल्ट एट अ हाइएस्ट पॉलिटिकल लेवल ग्लोबली. द हाइएस्ट UN quadripartite, World Health Organization, World Organization of Animal Health, फूड एंड एग्रीकल्चर ऑर्गेनाइजेशन एंड UNEP. तो बहुत सारे जो ग्लोबल एजेंसीज़ हैं वो इस डेफिनेशंस को लेकर के अभी चिंतित है कि हम इस डेफिनेशन में हम क्या क्या एनकम्पास करें. बट लेकिन मैं ये डेफिनेशन आपके सामने प्रस्तुत करना चाहूँगी कि जो अभी लेटेस्ट डेफिनेशन है. वन हेल्थ इज़ अ कोलैबोरेटिव मल्टी सेक्टोरल ट्रांसडिसिप्लिनरी अप्रोच वर्किंग एट लोकल, regional, national and global levels to achieve the optimal health and well-being outcomes, recognizing the interconnections between people, animal, plants and their shared environment. अभी सब students you are medicos, but have you ever interacted with your line discipline, the veterinary medicine? To what an extent they are going to play an important role in the upcoming health well-being of our country. So veterinary science is equally important for us. Human health along with the human health science, and similarly we have to have a very close connection with the agricultural scientists. तो ये जो डिसिप्लिन है वन हेल्थ का, ये मल्टी सेक्टोरल डायमेंशंस की बात करता है, जिसमें ह्यूमन हेल्थ सेक्टर यानी कि जो मेडिकल डॉक्टर है उसको वेटरनरी के साथ कंधे से कंधा मिला करके प्रॉब्लम्स को समझना है और उसके सॉल्यूशंस को आगे लेकर के आना है. सो दिस इज़ हाउ वी अंडरस्टैंड. अभी क्या होता है कि बिकॉज वी हैव बीन सेलेक्टेड बाय वर्च्यू ऑफ दैट वी हैव गॉट सेलेक्टेड इन अ मेडिकल फील्ड. कुछ एक लोग जिनका सब लोग मेडिकल फील्ड के लिए ही एस्पायर करते हैं. जब हम लोग PMT की तैयारी कर रहे होते हैं या जब हम लोग 11th 12th स्टैंडर्ड में होते हैं तो हम लोग ये सोचते हैं कि हमारा मेडिकल में सिलेक्शन हो जाएगा. कुछ लोग होते हैं कि उनका नहीं हो पाता, किसी का होम्योपैथी मिल जाता है, किसी को आयुर्वेदिक मिल जाता है. कुछ एक बच्चे ऐसे होते हैं जो वेटरनरी प्रोफेशंस में आ जाते हैं. तो हमारे दिमाग में क्या होता है कि जिसको MBBS मिल गया वो सुपीरियर है. Do you think, how many of you think that MBBS are superior? ये एक कॉमन डिक्टिम है कि जो मेडिकल प्रोफेशन है, दे कीप देमसेल्व्स, दे थिंक देमसेल्व्स दैट वी आर सुपीरियर अमंग दैट लॉट. बट लेकिन जैसे जैसे आप अपने प्रोफेशन में आगे बढ़ेंगे, आपको ये समझ में आएगा कि दूसरे डिसिप्लिन्स कितने ज़्यादा इम्पॉर्टेंट हैं हमारे लिए. आज की डेट में हम लोग सुबह ब्रेकफास्ट से उठते हैं and then we have a cup of tea. What exactly we are having? We are having a milk in that cup of tea, and that milk, by virtue of our veterinary doctors and veterinary professionals, that is reaching to our houses. So you need to understand the importance of food safety and security. The veterinary science and agriculture science is equally important to keep away the health at core. So this is how we understand the One Health, the true principle of One Health in our overall human health well-being. If we look at the historical perspectives, तो जो Greek physicians हुए थे, Hippocrates, उन्होंने बहुत पुराने समय में ये लिखा था कि air, waters and places, they are harbinger, they have a very close connection among each other. And similarly, the famous Rudolf Virchow, he was a famous scientist in the 19th century, and he has written very beginning that between animal and human medicine, there is no dividing line, and nor there should be. Human and animal, they are going to share the same environment, same climate, same resources. So there should not be any dividing line between them. आप में से बहुत सारे लोग, हम लोगों में से बहुत सारे लोग हैं जो हम गांव की पृष्ठभूमि से आते हैं. लाइफ स्टॉक एनिमल यानी कि गाय, भैंस, बकरी, ये हमारा एनवायरनमेंट शेयर करते हैं हमारे घरों के साथ. लेकिन क्या हमने कभी उस पर्सपेक्टिव से देखा है कि वो जो बीमारियां हमारे उन जानवरों में है, क्या वो हमें अफेक्ट कर सकती हैं, या हमें जो बीमारियां हैं वो अफेक्ट कर सकती हैं? कुछ एक बच्चे, बिकॉज यू बिलोंग टू अ डिफरेंट प्रोफेशनल्स, फर्स्ट प्रोफेशनल भी होगा, सेकेंड प्रोफेशनल, फाइनल प्रोफेशनल भी होगा, पीजीज भी हैं. Depending on your standard of current education, you might be gradually understanding what exactly is the zoonotic diseases are important concerns, which are the diseases which are transmitted between human and animals. And similarly, the reverse zoonosis is another term which came into perspective of One Health. So the Rudolf Virchow was one famous scientist which has already highlighted that there is a close connection between human and animal. सिमिलरली विलियम ओसलर साहब कुछ कह के गए, उसके बाद इंडियन सिनेरियो में बोर कमेटी मैंने पहले बताया है. तो ओवरऑल अगर हम देखें कि हेल्थ फॉर ऑल, एनकम्पासिंग प्लेनेटरी हेल्थ एंड देन इको हेल्थ एंड देन वन हेल्थ. सो दीज आर ऑल कोर कंसेप्ट्स. वाई वन हेल्थ इज इम्पॉर्टेंट? वन हेल्थ इज़ इम्पॉर्टेंट क्योंकि अगर हम इन्फेक्शियस डिजीज़ का डेटा देखते हैं तो हमें ये पता लगता है कि 60% of the non-infectious diseases and 70% of the newly emerging re-emerging infectious diseases are zoonotic in origin. और zoonosis में भी वाइल्ड लाइफ ओरिजिन से ये पैथोजेंस आ रहे हैं. जितने भी dreaded pathogens हैं, starting from SARS-CoV-2 which was having a significant R0. Similarly, the Ebola which is creating so many outbreaks in the other countries, African countries. जीका वायरस, इबोला वायरस, नीपा आउटब्रेक अगर आपने सुना हो, आजकल में ही केरला में काफ़ी आउटब्रेक्स हो रही हैं. क्रीमन कॉन्गो हेमरेजिक फीवर. तो ये जो यूनिक पैथोजेंस हैं ये बहुत ही सिग्निफिकेंट केस फर्टेलिटी रेट रखते हैं. रेबीज़ इज़ अ यूनिक virus which is almost 100% fatal. I understand that few of you have seen the rabies patient in front of your eyes. और अगर किसी ने रेबीज़ पेशेंट नहीं देखा है तो आप प्लीज़ यूट्यूब पे जाइए और देखिए कि रेबीज़ पेशेंट कैसे बिहेव करता है. इट इज़ 100% फेटल डिजीज़, 100%. अगर रेबीज़ हो गया तो उसके बचने की कोई उम्मीद नहीं है. दैट इज़ अगेन अ जूनोटिक पैथोजन. और किससे होता है? डॉग बाइट से होता है. सो दिस इज़ वेरी इंपॉर्टेंट टू अंडरस्टैंड राइट फ्रॉम द बिगनिंग that to what an extent we are adopting the treatment strategy to treat or to prevent or to save a life of an animal bite victim from a potential rabid dog. तो ये सब चीज़ें बहुत important हैं. Zoonosis is one of the core domain of One Health. But apart from this, there are other domains. But why One Health is important for us? That world population is growing, interaction between the human and animal is growing. हम लोग वाइल्ड लाइफ एरियाज में एनक्रोच करते जा रहे हैं धीरे धीरे, फॉरेस्ट को काट करके हम एग्रीकल्चरल लैंड बना रहे हैं, तो क्या हो रहा है कि जो वाइल्ड लाइफ फ्लोरा एंड फौना है उनका तो आपने हैबिटेट लॉस हो गया उनका, तो वी हैव स्नैच्ड देयर होम्स, सो नाउ दे आर एनकंपासिंग ऑन आवर डोमेस्टिक एरियाज. So we are encroaching on, we are at pace of utilizing the natural resources at expense of growing and emerging health threats at human-animal interface. अगर आप नेचर को डिस्टर्ब करेंगे तो नेचर भी आपको नहीं छोड़ेगा. So this is how the nature is balancing in itself, and there is again and again an increasing threat of zoonotic pathogens because of all these issues. Changing land use, इंक्रीजिंग वर्ल्ड पॉपुलेशन, इंक्रीजिंग डिमांड ऑफ द लाइफ स्टॉक प्रोडक्ट, पॉपुलेशन बढ़ती जा रही है, दूध सबको चाहिए, मीट सबको चाहिए, एग सबको चाहिए, तो कहाँ तक हम इस डिमांड को पूरा करेंगे? सो दिस इज हाउ द वी आर कॉन्स्टेंटली प्रेशराइजिंग अवर नेचुरल रिसोर्सेज एंड वी आर कॉन्स्टेंटली डिस्टर्बिंग द नेचुरल हार्मनी, नेचर हार्मनी. सो दैट्स वाई दीज थ्रेट्स आर अगेन एंड अगेन इंक्रीजिंग. And globally, we are seeing that there is a rising trend of zoonotic threats, pandemic threats. अभी जो पैंडमिक आया करीब 70-80 साल के बाद ये पैंडमिक हमने देखा. इन्फ्लुएंजा के बाद ये वाला कोविड पैंडमिक था, लेकिन आने वाले समय में हमें ये समझ में आ रहा है कि अब पैंडमिक शायद 20 या 30 साल के अंतराल पे भी आने लग सकता है. अगर हमने क्लाइमेट की तरफ ध्यान नहीं दिया, अगर हमने अपने नेचुरल रिसोर्सेज का जो कंजम्पशन पैटर्न है उस पर ध्यान नहीं दिया. सो दीज आर द थिंग्स दैट वी नीड टू थिंक राइट फ्रॉम आवर स्टूडेंट लाइफ. सो दीज आर द फैक्टर्स. इसी को ध्यान में रखते हुए देयर आर सेवरल ग्लोबल इनिशिएटिव्स हैज़ कम ऑन द वन हेल्थ. मैनहट्टन प्रिंसिपल आया था, फिर उसके बाद वन हेल्थ कमीशन आया, अमेरिकन वेटनरी मेडिकल एसोसिएशन और अमेरिकन पब्लिक हेल्थ एसोसिएशन, दे कम टुगेदर टू कम अप विद अ वन हेल्थ इनिशिएशन. फिर उसके बाद UN क्वाड्रीपार्टाइट आ गया, FAO, वर्ल्ड ऑर्गेनाइजेशन ऑफ एनिमल हेल्थ, वर्ल्ड WHO, USAID ने कुछ लॉन्च किया. इसी तरीके से बहुत सारी ग्लोबल मोमेंटम इज़ देयर फॉर द वन हेल्थ एक्टिविटीज़. अभी बहुत ज़्यादा ट्रेंड में है कि वन हेल्थ को कैसे हम लोग ऑपरेशनलाइज करें, कैसे इंस्टीट्यूशनलाइज करें, उसके लिए लीगल फ्रेमवर्क की क्या ज़रूरत पड़ेगी, लीगल बैकअप का क्या ज़रूरत पड़ेगा. तो दिस इज़ अ स्लाइड विच इज़ शोइंग सम ऑफ द ग्लोबल इनिशिएटिव्स विच हैज़ बीन हैपनिंग ऑन द वन हेल्थ कोर डोमेन्स. So as I was talking about One Health core domains, so that is a zoonosis is one of the important subject which comes under the domain of One Health. Environmental health and climate related health problems, they are again important from the One Health perspectives. Antimicrobial resistance is the biggest threat. Most of you, they might be belonging to the clinical disciplines and you may understand कि hospital acquired infections का main कारण क्या है, कहाँ से ये nosocomial infections आते हैं, ICU में क्यों डेथ्स इतनी ज़्यादा होती हैं. सो आई वुड रिक्वेस्ट दिस यंग स्टूडेंट्स just to look into the data sets of the ICU, the death patterns, the mortality patterns which are happening, to what an extent, what fraction of deaths in the ICU is because of resistant bacteria, what led to the multi-organ failure in the ICU setting. So for that antimicrobial resistance is one of the important, क्योंकि हम लोग injudicious use करते हैं एंटीमाइक्रोबियल रेजिस्टेंस का, जबकि हमें जुडिशियस यूज़ करना है. जहाँ पे ज़रूरत नहीं है एंटीमाइक्रोबियल वहाँ हमें एंटीबायोटिक प्रेस्क्राइब नहीं करना है. लेकिन हम लोग पिल को ऐसे स्वेलो करना सिखा देते हैं मरीज़ को भी, जब तक हमने उसके प्रेस्क्रिप्शन पे एंटीबायोटिक नहीं लिखा तब तक वो भी सवाल करता है डॉक्टर से कि डॉक्टर साहब आपने तो दवाई नहीं दी. सो दिस इज़ द हाउ द प्रैक्टिसेस अभी इतना इनजुडिशियस यूज़ ऑफ एंटीबायोटिक्स इतना मार्केट में है, इतना प्रेवलेंट है. सो दैट एंड वी आर नो मोर लेफ्ट विद एनी न्यू मॉलिक्यूल. अभी आने वाले 10 या 20 साल में भी कोई नया एंटीबायोटिक, कोई नया सेफेलोस्पोरिन, आई डोंट नो वेदर वी विल बी एबल टू डिस्कवर और नॉट. एंड वी आर एट लेंथ वी आर एग्जॉस्टिंग ऑल द अवेलेबल एंटीमाइक्रोबियल्स. सो दिस इज अलार्मिंग बेल. ग्लोबल लेवल पे ये बहुत सिंसियरली देखा जा रहा है, बट क्या हम गांव में जो हमारा फिजिशियन है जो प्रैक्टिस कर रहा है, जिसको आदत लग गई है एमॉक्सिसिलिन और एम्पिसिलिन लिखने की, उसको हम कैसे समझा पाएंगे, कैसे हम उसको अवेयर कर पाएंगे. हमारे यंग रेजिडेंट्स, सीनियर रेजिडेंट्स, दोज वी अपील टू यू एज अ young doctors that please think of judicious use of antimicrobials. Sitting at a highest level, at ministry level, we can only draft the policy. We can only think. But implementers तो clinicians ही हैं, implementers तो frontline worker ही है. Frontline PHC में बैठा हुआ डॉक्टर या CSC में डॉक्टर या एक प्राइवेट फिजिशियन. आप लोग जाएंगे यहाँ से प्राइवेट प्रैक्टिस करेंगे. So apart from this, food safety and security is again a big concern. आप देख रहे हैं कि अभी जो भी स्ट्रॉबेरी, ब्लूबेरी, जो बहुत ही ट्रेंडिंग फ्रूट्स हैं, उनमें अगर आप पेस्टिसाइड्स की मात्रा देखें, you will not believe that they are not even, worth eating. So these are the things which need to be understood from a greater public health perspective. But the authorities are working on that, but still a long way to go. Agriculture scientists, public health professionals, and veterinaries, they need to work together to understand these core principles and work in coordination and collaboration with them. One Health governance, not only for these above core domains, but it is very much relevant to the mental health, occupational health, and chronic diseases as well. So this is again the same slide, that how deforestation has impacted the One Health and given rise to so many problems, including the zoonosis and other re-emerging infectious diseases. Antimicrobial resistance, I have already told that it is a global threat and coming in a big way, and challenging our own health gains which have achieved so far. So this is one of the serious concern and need to be looked from a One Health lens. ये कॉन्सेप्ट मैं आपके साथ शेयर करना चाहूँगी, जहाँ पे zoonotic diseases emergence are happening because of a spillover of pathogens from animals to humans. COVID may or may not be of a same example, because there are only conspiracy theories going on about COVID. अभी तक कुछ कॉन्क्रीट उसके लिए सामने नहीं आया. बहुत सारी थ्योरीज हैं, कॉन्स्पिरेसी थ्योरीज वन ऑफ देम कि लैब रिलेटेड वायरस था या एक्चुअल पेंगोलिन से आया था, ह्यूमन में ट्रांसमिट हो गया, धीरे धीरे इवॉल्व हुआ. सो दीज आर ऑल, बट द थिंग्स आर हैपनिंग इन द नेचर. ये स्पिल ओवर धीरे धीरे हो रहा है. अगर हम इन्फ्लुएंजा के पैथोजन को देखें, H5N1 का, CDC ने 3 या 4 रिपोर्ट्स पब्लिश की हैं. CDC US अटलांटा, उन्होंने कैटल में अभी इन्फ्लुएंजा आने लग गया है, यानी कि काउज एंड बफेलोज, दे आर रिपोर्टिंग द इन्फ्लुएंजा वायरस H5N1, जिसकी 50 से 70% केस फेटेलिटी रेट है. यानी कि अगर हो गया और टाइम पे डिटेक्ट नहीं हुआ, पेशेंट 48 आवर्स में दे कैन सकम टू डेथ. सो दिस इज द थिंग. एंड रिसेंटली नेशनल सेंटर फॉर डिजीज कंट्रोल, दे हैव इन्वेस्टिगेटेड एन आउटब्रेक जहाँ पे 4 zoo tigers, they were detected to have the H5N1, but luckily there was no human infection was there. वो एक जॉइंट आउटब्रेक इन्वेस्टिगेशन था जिसमें मल्टीडिसिप्लिनरी टीम गई थी, ह्यूमन हेल्थ, वेटनरी हेल्थ, वाइल्ड लाइफ और एनवायरनमेंट. चारों स्पेशलिस्ट ने जाकर के वो इन्वेस्टिगेट किया, बहुत थॉरो इन्वेस्टिगेट किया. पूरा वैल्यू चेन हमने डिस्कवर किया कि टाइगर को कहाँ से मूव किया गया था, क्या उसने खाना खाया था, क्या उसको चिकन दिया गया था, वो जो चिकन दिया गया था उसका सर्विलेंस हुआ तो उसकी टेस्टिंग रिपोर्ट थी क्या. सो these all aspects were looked into those kind of outbreaks. So these spillover are happening. Why I am concerned कि H5N1 अब धीरे धीरे अपना पैटर्न चेंज कर रहा है. पहले बर्ड्स में होता था, लेकिन अब मैमल्स, मोर स्पीशीज ऑफ मैमल्स आर बीइंग अफेक्टेड बाय दिस H5N1 वायरस. H1N1 तो हमने सुना था कि नॉर्मल है, लेकिन H5N1 इज अ लो पैथोजेनिक एंड हाई पैथोजेनिक, दोनों तरीके का होता है और दोनों में ह्यूमन पे ट्रांसमिशन हो सकता है. बट द ब्रिजिंग पॉपुलेशन, zoo animals, increasing livestock animals involvement by H5N1. So this is an example of spillover. Similarly, Nipah is again a similar kind of virus wherein spillover is happening. Greater and greater outbreaks. अब हम बहुत ज़्यादा recent outbreaks वो हर साल हमें नीपा की 2 या 4 केसेस हमें कंट्री में मिल जाते हैं. But thanks to the Public Health Department and the other department, Wildlife and Animal Husbandry, they collectively put together and contain the outbreak on time. But this is the things I would like to tell you as a young children, young students, that please try to understand that these transmission dynamics, to what an extent these are going to be important for us in the future. This is a slide showing the history of greater pandemics which are of zoonosis in origin: plague, cholera, Russian flu, then Hong Kong flu, swine flu, Ebola, then Spanish flu, yellow fever, Asian flu, SARS, then MERS-CoV from the China, and then again MERS-CoV was in a Middle East country, but the China was also incriminated, and latestly from the COVID-19 pandemic. So these were the greater pandemics which has been of zoonotic in origin. जिन्होंने फ्लू ने तो पूरा कॉन्टिनेंट ही that was taken on toll. अगर आप हिस्ट्री पढ़ें, स्पेनिश फ्लू and this Hong Kong flu, how they have taken a toll on a greater, and black death. The plague has been known in the past time as a black death. This is a slide showing to what an extent the economic is being affected by One Health. We can understand that SARS-CoV-1 in 2020 they led to $41.5 billion US loss. तो इकोनॉमिक इम्पैक्ट इतना होता है अगर पैंडेमिक होती है. यू हैव फ्रॉम योर आई थिंक कभी 80 साल में या 70 साल में कोई एक पैंडेमिक आता है, एंड वी हैव फ्रॉम आवर जनरेशन हैज सीन दिस कोविड पैंडेमिक कि कितना लॉस हुआ था इकोनॉमिकली, सोशली. every it has taken it had a devastating impact. आपने देखा होगा कि लोग कैसे घर छोड़ करके जा रहे थे कैसे. So this is the thing. फिर उसके बाद इतना वन हेल्थ के लिए इतना मूवमेंट चला, इतना बाहर से इतनी डोनेशंस आई. देयर आर सो मेनी फंडिंग वाज अवेलेबल फॉर द वन हेल्थ पर्सपेक्टिव कि अब हमें हर एक कंट्री को विश्व में पैंडेमिक के लिए प्रिपेयर्ड होना चाहिए. Now I would speak about National Center for Disease Control. We know that maybe you may be new to hear about NCDC, but NCDC is one of the apex public health institute in the country, which is an advisory body for Ministry of Health and Family Welfare to take any kind of policy or technical decision on any public health emergency or routine endemic diseases as well. हमारे पास NCDC में बहुत सारे टेक्निकल डिवीजन्स हैं, 18 टेक्निकल डिवीजन हैं और बहुत बड़ा लेबोरेटरी स्ट्रक्चर है, इंक्लूडिंग BSL-3 लेबोरेटरीज. तो करीब 72 BSL-2 लेबोरेटरीज हैं, BSL-3 लेबोरेटरीज भी हैं. और NCDC खाली दिल्ली में ही नहीं है, 8 ब्रांचेस अभी हमारी फंक्शनल हैं पूरी कंट्री में, और हर स्टेट में एक ब्रांच बन रही है आने वाले टाइम में. NCDC को बहुत बड़े लेवल पे एक्सपेंड किया जा रहा है. इसके अलावा 5 रीजनल NCDCs भी बन रहे हैं, और इसके अलावा मेट्रोपॉलिटन सर्विलेंस यूनिट भी हैं, जो 20 मेट्रोपॉलिटन सर्विलेंस यूनिट हैं जो सिर्फ अर्बन पॉपुलेशन को केटर करती हैं. तो दिस इज़ द होल स्ट्रक्चर ऑफ NCDC. कुछ नेशनल हेल्थ प्रोग्राम्स हैं, सिग्निफिकेंट प्रोग्राम्स हैं जो नेशनल सेंटर फॉर डिजीज़ कंट्रोल के द्वारा कोऑर्डिनेट और कंट्रोल किए जाते हैं. इंटीग्रेटेड डिजीज सर्विलेंस प्रोग्राम दैट हैज़ बीन वन ऑफ द यूनिक प्रोग्राम विच हैज़ बीन शोकेस्ड ऑन अ ग्लोबल प्लेटफॉर्म, that it is unique in terms of capturing incidence data of 32 and more than 32 disease conditions. तो अगर किसी ने IDSP का डेटा कभी देखना चाहे तो IDSP आप लिखिए गूगल में, so you will get to know that what exactly is the IDSP and IHIP platform. How many disease conditions, किस तरीके से रिपोर्टिंग होती है, आशा और ANMs कैसे रिपोर्ट करते हैं, डिस्ट्रिक्ट पब्लिक हेल्थ यूनिट्स कैसे रिपोर्ट करती हैं. So this is one of the biggest digital initiative, I think around 70 countries से advance ये IDSP है हमारा इंडिया का, और ये पूरा NCDC के द्वारा कंट्रोल किया जाता है. Okay, I'll take 5 minutes more.
Yeah, ma'am.
Second is AMR program, then climate, rabies, lepto, and viral hepatitis, and there are many programs. Snake bite is a recent addition. So this is Center for One Health, which has several technical divisions. We have one big program on National One Health program for prevention and control of zoonosis. There are many activities which are being undertaken under this program. This is the laboratory network which we have created under NOHP PCZ. So the target is 153, but as of now we have achieved 74 laboratories, and rest of the laboratories, they are in a phase-wise manner we are establishing, including the establishment of laboratory for undertaking augmented zoonotic disease surveillance at human-animal interface. So this is a list of pathogens, and then you can go on the NCDC website and wherein the detailing about these programs is available. One thing I would like to highlight that we are reaching out to the beneficiary with the helpline. Please ये आप helpline note कर लीजिए 15400. ये अभी 5 ही स्टेट में फंक्शनल है, बट लेकिन कोई भी डॉग बाइट विक्टिम हो इस पर कॉल करेगा तो उसको ये पता लग जाएगा कि उसको एंटी रेबीज वैक्सीन और एंटी रेबीज सीरम कहाँ से मिलेगा, और उसको एनिमल बाइट अगर हो जाता है तो उसको उस इवेंट में क्या करना है. सिमिलरली फॉर द स्नेक बाइट. इसी तरीके से कोविन और ईविन का एक डिजिटल प्लेटफॉर्म हम लोग क्रिएट कर रहे हैं बेनिफिशरी ट्रैकिंग के लिए, ताकि कोई डोज ना मिस करे, क्योंकि रेबीज 100% फेटल है. तो वी अंडरस्टैंड कि पूरे पाँचों के पाँचों डोजेज या 4 डोजेज जो भी इंट्राडर्मल और इंट्रामस्कुलर लेना है वो उसको कंप्लीट करना है. सो दिस इज़ द बेस्ट प्रैक्टिसेस. अभी एक विषाणु युद्ध अभ्यास हमने किया था, मॉक ड्रिल, कि अगर कोई H5N1 का केस सिनेरियो होता है तो उसमें हेल्थ सिस्टम कैसे रिस्पॉन्ड करेगा. तो ये नेशनल वन हेल्थ मिशन जो अभी आया है उसके अंडर हमने एक मॉक ड्रिल की थी अजमेर ज़िले में जा कर के, जहाँ पे हमने एक सिनेरियो सिमुलेशन एक्सरसाइज, हमने एक सीन क्रिएट किया एंड देन वी हैव एक्चुअली डिड ऑन फील्ड की कैसे रिस्पॉन्स होता है. इसी तरीके से बहुत सारे इनिशिएटिव्स वी आर अंडरटेकिंग, लीगल इंसाइट्स एंड ऑल. सो दीज आर द ऑपरेशनल गाइडलाइंस. जूनोसिस के ऊपर बहुत सारा रिसोर्स मटेरियल आपको एनसीडीसी की वेबसाइट पे मिल जाएगा. इसी तरीके से AMR, क्लाइमेट रिलेटेड हेल्थ, एंड मेनी ऑफ द इम्पॉर्टेंट public health related guidelines, these are available on NCDC websites, and these are all ministries guidelines. Capacity building is a routine practices. We keep on doing the hands-on trainings and joint multi-stakeholder workshops, multidisciplinary workshops, where is not only human health वाले आते हैं, लेकिन veterinary professionals equally हमारे साथ काम करते हैं. Veterinary, human health, wildlife professionals, and including पंचायती राज people and tribal people. So they all specialists, they sit together and jointly discuss the problems and how we can address them. So this is all communication material which you can get on the NCDC website. फील्ड एपिडेमियोलॉजी का एक ट्रेनिंग प्रोग्राम है हमारा इंडिया EIS प्रोग्राम इज़ एपिडेमियोलॉजिकल इंटेलिजेंस सर्विसेज. इसमें हम लोग ट्रेन करते हैं EIS ऑफिसर्स को कि आउटब्रेक को इन्वेस्टिगेट कैसे करना है और रिपोर्टिंग कैसे करनी है. इसी तरीके से फील्ड एपिडेमियोलॉजिकल ट्रेनिंग प्रोग्राम्स हैं. मास्टर ऑफ पब्लिक हेल्थ है फील्ड एपिडेमियोलॉजी में. देयर आर मेनी ट्रेनिंग प्रोग्राम्स विच आर बीइंग रन बाय NCDC. And Sector Connect, this is one of the beautiful program which we have recently undertaken, wherein we have a structured course for the joint outbreak investigation, joint risk assessment, risk communication for the One Health core domains, not only zoonosis but other activities as well. IDSP I have already done, and we are trying to create an IHIP API based integration with the other sectors. AMR का एक बहुत बड़ा प्रोग्राम है जो NCDC चलाता है और उसका आपको डिटेल NCDC पे मिल जाएगा. अगेन आई हैव स्पोकन अबाउट द एंटी माइक्रोबियल रेजिस्टेंस विच इज़ अ बिग कंसर्न फॉर आवर कंट्री. क्लाइमेट एंड ह्यूमन हेल्थ, अगेन वी आर नाउ फोकसिंग ऑन अ हीट रिलेटेड इवेंट्स एंड एयर पॉल्यूशन. But other than there are many other activities wherein we are trying to create green hospitals. That means the hospitals which is consuming less energy, less electricity, but all solar energy based, and based on a carbon footprint which could be minimized to the extent by adopting these climate resilient health infrastructure. These are the technical guidelines, SOPs, documents, but just 30 seconds more. So these are the challenges in implementing One Health, that we understand that priorities जितने भी sectors हैं, वेटनरी सेक्टर इज़ इकोनॉमी ड्रिवन सेक्टर. वेटनरी सेक्टर को अपने पशुपालन उद्योग का बहुत ख्याल होता है. तो दे आर नो मोर कंसर्न अबाउट जूनोसिस, तो उनको प्लेटफॉर्म पे लाना पड़ता है, साथ में सेंसिटाइज करना पड़ता है कि नहीं, जूनोसिस भी उतना ही इम्पॉर्टेंट है आपके लिए जितना ह्यूमन के लिए है। सो दिस इज़, क्योंकि सेक्टोरल प्रायोरिटीज़ डिफरेंट हैं तो थोड़ा चैलेंजिंग होता है, बिकॉज दे हैव देयर ओन मैंडेट। उनको पशुपालन, डेयरी उद्योग, मत्स्य पालन, इसमें उनका मैंडेट ये है, उनका प्रिंसिपल ये है। तो पशु का स्वास्थ्य उनके लिए उतना इम्पॉर्टेंट है, but from the economic perspective only, not from the zoonotic transmission perspective. But now the games are changing, now the things are changing gradually, and they are equally contributing in taking the One Health agenda forward. इसी तरीके से अभी तक लिमिटेड कोऑर्डिनेशन एफर्ट्स थे डिफरेंट सेक्टर्स में, बट नाउ द थिंग्स आर मूविंग बिकॉज वी हैव क्रिएटेड लॉट मेनी कमिटीज एट स्टेट एंड डिस्ट्रिक्ट लेवल एंड एट नेशनल लेवल। देन बायोडाइवर्सिटी चैलेंजेस इज ऑफ कोर्स, इसको हम कुछ नहीं कर सकते, डेवलपमेंट तो हमें करना ही है, सड़कें तो बनानी ही है, तो हमें कैसे करना है, तो उसके लिए हमें कुछ हमें मिटिगेशन एफर्ट्स लेने पड़ते हैं, लॉजिस्टिक्स की हमेशा कमी होती है। तो दीज आर फ्यू चैलेंजेस, बट पॉलिटिकल विल हमारे पास बहुत स्ट्रांग है। ग्लोबल लेवल पे G20 की प्रेसिडेंसी इंडिया ने होस्ट की, तो वहाँ पे हमारे ऑनरेबल प्रधानमंत्री ने क्या नारा दिया, वसुदेव कुटुंबकम, वन हेल्थ, वन फ्यूचर, वन अर्थ। तो ये एक नारा दिया गया था। सो वी हैव अ वेरी स्ट्रांग पॉलिटिकल विल एट एवरी लेवल। So this is one of the positive note for us, that we keep on going and keep on doing efforts by resource sharing and mobilizing of whatever resources we do have in our own hand. So this is how we think that when we tackle the well-being of human, animal and environment together, everybody wins. So One Health approach can protect the world in the upcoming days. Thank you very much, sir. And I'm sorry for taking...
No. You had not delayed it. In fact, we started 25 minutes late. So to stay back on time, I was doing it. Thank you, Dr. Simi. You have delivered a very important messages. खास तौर पे हमारे जो बच्चे बैठे हैं उनको एक चीज़ रियलाइज़ होनी चाहिए कि आप मेडिकल प्रोफेशन में हो, चाहे वेटनरी में हो या किसी भी टेक्निकल और एनवायरमेंटल साइंसेज में हो, हम सबको मिलके काम करना है, कोलैबोरेटिव करना है। अगर हमको ये धरा या ये धरती या ये आपका एक मुल्क अगर आपको सेफ रखना है, सस्टेन रखना है, क्योंकि वन हेल्थ मीन्स all environment, all animals, all you have to be in complete harmony, which our forefathers used to say it, and that's where the Vasudev Kutumbakam has come up. So we need to work into that. But nevertheless, ma'am, I just want to share very quickly, our institution is actually collaborating very closely with NCDC. We have a whole department of microbiology here, where we are having a national AMR program. They are doing it. Also with you, we have that scrub typhus and other zoonotic regional center doing it. And finally, we are thankful to NCDC and also Honorable Prime Minister of the country that Rohtak has been selected one of the places, this institution, for the BSL-3 lab. Our Honorable Vice Chancellor and Director both are sitting here. So we have done all the formalities and hope to see the BSL-3 lab in this institution in next 2 to 3 years. Thank you very much. Dr. Tiwari, please.
Thank you, Madam Sir, for such an excellent presentation. This concept of One Health among the young graduates, and you spoke very well, not only in the English but in the Hindi language also. So I am very sure that the students will take home this message and take care of not only as a medical but as the food chain, the environmental health, your animal health. Because if you talk of One Health, then only we all can survive. Thank you, madam, for such an excellent presentation. Thank you.
Thank you, ma'am. आपने इतने सरल शब्दों में सभी का ज्ञानवर्धन करा, and I hope the students learnt a lot. So may I now request our Honorable Vice Chancellor, Dr. H.K. Agarwal sir, and our worthy Director, Dr. S.K. Singhal sir, to please come on the stage to felicitate our esteemed speaker, Dr. Simmi Tiwari ma'am, by presenting a memento and a certificate to her. I request.
May I request our Honorable Vice Chancellor, Dr. H.K. Agarwal sir, and Dr. Suresh Singhal sir, our Director, to please felicitate our speaker. May I request our Chairperson to please join us. This is the third research conclave, and every year we are expanding under the able leadership of our Honorable Vice Chancellor, Dr. H.K. Agarwal sir, and Dr. Suresh Singhal. We are having a bigger spectrum of our speakers, and One Health, as already ma'am said, it has multi-pronged arms, multi-sectorial approach, and I believe so that this college is also going to excel in One Health streams, be it lab, be it zoonotic disease. And thank you so much, ma'am, for gracing this occasion and enlightening us with your speech. Big round of applause, ladies and gentlemen. And may I request our Honorable Vice Chancellor and Director, sir, to please felicitate our chairperson for this session with a sapling. Thank you. Thank you so much, sir. Thank you so much, sir. I thank our Honorable Vice Chancellor, sir, and Director, sir. Thank you. Now we proceed to our inaugural session in a while.
इसको बंद कर दे या खुला रहेगा आप एंगेज करो ऑडियंस को विच इन गिव 5 minutes.
We would soon begin with the inaugural ceremony. Kindly give us 5-10 minutes.
With more 760 registration and around 272 poster presentation, I must tell you that third research conclave of University of Health Sciences is already a hit, and all the sessions are already parallelly going in Hall A, Hall B, and the poster session first round has already been completed, which is being done on more than 10 plasma projectors, plasma screens across the reception area. The research is the heart of any university, and none other less our university, which is also working leaps and bounds to make the research the core principle of our institutions, all the constituent institutions. We are thankful that all the directors of many affiliated colleges have also spared their valuable time to grace this occasion. Thank you so much, sir. And all the eminent faculty who has been here to support this research-driven conclave. start with our formal event, I'll take this opportunity to welcome Dr. Mandeep, who is Registrar from Haryana Medical Council and has come directly from Chandigarh to join us. And you will be glad to know that we have been awarded 4 credit hours for this conclave. A big round of applause. Thank you so much, sir, for always so supportive and giving us credit hours as and when we require. Thank you.
To be seated. One and all. Respected teachers, esteemed dignitaries, revered guests, delegates, residents, eminent faculties, friends and colleagues. On behalf of the organizing committee, I, Dr. Urmil Chawla and Dr. Manjunath BC, your host for the day, have the proud privilege to welcome you all to the inauguration of 3rd University Research Conclave 2025 of Pandit B.D. Sharma University Health Sciences, Rohtak.
This 3rd University Research Conclave not only provides a platform to identify and explore multidisciplinary research problems, but at the same time, it also encourages the researchers to be passionate about their scientific work and bring out quality research output and showcase them to this august audience.
Ladies and gentlemen, I once again extend a very warm and heartfelt welcome to all the esteemed members. With immense pleasure, we would like to begin the inaugural ceremony, and we would begin by inviting the dignitaries on the dais.
We extend a warm welcome to our Honorable Vice Chancellor, Professor H.K. Agarwal sir, to please come on the dais. This program is conducted based on his vision that our university should be a great center of medical research, and deliberation will encourage each one of us to conduct high throughput research for the benefit of mankind. Ladies and gentlemen, please welcome a big round of applause, give a big round of applause to our Honorable Vice Chancellor, Professor H.K. Agarwal. So Dr. Varun, please escort sir.
Now we would extend a warm welcome and heartfelt gratitude to our Honorable Director, Dr. Suresh Singhal sir, and request him to kindly come on the dais. He's a great administrator and is also heading the Department of Anesthesia, an anesthesiologist par excellence. Next.
Now I invite Dr. Dhruv Chaudhary, Senior Professor in HOD, Pulmonary and Critical Care Medicine, Dean Academic Affairs, and he's also Dean Research and Development Cell of this university on the dais, please. Sir is a great clinician, good human being, and researcher par excellence. Under his able leadership and guidance, medical research has flourished in our university and has grown leaps and bounds. Ladies and gentlemen, give a big round of applause to Dr. Dhruv Chaudhary, sir.
Now I invite on stage Dr. Kuldeep Singh Lalar, Dean PGIMS Rohtak. Sir is an excellent cardiologist and a very good teacher. He has played a significant role in establishing the cardiology department in PGIMS Rohtak. Please give a big round of applause, ladies and gentlemen, for Dr. Kuldeep Singh Lalar.
So we also extend a warm welcome to Dr. Mandeep, who is a registrar of Haryana Medical Council. He has been deputed as an observer by Haryana Medical Council, sir. So warm welcome, sir. Now we invite Dr. Sanjay Tiwari, Principal PGIDS on the stage. Sir is an excellent researcher, able administrator, a great clinician, and moreover a good human being. Under his leadership, PGIDS has transformed as a jewel in the crown of our university. He is my mentor who stands rock solid in all our endeavors. So I'm able to perform here, it's because of his constant support. Ladies and gentlemen, give a big round of applause to Dr. Sanjay Tiwari, Principal of Postgraduate Institute of Dental Sciences, Rohtak.
Now we extend a warm welcome to our chief guest of the day, Dr. Naveen Kumar, Director, National Institute of Virology, Pune. He has taken out time from his busy schedule, and we thank you, sir, for gracing the occasion as chief guest. Sir is a distinguished virologist, having made significant contributions in understanding virus-host interactions. He is a recipient of numerous awards and has also acted as advisor to both WHO and WOH on various infectious diseases. We extend a warm welcome and a big round of applause for our chief guest, Dr. Naveen Kumar.
We'd also like to invite on the dais our dynamic medical superintendent, Dr. Kundan Mittal, sir. Sir keeps working tirelessly for the improvement of the hospital and is a pillar of strength. He has undertaken numerous initiatives in increasing the quality of healthcare services at PGIMS. Ladies and gentlemen, give a big round of applause to Dr. Kundan Mittal, our medical superintendent.
Last but not the least, I invite the heart and soul of this third University Research Conclave, who has pitched her best foot forward to make this event a grand success. It is none other than Dr. Pushpa Dahiya, chairperson of this third University Research Conclave. Ladies and gentlemen, please give a big round of applause for Dr. Pushpa Dahiya. We welcome you on the stage, ma'am. Thank you to all the distinguished dignitaries on the dais to be part of the inaugural ceremony. So, ladies and gentlemen, let us begin today's program on a positive note with the University Kulgeet. May I request everyone to kindly rise to show your respect to the Kulgeet.
Om Trambakam Yajamahe Sugandhim Pushtivardhanam Urvarukamiva bandhana Mrityurukshiyamamrita. In the name of humanity, we will be always with humility. In the name of Hippocrates, our knowledge and honesty will never be separated. But best of knowledge, we will serve, we will devote this we all pledge, this we all pledge. सुश्रुत ऋषि के शल्य ज्ञान का देखो कैसा है वरदान। उस ज्ञान की हमने दीक्षा ली, जग का हुआ योग निदान।
चिकित्सकुल के हम प्रहरी मानव सेवा ही परम धर्म है।
भारत भूमो व्याधि मुक्त रोगी की सेवा अपना कर्म है। राष्ट्र सेवा को रहे समर्पित, अपने जीवन का सार ही हो। पाँव में रहे सांसों की डोरी, चिकित्सक का संस्कार ही हो।
भारत को दे हम स्वस्थ नागरिक, तन मन कर चरणों में अर्पित।
स्वर्ग धन्वंतरि के वरद पुत्र, हम जीवन कर पूर्ण समर्पित। परंपरा और तकनीकों का समावेश हम सब में है।
विश्व जानता अपना कौशल गुण विशेष हम सब में है।
सेवा की शिक्षा करे कुल का हम वंदन।
नत्वहं कामये राज्यं न स्वर्गं न पुनर्भवम्। कामये दुःखतप्तानां प्राणिनामार्तिनाशनम्।
Thank you very much. Now it's time to extend a warm welcome to all our dignitaries on the dais with a sapling as a token of appreciation for attending this program amidst their busy schedule and encouraging all of us and making this program a grand success. We may now request our Honorable Vice Chancellor, Professor Dr. H.K. Agarwal, to please welcome our chief guest of this third research conclave, Dr. Naveen Kumar, Director, National Institute of Virology, Pune, with a sapling. आगे जाओ, आगे जाओ.
May I now request Dr. Pushpa Dayal ma'am to please welcome our Vice Chancellor, Dr. H.K. Agarwal sir, who is the Chief Architect of this research conclave, with a sapling.
Now I request Dr. Pushpa Dayal Madam to please welcome our Director, Dr. Suresh Kumar Singhal, with a sapling.
Be quick, be quick, be quick.
We would next like to welcome our Dean Academic Affairs and Dean Research and Development Cell, Dr. Dhruv Chaudhary, with a sapling. Dr. Pushpa Dayal ma'am, please.
Now I request Dr. Pushpa Dayal Madam to please welcome our Dean PJMS, Dr. Kuldeep Singh Lalad, with a sapling. Madam.
Next, we would like to welcome Dr. Sanjay Tiwari, Principal PGIDS, and may I request ma'am to kindly honor him with a sapling.
Now it's time to welcome our Medical Superintendent, Dr. Kundan Mittal. I request Pushpa Madam to please welcome with a sapling.
And we would like to welcome our guest, Dr. Mandeep Sachdeva, Registrar, Haryana Medical Council, Panchkula, also with a sapling. Dr. Pushpa Dayal ma'am, please.
Last but not the least, we extend a warm welcome and heartfelt regards to our chairperson, Dr. Pushpa Dayal, who has toiled day and night to make this third research conclave a grand success. I request Dr. Dhruv Chaudhary, Dean Academic Affairs and Dean Research and Development Cell, University, to do the honors with a sapling. Thank you very much, madam.
A big round of applause, ladies and gentlemen.
Ladies and gentlemen, give a big round of applause to Dr. Pushpa Dayal, chairperson of this third research conclave. Today, the theme of our research conclave is Oral Health, One Health, a new paradigm in human health. In an increasingly interconnected world, the health of humans, animals, and environment is deeply intertwined. The One Health approach recognizes this interdependence and seeks to integrate efforts across multiple disciplines to improve global health outcomes. This holistic perspective is gaining traction as a crucial paradigm in addressing emerging infectious diseases, antimicrobial resistance, food security, and climate change.
By fostering collaboration among healthcare professionals, veterinarians, ecologists, and policymakers, One Health aims to develop sustainable solutions for pressing health challenges. The One Health approach is a transformative model that acknowledges the interconnectedness of human, animal, and environmental health. By embracing this paradigm, societies can better predict, prevent, and respond to global health threats, ultimately ensuring a healthier future for all. Today, our eminent speakers are going to enlighten us on the various aspects of One Health, and we all are looking forward to hear from them. So proceeding further, we would like to begin this third research conclave, remembering the Almighty and going ahead with the lamp lighting.
In our Indian culture, light symbolizes brightness and prosperity. It dispels darkness and gives us positivity. Similarly, knowledge dispels ignorance and empowers us. So, to seek the choicest blessings of Goddess of Knowledge, let's invoke Ma Saraswati. We'll now have the lamp lighting ceremony. I invite the students from UHSR to recite the Saraswati Vandana. We would like to invite all the dignitaries to please proceed for the lamp lighting ceremony. Thank you very much, all the dignitaries.
Ladies and gentlemen, there is a saying that a true leader is one who knows the way, shows the way, and goes the way. We have a true personification of these lines in our Honorable Vice Chancellor of our university, Professor H.K. Agarwal sir, the driving force behind today's program. May I now invite sir to come on the dais to deliver the welcome address.
Good morning to all of you. Dr. Naveen Kumar, Director, National Institute of Virology, Pune, our chief guest and keynote speaker for today's scientific program. My esteemed colleagues, Dr. S.K. Singhal, Director, PGIMS, Dr. Dhruv Chaudhary, Dean Academic Affairs and Senior Professor in Charge Research Cell, Dr. K.S. Lalad, Dean PGIMS, Dr. Kundan Mittal, Medical Superintendent, Dr. Sanjay Tiwari, Principal, Postgraduate Institute of Dental Sciences, our dynamic organizing chairperson, Dr. Pushpa Daya, Dr. Mandeep Sachdeva, Registrar, Haryana Medical Council, and observer for today's scientific deliberations, directors and deans of our affiliated colleges and distinguished guests, faculty colleagues, delegates, and my dear students. It is my great honor and privilege to welcome you all to this third research conclave being held consecutively at the campus of Pandit B.D. Sharma University of Health Sciences, Rohtak, with the theme, One Health, a New Paradigm in Human Health. And we are fortunate to have Dr. Naveen Kumar, Director, National Institute of Virology, as our chief guest, and keynote speakers, Dr. Simi Tiwari, Joint Director and Head of Center for One Health, National Center for Disease Control, New Delhi, Dr. Abdul Ghafoor, Consultant in Infectious Diseases and Clinical Microbiology, Apollo Hospital, Chennai, and Dr. Shankar Prinja, Professor, School of Public Health, Postgraduate Institute of Medical Education and Research, Chandigarh, to share their expertise with all of us. I am truly privileged to have such an outstanding group of experts, scholars, and innovators with us today. I am delighted to host all of you at Pandit B.D. Sharma University of Health Sciences, Rohtak, Haryana. I am also delighted to have among us Dr. Virender Sangwan, our alumni, presently Director, Innovations and Translational Research, Dr. Shroff Charity Eye Hospital, New Delhi. He has brought laurels to our institute by way of his nationally and internationally acclaimed research in the field of ophthalmology. He is a highly decorated scientist and ophthalmologist. This year's conclave aims to foster collaboration, exchange ideas, and especially focuses on One Health initiatives in India and internationally, a topic of growing importance and relevance in the present era. The goal of this conclave is to provide a platform for researchers to share their work, engage in meaningful discussions, and forge collaborations. The research conclave is not just about presentations and papers, but also building a vibrant community of thinkers and doers. Whether you are here to present your research, learn from others, or network with the like-minded individuals, I hope that today's deliberations will ignite new ideas, collaborations, and opportunities. On this platform, I am delighted to say that we have more than 760 registered delegates, 240 poster presentations, 32 oral presentations, and 25 young faculty research papers. Almost the scientific content is equal to almost a national conference. From this platform, I wish to announce that faculty intramural research grant, which was being given to the constituent colleges of the university, from next year on, we wish to extend its benefit to all our affiliated colleges and institutions as well. We are also planning to grade this faculty intramural research grant, and the first 3 positions shall be awarded in coming times. Further, we are going to start full-fledged PhD program in next 4 to 6 weeks' time. I look forward to the fruitful discussions and collaborations that will unfold throughout the day with scientific deliberations. At last, I would like to express my sincere gratitude to our Dean Academic Affairs and Professor in Charge Research, Professor Dhruv Chaudhary, and our dynamic organizing chairperson, Dr. Pushpa Daya, our anchoring team led by Dr. Manjunath, Dr. Urmil Chawla, Dr. Varun Arora, Dr. Harneet, and Dr. Preeti Galot for their hard work and dedication in making this research conclave a reality in a short span of time. Further, I wish to acknowledge the hard work put in by all chairpersons and members of our various committees constituted for this purpose. My thanks to our engineering wing and account department, and welcome and thanks to press and media personnel present here. Once again, I welcome you all to this third research conclave, and let us make this moment a memorable, inspiring, and transformative experience. Thank you all. Jai Hind.
Thank you, sir. The warmth with which you have welcomed is quite visible. And thank you for your earnest efforts to promote medical research in our university. We are truly blessed to have you as our Vice Chancellor.
Now, I request all the dignitaries to kindly please be seated. We'll be having our inaugural address by Dr. Naveen Kumar.
We thank all the dignitaries for inaugurating this event, and may I now request them to kindly be seated in the front seats of the auditorium.
I request our chairperson for the inaugural address, our Honorable Vice Chancellor, Professor H.K. Agarwal, and our Medical Superintendent, Professor Kundan Mittal, to please stay back to conduct the inaugural session. We thank all the dignitaries for inaugurating the third research conclave. Now let us begin the session with our chairperson will introduce the chief guests to the August gathering.
Good morning. I welcome Dr. Naveen Kumar, Director, National Institute of Virology, Pune. Dr. Naveen Kumar was born in Rajasthan, and he earned his BBSc and AH and MBSc degrees from the College of Veterinary Sciences, Bikaner. In 2006, he completed his PhD at the Veterinary College, Hisar, and the Friedrich-Loeffler Institute in Riemens, Germany, under the DAD Sandwich PhD program. He has pursued postdoctoral research at the School of Medicine, Emory University, Atlanta, USA, from 2006 to 2011. In 2017, he was a visiting fellow at Edinburgh Memorial School, University of Edinburgh, UK. A distinguished virologist, Dr. Kumar has made significant contributions to understanding virus-host interactions. His research has identified several key cellular kinases and epigenetic modifiers as viral host dependency factors. Dr. Kumar was first to isolate the lumpy skin disease in India and developed world's first DIVA marker vaccine for LSD, which has been commercialized via at least 4 major vaccine manufacturers in India. He is recipient of several awards and honors and a well-decorated scientist. He has acted as a technical advisor to both WHO and WAH on various infectious diseases. With these few words, I welcome Dr. Naveen Kumar for his keynote address.
Should I start? Okay, Honorable Vice Chancellor of this university, Dr. Agarwal, Dr. Suresh Singh, Director, Dr. Dhruv Chaudhary, Dean Academic Affairs, Dr. Kuldeep Singh Lallar, Dean PGIS MS, Dr. Sanjay Tiwari, Principal, Dr. Mandeep, Registrar, my senior colleague Dr. Simi Tiwari, Dr. Adul Gaffar came from Chennai, Dr. Puspa Daiya, head of the departments of this university and college, also the faculty from the MDU, all the students, ladies and gentlemen. Good morning to all of you. I want to thanks to the university administration, particularly Dr. Dhruv Chaudhary, who has invited me to share the One Health initiative undertaken by the Government of India that are under several programs that are under implementing phase. So I am just going to share these various programs that is coordinated by the ICMR. So, as has already been introduced, I am at National Institute of Virology, Pune. So, this institute was established in 1952 in Pune as a virus research center in the beginning. Now we have physical presence at 8 different places, 2 campuses in Pune and 6 campuses in different parts of country, way back from Jammu to Bangalore and then northeast Dibrugarh, then Pune, Jabalpur, Mumbai, Bangalore and Kerala. So the NIV is the apex institute under the ICMR, and we are collaborating extensively with various international agencies. Almost all the virus related international program that is run by WHO, we are part of that program. That includes the WHO National Influenza Center, WHO Collaborating Center for Measles, Rubella, WHO Collaborating Center for Polio, and we are the only poliovirus essential facility because now polio has been eradicated but is still under surveillance. So no other than the Pune lab is allowed to culture the polio. So this is very highly secure lab that is located at the Pune, at our institute. We are also part of the CEPI. So I'm in the letter presentation, I'm also going to come up with the zonal NIV issues. So although this is the broad topic of One Health, so being a director of the Virology Institute, I am going to be virus centric. So because most of the programs, that involves the epidemics, all these viruses. So when the first meeting of the International Committee of Taxonomy of Viruses, that took place in 1971. So at that time we have 2 viral families and about 300 viruses. And now in 2025, now we have more than 15,000 viruses and more than 300 viral families. So if you look at the progress of the virus identification or the emergence of the new viruses, so from 1971 to 2002, In 2002, we have about 1,500 viruses, but in next 20 years, so it increased 10 times that increase in the from 1971 to 2002. So that means new virus or their antigenic variants are being reported almost on the daily basis. Although all these viruses, they are not that harmful, but definitely the viruses they are responsible for that leads to several devastating pandemics across the human history. So this is not the end. So we are going to face new virus epidemics for sure. And as of now, there is no method by which we can prevent them. So we have to prepare ourselves. We cannot 100% prevent the emergence of new viruses. So the major factors that are responsible for the emergence of the pandemics are the globalization, because of the movement of the human and also the animal products, global warming and deforestation. So deforestation that allows increased animal to human contacts. And global warming is going to be one of the leading cause of the emergence of the novel pathogens. Because now, due to the melting glaciers, the viruses which were otherwise locked for many, many years under the ice. So due to melting ice, the viruses are going to come in contact with the animal or human population, and we may face new pandemics. So as of now, we have the vaccines against few of them. So, and we are under others, we are trying to develop the vaccines. Regarding antivirals, as of now, there is this area we have not been so much successful. We got some success in the field of the antivirus with hepatitis, but still, we don't have any specific antiviral that provides 100% protection, efficacy. So, since the beginning of this 21st century, we have seen that at least more than 10 different viruses, which we have never seen in our country. So, these viruses, they have emerged. So, this includes the Nipah virus in 2001, CCHF, Crimean Congo hemorrhagic fever virus in 11, West Nile virus, Zika virus, although Zika virus was reported several years back in 70s, 80s, but based on the antibodies. Now we have we have isolated the virus, and now last year there are a lot of cases of Zika virus were reported, and we all know that the SARS-CoV-2 they produce pandemics. We also got the monkeypox outbreak in 2022, 3 years ago, and we also got some cases in 24 as well, and several variants of the avian flu. So the latest one that is circulating is 2.3.4.4b that was detected in the cattle in US, and then also some few human cases, and then it actually across the globe it was reported. And at NIV we also got isolation of this recently circulating strain from the Kerala poultry outbreak. So the viral infections that pose a major threat to public health in India, we all know that it's the dengue, chikungunya, and now the Zika is equally. Last year there are large number of Zika cases in our country. Influenza, some of the viruses, they are somewhat neglected, that is the enteric infections and hepatitis viruses. So there are two diseases that maybe that has never been seen in North India, and that are particularly important, they are restricted to the somewhere central part of our country, but the virus is extending its geographical locations. They are moving from the south to north, and we may face the outbreaks of these two new virus, that is Chandipura virus and Casanur forest disease virus. So these two diseases, Chandipura and KFD, so they are only prevalent, these virus in India. They have never been reported outside India. And the KFD was initially it was restricted to Casanur forest in Karnataka. Now it's expanding, and it has reached almost across the Maharashtra and maybe then Gujarat, and we may also see the cases of the Chandipura in future. And so is the case of the KFD. So this geographical expansion is due to several factors. As I told you that the globalization, increased deforestation, and increased animal to human contacts. So there are so many viruses, so many antigenic variants, and most of these viruses, they involve the insect vector and the animal reservoir. So if you want to control that the disease or the virus in humans, so it's not possible. So we have to control the environment, we have to control the animal reservoir, and also look to the vector population as well. So that's why this place where we are conducting this research conclave, this exclusively dedicated for human health. But if you want to be healthy, so you have to take care of the milk and meat as well. So that means we have to take care of the animal health as well. So major part of the food for the animal and humans is coming from the plants. So if we, animal and human, they want to be healthy, so we have to take care of the plants as well. The plants should be healthy. And if all the three together, they want to be healthy, then we have, our environment should also be healthy. So the One Health includes actually this all four major components. So I'm not going to go much detail. 3-4 diseases that are major highlight last year. I just want to, in a single slide, I want to tell you what's going on in there. So the Chandipura virus, it was way back detected in 1965 in India, in Maharashtra. And now, as I told you, it's expanding its geographical locations. So there was a major outbreak in 2003-04 where more than 300 children, they died. And last year in 2024, we have seen another major outbreak where more than 30 children, they died. So the virus is believed to be transmitted by sandflies. But now extensive research work that is carried out by NIV and also other agencies, including NCDCs. So it appears that there are some other players as well. Because we don't know, the virus comes in outbreak form after each 15-20 years. So where the virus is, when there is no outbreak, where is the virus? We don't know. Whether there is animal reservoir, whether there is another mode of transmission. If you want to do serology, there 70-80% of adults, they are showing the antibodies. So these are the virus, the Chandipura, is already reached up to the Gujarat. And we may see in future in Haryana as well. KFD, as I told you, was restricted to Karnataka, and now you can see that it's extending. So this again involves, this transmitted by ticks, monkey, and cycle. So the monkeys that are in the forests, so they are infected by tick bites. And the livestock that is going to the forest is, by the ticks, they are carrying the infection, and then to human. So this is also a serious disease. At present, is restricted to the Western Ghats, but we may see in future in North India as well. So the H5N1, as I told you, it make a major headlines exactly at the same time last year, because it was first time shown to be infect the cattle. Cattle otherwise is considered to be resistant to the H5N1. But there are a lot of dairy farms that were infected in US. And most importantly, it was observed that the virus is excreted heavily in milk. So then later studies, they shown that the receptors that is used by the influenza virus, that is the alpha 26 type in human and alpha 23 types in poultry. So the cattle mammary gland has both type of receptors. So then, because it's heavily excreted in milks, then it's a severe public health consequences. And now in recent few weeks or few months, we have seen that the H5N1 was detected in the tigers in Maharashtra, Nagpur, and also in cats. So initially, virus that was that never shown to infect the cattle, and now frequently infecting the mammalian species. So that human is at risk. So currently, as Dr. Simmi told that the Europe and US, they have a stockpile of the H5N1 vaccine. So the ICMR has already started developing a vaccine. So we have already invited expression of interest at the ICMR website, and our Director General is very serious about it to have a vaccine as soon as possible. We have already actually isolated this virus, adapted it into the cell culture, and optimized inactivation, and in the process of looking at the immunogenicity in laboratory animals. And so very soon we are going to transfer the technology to the industry. So India would have a vaccine shortly for H5N1. So Nipah virus is restricted only to the Kerala, initially in Bengal, but now in Kerala. So we are getting one or two, a few cases almost each year. So the disease is very fatal. We don't have vaccine. So right now only option is the monoclonals. So we got the monoclonals from the Australia. But now the ICMR has developed its own monoclonals. They are under the validation phase, and after certain regulatory approvals, so India would have its own monoclonals against Nipah virus. CCHF again is a problem. This is restricted to Gujarat, and some few cases have also shown in the bordering stage. So it again involves the ticks and the livestock in this transmission cycle. So ICMR, in collaboration with the other DBT organizations, we are trying to develop the monoclonals and the vaccines for CCHF. Monkeypox, we first got first case in 2022. So there are two clades of monkeypox. One clade 2 is widely distributed across the globe. So initially we are having only clade 2, but in this last year, August, we have seen that the clade 1 is also there in India. So clade 1 is supposed to be highly pathogenic, where we see more than 10-15% mortality, whereas the clade 2 is relatively less pathogenic. Mortality rate is less than 1%. So NIV, in collaboration with the Serum Institute of India, we are trying to develop the vaccine for monkeypox as well. I'm not going to discuss much about dengue, chikungunya and Zika virus, but just one thing I want to highlight here is that there were a lot of media coverage last year that the chikungunya virus has changed. So we are getting a sample across the country, and we performed the whole genome sequence of the chikungunya virus. So this virus is very much similar to what is being reported over the years. So there is no much change. However, what we have seen that we got almost 5-6% more cases positive for chikungunya, and similarly the less number of cases in dengue. So this, at this moment, we don't understand, because it involves a lot of factors that includes the climate change and the mosquito biology and the dynamics of the virus replication. But it's true that last year in 2024, more number of dengue, chikungunya as compared to dengue cases were reported. So Zika, we got a lot of Zika positive cases last year. So that in Zika there are two genotypes, Asian and African lineage. So Zika virus is supposed to induce, produce defects in the newborns. So the African lineage is actually responsible for that. So at this moment, for fortunate part for us is that the virus which is circulating in India is of Asian lineage. That has never been shown to be associated with the defects in newborns. So now this was a background, what is going on in our country in terms of these viruses that are of they are highly infectious. They are emerging and re-emerging. So the COVID-19 actually has reshaped entirely, our approach of addressing the pandemics. So India initially, maybe if you go back 10, 15 years ago, so we were blamed that whatever we are doing, our approach is reactive, it's not proactive. But COVID-19 has taught us a lesson that yes, our approach is also now the proactive. So I am going to show you why our approach has been changed from reactive to proactive. So I am going to show you the programs or the investment by Government of India and our ICMR leadership to tackle the pandemics and the other healthcare issues in our country. So when there was a COVID-19 pandemic, so whenever there is any virus-related issues, actually this comes to Pune at NIV, because NIV is the only BSL-4 lab in our country. So during the initial phase of the pandemic, our lab was, under severe pressure. So we have to optimize the tests, we have to validate them, then we have to send these reagents to various laboratories, train them. So we have overwhelming pressure from all across all the sectors. So at that time it was decided by our policymakers that we must have more labs like NIV Pune. So then after several thoughts and involvement of more than 13 ministries, so it was a national One Health mission was set up in 2022. I think Dr. Simmi has already mentioned about the One Health issues, what it is. I am not going to go in much detail. So I just want to tell you what is National One Health Mission, what are the activities that is being undertaken under the National One Health Mission. So, so there is under National One Health Mission, parallel there is a program called PM Abhim, Pradhan Mantri Ayushman Bharat Health Infrastructure Mission. So it's a multi-crore rupees project. So that would allow us to prepare ourselves for the future pandemics. So under this, so the whole idea is to prepare our country for the pandemics. And if you want to prepare ourselves for the pandemic, then as Dr. Simi has already told that all the sectors, all the veterinary sectors, human, environment, all these different departments, they have to come together and collaborate with each other to tackle the pandemics. So, one important activity is that there should be integrated disease surveillance. It means that if there is an outbreak, so maybe 5 years, 10 years ago, if there is an outbreak, so only if it's outbreak in poultry, so only the Bhopal lab is going and attending the outbreak. But now, under the National One Health Mission, there is integrated disease surveillance. That includes the human, livestock and wildlife. So, for example, Few weeks ago, you know that the H5N1 outbreak was reported in lions. So the samples were sent to log and scientists, they are going there to attend the outbreak. So now this again, you know, is possible only because of the National One Health Mission. And now our approach and the data, kind of data that is being generated, they are much more robust and we can make much more meaningful inferences out of this outbreak investigation. So now the data that is being generated out of this outbreak response, that are very much important. Because if you want to make any policy decision, then you need data. So now the data is being very carefully recorded and is being deposited. At ICMR level, now we have a repository, a data repository. So I want to give you an example, you know, why the data are important. So last year when there was this H5N1 outbreak was in US, so I got a call from somebody at the DAHD that should we issue an advisory because the virus was excreted in milk heavily. So he said that should we issue an advisory to ban the raw milk in our country? So I said that at this moment I don't think we should take a decision because at this moment only few human cases are there in US, although the virus is shown to be excreted in milk, but only at that time 2 or 3 human they were found to be infected with H5N1 that were in contact with the cattle. Second thing is that at present we don't have this disease in our country. So if you want to make a decision, policy decision of such kind of policy decision, that you need data. So I said that first we need to do the surveillance. Go to animal population, do surveillance, extensive surveillance in cattle. If there is an evidence, then we can think. So the data for policy decision are very much essential. Even then, we have to think about taking such a huge, big decision. So data management is very much essential. That was a very poor part, but now under the National One Health Mission, so under several programs, the data are being very carefully managed at the respective stakeholders. So now the viruses which I mentioned here, whether it's Nipah, CCHF, SARS-CoV-2, monkeypox, all of these viruses, they are of high-risk pathogen. So you can't handle these viruses in a BSL-2 lab. So you need to have at least BSL-3 lab. So in our country, the first BSL-3 or BSL-4 lab was established by the Veterinary Institute in Bhopal. Initially, it has a status of BSL-4, but now due to changing guidelines, it's BSL-3. But at this moment in our country, there are, I believe, more than 150 BSL-3 labs are there. So, under National One Health Mission, it was decided that we must have a network of BSL-3 lab, functional, which we can engage at the time of the emergencies, such as those the pandemic, COVID-19 pandemic. So, under this National One Health Mission, so that is being coordinated at the PSA level, and that's being implemented by the ICMR and NIV. So we made a network of BSL-3 lab. So under National One Health Mission, there is agreement that whosoever the lab that are part of this network, they do not need to take any permission, because one of the major problem in our country is that if you want to work that, you don't have permission to work for such virus. If somebody is working on human virus, why you are the human scientist, why you are working on the veterinary virus, and vice versa. But under this, the guidelines of this National One Health Mission, the network of this BSL-3 lab, they do not need to take any permission. So whenever there is emergency, even if you are working on animal virus, if there is emergency of human pathogen, they have to test. So at NIV, we conducted at least 3-4 different trainings, and we are providing them the validated reagents. And 2 of the labs, BSL-3 labs of Haryana, one in Hisar, National Research Center on Equines, and one in the Faridabad, THSTI. They are part of this national network of BSL-3 labs. So now, besides the NIV Pune, we have at least 22 labs that they are having validated reagents. We are engaged in their capacity building and providing them the validated reagents. So this is how we are preparing ourselves for the future pandemic. Then sometimes, there is an outbreak which is in remote areas. So it's very difficult to bring the samples from there, and every day, reaching all the samples to Pune or other part of the network BSL-3 lab, it's very difficult. So the NIV and ICMR, we have actually designed 2 BSL-3 labs. So these mobile BSL-3 labs. So these mobile BSL-3 labs, they are functional, So if you have some outbreaks that are potentially, there is involvement of a high-risk group pathogen, so we can engage these labs in remote areas. For example, 2 months ago, there was some cases in Rajouri, in Jammu and Kashmir. So our ICMR headquarters actually deploy these BSL-3 labs there immediately. So this bus that is having a BSL-3 lab, this is equipped with all sort of reagents to test the samples at the sites where is, there is a problem. So then there is, as I told you, as a part of the National One Health Mission, there is a provision of National Institute of One Health. So the foundation stone has already been laid down. So the building is under construction, but we already started the activities in Nagpur. So besides the National Institute of One Health, so National Institute of One Health is going to be multi-ministries involved there. So it's part of not only the ICMR, it's part of the DBT, CSIR, DAHD, Ministry of Environment, Forest. So the National Institute of One Health is multi-ministerial institute. So once it's functional, then we would be much easier, in tackling some the pandemics like those, we have seen 5 years ago. So besides the National Institute of One Health, there are 4 zonal NIVs. So main NIV, as I told you, is in Pune, headquarters is in Pune. But now, under the National One Health Mission, it was decided that we must have more zonal NIVs like in Pune. So as per the different zones of the country, so in North Zone, the zonal NIV is being established in Jammu. In Northeast is in Dibrugarh. In central part of our country is in Jabalpur. And in southern part of the country is in Bangalore. So the construction work has already started, and few of them we would able to actually inaugurate by in 2025 as well. Although the construction work is going on, but research activities already been started. So we have posted few of the scientists and technical staff, although they are working in a rented building. But once we have these zonal NIVs functional, that would be much easier for us, So we can immediately, tackle these outbreaks at a local level rather than sending the samples to Pune that takes 2-3 days. So the zonal NIVs, we have already started doing collaborations, developing research proposals, doing capacity building. So, for example, this Haryana is in the North Zone. So North Zone zonal NIV is being established in Jammu. So in March, this month only, we had some zonal workshop. I don't know whether somebody, I believe not. We didn't get any proposals from the Haryana, but we got the proposals from the Punjab, Jammu and Kashmir. So, first thing what we did under the zonal NIVs is that we have prioritized the diseases. Because if you want to prepare yourself, then first you have to prioritize the diseases. Which diseases are of priority? So the diseases were prioritized based on the involvement of multiple stakeholders from the medical side, veterinary side. And then after prioritization of 10 diseases, then the next phase, what we are doing now is we are trying to identify the hotspot areas. And at the meantime, we are making MOUs and doing collaborations. So I just joined exactly a year ago at NIV, and I have signed more than 35 MOUs at local level with medical colleges, research institute, whether it's from medical or from veterinary. And this year, after signing the MOUs, what we are doing is that we are developing research proposals. So out of 4 zonal NIV workshops, we have now got about 25 research proposals. So that after a few rounds of revisions, that we will submit it to the ICMR headquarters for funding. So this is how at zonal NIVs they are helping, at the local level. So you can see that there are 4 zonal NIVs, and this is how we have the collaborations what we have made. This across the country. So these are the diseases that has been prioritized in different zone, central zone, east zone, south zone and north zone. So most of the diseases, they are common across different zones, but some of the zones, the priority is different. For example, the KFD and the Chandipura is not a priority on north and the northeast or the central part of the country. So based on these priorities, disease that has been prioritized, we are developing their hotspot areas and also identified the list of diseases that are limited occurrence and chance of importation. So now one of the more important, network that is already existing. That's before, even before the establishment of or the coming that National One Health Mission. It is the Virus Research Diagnostic Laboratory Network.
Sir, we will appreciate if you finish in 3 minutes.
Yes, just this last 2-3 slides. So this is a network of more than 165 labs across the country. So NIV is engaged in their capacity building, provide them the validated reagents, and this network helped us in a very great way. This was activated during pandemic. So these were the first lab that we actually trained them and for testing the COVID-19 samples. So this also includes the 3 of the labs. Into PGI is also part of this medical college where we are sitting. This is also part of this VRDL network. And beside that, 2 other labs, one in Sonipat and Karnal, are part of that. So you can see that NIV is, interconnected almost across the country with the various medical organizations, that is medical college or research institutes. So regarding the medical countermeasures, as I told you, we have the vaccines. Against few of them, we are trying to develop the vaccines that are in preclinical development is KFD, Chandipura, H5N1, monkeypox, chikungunya and CCHF. The dengue and Zika virus, they are under clinical trials. And you know that India is having world-class infrastructure for developing the vaccines. More than 70% of the vaccine being used globally is produced by our country. Diagnostics has not been a major problem because of the advancement of the sequencing tools. Like PPE medical devices, this is doable. We did a very good job during the COVID-19 pandemics. Antivirals, as I told you, is a problematic. We have to shift our approach because most of the drugs that we are using is virus-centric, repeated use of which, allows the generation of the drug-resistant viral mutants, and we have to look for the host-directed antiviral agents. Some very highly pathogenic viruses such as Nipah, we are also trying to develop the monoclonals. So besides this, the ICMR has launched other specific program where the new virus will come. So one way of importation of the new virus is by the birds, that are coming from these migratory birds coming from Siberia or other part of the world during winter time. So the people who are in contact with the bird, people engaged with the bird sanctuaries who are in contact with these birds, they get the new virus. Likewise, the new interface is the slaughterhouse. People who are working in the slaughterhouse, they may get the virus, from the animals at the animal-human interface, and likewise Jew as well. So this is also a network. There are a lot of bird sanctuaries, slaughterhouse and Jew we are connected with. We are extensively collecting the samples and monitoring the people who are in contact with at these interfaces, and also examining the virus, whether there is mutation and emergence of the new viruses. Yes, okay. So I have already been alerted twice, so I'm going to close my talk. Just 2 lines. So we are going to face the pandemics for sure. We don't have any way to 100% prevent the pandemics. Only way what we can do is we can better prepare ourselves. So under this National One Health Mission, there are various programs. I told you how ICMR is connecting the various departments together to better tackle the pandemics. Thank you very much.
Thank you, sir, bringing the challenges of virus illnesses in India and globe. I hope you are preparing for the SOPs for meet these challenges also in future. Thank you.
Thank you very much, sir, for your valuable insight, which has definitely been an eye-opener for all of us. You have emphasized the importance of One Health, where all the sectors can integrate and come together for making this a better world. Thank you, sir. Now, I request our chairperson, Professor H.K. Agarwal and Dr. Kundan Mittal, to please felicitate our chief guest, Dr. Naveen Kumar, with a token of appreciation. I request our chairperson to please come forward. Ladies and gentlemen, please give a big round of applause. He embodies One Health. So COVID-19 has taught us how integration with various sectors is essential. Thank you very much, sir. Now it's time to felicitate our chairpersons. I request.
Sir, please, I request the chairperson to take the seat. Now it's time to acknowledge one of our alumnus who has brought so many international laurels to this, I would say, alma mater. Ladies and gentlemen, I'll take this opportunity to please welcome Dr. Virender S. Sangwan, who is currently Director, Innovation and Translational Research at Dr. Shroff Charity Eye Hospital. Formerly, he has been Adjunct Professor, Department of Ophthalmology and Visual Sciences at Ohio University School of Medicine, and Adjunct Associate Professor of Ophthalmology at School of Medicine and Dentistry, University of Rochester Medical Center, USA. He has been awarded with various awards. To name a few, Dr. Shanti Swaroop Bhatnagar Award for excellent work in stem cell transplantation in 2006, and National Technology Award, as you can see, with none other but ex-President one of the most favorite president of India, our only beloved Abdul Kalam ji. And just now, a book has been published as a biography, Unbound. I would say, sir, you are unbound, untamed, unchallenged, and your work is kind of an inspiration for all of us. The award list is bigger than our publication list. You can see, to name, I would say it will be kind कि सूरज को जिस तरह से आप आईना दिखाते हैं. So many awards, so many appreciation, and I would say a small video will do the justice that what kind of work has been done by Dr. Virendra Sangwan. Can we play the video, please? Video, please. It's always kind of a homecoming when we see those people who have been the alma mater of this institution, this college, and those who have brought laurels. कोई भी अगर यहाँ का स्टूडेंट या यहाँ की फैकल्टी कहीं अवार्ड जीतती है तो ऐसा लगता है कि हमने वो अवार्ड जीता है. इट्स काइंड ऑफ एन अवार्ड जस्ट शेयर्ड बाय द फैमिली. जैसे जब बच्चा घर पे कोई अवार्ड लेकर आता है तो पूरे परिवार के सदस्य कहते हैं कि अवार्ड मेरा है. सर, ये अवार्ड आपके नहीं, हमारे भी है सर. थैंक यू सो मच फॉर शेयरिंग विद अस to spark the ignite and passion in all of the students. Please.
Well, it started in 1995. I had chemicals in my eyes, so I had chemical trauma. I decided to go to Rotterdam and I tried to some drops, but I could not really do something for me. So I decided to look for an alternative.
That alternative happened to be stem cell transplantation for eyes with limbal stem cell deficiency. It uses a laboratory-based technology that was developed and refined by research scientists at the L.V. Prasad Eye Institute in India in the year 2009. The team worked along with Dr. Virendra Sangwan, a surgeon who has since performed the procedure called cultivated limbal epithelial transplantation in over 800 patients. Abhishek Sharma, a young married gentleman with 2 daughters, is a beneficiary.
That Dr. Sangwan is really God for me. He make me able to see, and I can see, and I can read, I can drive my bike and come back to my normal life.
However, difficulties arose with the new procedure being expensive and offering access limited only to those patients who couldn't reach the tertiary care center. These difficulties were recently overcome by Dr. Sangwan's innovative and significantly cheaper procedure called Simple Limbal Epithelial Transplantation, or SLET, that uses limbal stem cells from the patient's healthy eye. The laboratory is neatly sidestepped as the nutrition for the stem cells to grow is offered by the patient's own tear film.
I heard about this about 6 months ago. Limbal stem cell transplantation is a major focus of my practice back in North America, in Canada, and Toronto. And I became aware of this new technology, this new technique that Dr. Sangwan has really invented. The benefits of this technique is it allows you to basically bypass the laboratory. There's no question that this has international impact. This is a simplified limbal epithelial transplant technique. And as such, I think that countries around the world will be adopting this technology. I know I will be when I go back to Canada. And I really think that this offers cornea surgeons across the world a new way of doing limbal corneal transplantation.
May I request Dr. Sangwan to please come on the stage, and may I request our Honorable Vice Chancellor Dr. H.K. Agrawal sir, and our medical superintendent, dynamic medical superintendent, Dr. Kundan Mittal, to please felicitate Dr. Sangwan with a memento. May I request Dr. Dhruv Chaudhary to please join. Sir, truly your work has been a proud moment and rather an inspiring one for all the students.
I think we need to give a standing ovation to Dr. Virendra Sangwan. He has done what none of us have been able to do it. And Shanti Swarup Bhatnagar Award is actually Indian Nobel Prize for the researchers. I think it's a sense of pride. Dr. Virendra, thank you so much.
Thank you so much, sir. Thank you. Thank you so much, sir. Now, may I request our worthy director, sir, and our dean, sir, Dr. K.S. Lalat, sir, Dr. Singhal, sir, to please come on the stage to felicitate our chairperson for this talk. जितनी तालियां आपने अभी बजाई, उनसे ज़्यादा तालियां मैं चाहूँगा आप बजाएं हमारे ऑनरेबल वाइस चांसलर सर के लिए, जिनकी वजह से आज ये इवेंट सक्सेसफुल हो पाया, और डॉक्टर पुष्पा दहिया मैडम जो सूत्रधार रही. प्लीज़ आप भी मैम स्टेज पर आएँ. It has been a wonderful experience of having third research conclave, and I believe so that it is just the beginning. We just started. We are learning day by day. Big round of applause for our Honorable Vice Chancellor, Dr. H.K. Agrawal, sir. Our Director, sir, is also here. Thank you so much. May I have another sampling? टोकन चिराग स्टूडियो से अनुरोध है, एक बार ये टोकन की फोटो जरूर लें. सर एक फोटो. Unbound, unleashed, unparalleled energy with a, I would say, subtle tinge of humility and down-to-earth personality. Thank you so much.
Thank you, ma'am.
So moving forward, next topic is very, very important for all the undergraduates and postgraduates. It is about antimicrobial resistance, and one of the pioneer in this is going to present this talk. So please be attentive, because this is the need of the hour. Unjudicial use of antibiotics is causing a menace in this country.
A very good afternoon, everybody. Since we are running short of time, and also one of the guest speaker for today's function, Dr. Abdul Ghafoor, he has a flight to catch in the evening, so we are just preponing the event. So all the faculty are requested to have a short tea break. Meanwhile, we'll be continuing with the proceedings. Good afternoon, respected doctors, experts in the field, and students. It is both a privilege and a necessity to gather here today to discuss one of the most pressing public health challenges of our time, that is antimicrobial resistance. As a frontline healthcare providers, we are not just observers but active participants in this unfolding crisis. AMR is not a distant threat, it is already altering the way we treat infections, perform surgeries, and manage critically ill patients. Additionally, antimicrobial resistance has a serious economic consequences, leading to higher healthcare costs, prolonged hospitalization, and reduced productivity.
The 2022 Global Antimicrobial Resistance and Use Surveillance System GLASS report provides alarming statistics, indicating a growing difficulty in managing even the most common infections. Moreover, India has been referred as the AMR capital of the world, with rising rates of multi-drug resistant organisms, posing significant diagnostic and therapeutic challenges. To guide us through this critical discussion, we have with us today a highly esteemed expert in the field of AMR. As we listen to our esteemed speaker, I encourage all of you to reflect on the role we play in shaping AMR interventions, whether it is through rational prescribing, infection control, policy advocacy, or research. The battle against AMR is not just about finding new drugs, it's about preserving the ones we already have.
Without further ado, let's now invite our chairperson, Dr. S.K. Singhal, our director, Pandit B.D. Sharma University of Pandit B.D. Sharma PJMS, Rohtak on the dais. He is already sitting. Now we invite Dr. M.G. Vashish, Senior Professor and Head Department of General Surgery, to please come on the dais to start the proceedings of the keynote address. Ladies and gentlemen, please give a big round of applause to our chairpersons. So now, I request our chairperson to please introduce the distinguished speaker for the august audience.
So for this keynote address, we have Dr. Abdul Ghaffar. He is MD MRCP, FRCP Pathology. Presently, he is working as Senior Consultant, Infectious Diseases, Apollo Hospital, Chennai. So he has been kind enough to spare his time to come to this city. And he is also coordinator of Chennai Declaration on the Antimicrobial Resistance. Also, he is managing trustee of AMR Declaration Trust, managing partner of Quorum of Veda Consulting Services. He is also active in the academy and policy perspective of AMR. Widely published, his work has been published in Lancet, British Medical Journal, and other international journals. He is also jury member and got a lot of prizes on this topic. So his keynote address, he would be addressing us is innovation is the solution to the complex challenges in the AMR. So we would be benefited because this is the global challenge, particularly in India, because we have a lot of prescriptions by so-called over-the-counter, and say we don't have any antibiotics to hardship in our country. I request Dr. Abdul Ghaffar to kindly go ahead with his presentation. In the coming year, even at the national level, antimicrobial resistance is being taken seriously, because so fast the resistance is developing to the existing antimicrobials, and it takes time for a new agent to get into clinical practice. As we know that, judging by the talk of previous speakers, we are now getting genetic mutation and so much flora and the change of bacteria are coming in the society with interaction of animals, interaction of birds, and also by international traveling, we are getting exposed to the things which were not previously there in our country. Facilitate.
I'm Dr. Ghaffar. I'm an infectious disease physician. I work at Apollo Hospital, Chennai, especially in the cancer institute. Most of my patients are cancer patients, and cancer patients are the most immunocompromised and most vulnerable patients for severe infections. That's why I got involved in the problem of antimicrobial resistance, because I'm forced to get involved. I've seen patients die without antibiotics. I treated patients with infections where not even a single antibiotic is working. My job is also to prevent and control infections in the hospitals, in the community. I work as an advisor to various countries and government organizations. Recently I published a book called Outbreak Chronicles, The Untold Stories of Real Life Outbreaks. I wrote it as a novel. Why? Because I can't disclose the name of the people and because many of the individuals can't name. So I wrote it as fiction with heroes and heroines. What I just did was basically selling my book. I was selling my book. Why did I do that? I'm an infectious disease physician. Why am I selling something? It's because of the need for entrepreneurship. Again, writing a book, no, it's not entrepreneurship. But trying to sell that is entrepreneurship. And why should doctors be entrepreneurs? We doctors need to be entrepreneurs. And why did I have this attitude change? It's something new. I got this concept a year or two ago. Until that time I was a pure clinician, academician, researcher, policy maker. I had this perspective change because of my involvement in antimicrobial resistance issues. I can confidently say that I spent half of my life for the antimicrobial resistance issue. In 2012, who was part of it on behalf of Intensive Care Society, we prepared a document called as the Chennai Declaration. That is an initiative by all the medical societies in India with the participation of governmental and non-governmental organizations. It's because Indian government published a national antibiotic policy 2011. Then we thought the stakeholders, the real stakeholders, the doctors should support that initiative from the ground. And that we created Chennai Declaration. I was the coordinator of the Chennai Declaration. And after that, we have been regularly communicating with the Union Health Ministry. There was a time in 2012, 13, 14, every month I used to visit Health Ministry. I don't take appointment. I just go and meet the secretary to inform the joint secretary, Dr. Dafur from Chennai has come. Okay, send him out. I meet the joint secretary, I meet the additional secretary, I meet the health secretary, and the health ministry is available somewhere, I meet it. That was a time. Not just me, there was so many other people who worked the similar way, organizations worked the similar way, government organizations like ICMR, NCDC, all of them worked the similar way. Do the collective efforts of government organizations, NGOs, individual societies, we made a big change in the country. We will not claim that national antibiotic policy is implemented on the ground. No, it's still too early, even after years of policy making, because nobody's fault. Our country is too big, too complex, too many languages, too many political parties, too many governments. Implementing a national policy in a country like India is very difficult. Then we had 2015, the UN, the WHO declaration, 2016, the UN declaration, 2017, we formulated the national action plan and we asked the states to implement. Very few states have initiated implementation. Again, not anybody's fault, it's because of the complexity of our country. Nobody's fault. But what I learned from my involvement, there was a time again, I'm a private practitioner. Still I used to spend at least 1 week out of my hospital or out of country working on the policy level. But after years I learned something. Policy making in Delhi is one thing, it's difficult, very difficult. Implementing on the ground is another thing. And quite incidentally, in 2014 when I was busy with Chennai Declaration and government policy work, I was invited as a jury member by the British government for the Longitude Prize. That was in 2014. Longitude Prize is a £10 million prize for an innovation that can transform the field of AMR. And we identified it as a rapid point of care diagnostic test that is transformative, innovative, and can give the doctors an answer. Within half an hour, we can know which bug is causing infection and which antibiotic is effective. And we started 2014. I was happy that I was jury and advisory member. But I don't think it really that significant. We are busy with policy making. We are busy with implementation. Innovation is important. But then the 5-year Longitude Prize became 10 years because we couldn't identify a real winner for the prize. the same time, I was slowly getting disappointed by the slowness of implementation. Nobody's fault, the complexity. And then realized, yes, you make policies, but implementation is not easy because you need to understand the perspective of the stakeholders. We all blame doctors for irrational antibiotic usage. We are not to blame. I wrote an article in JAPI 2010, an obituary on the death of antibiotics. And I blamed the Indian medical community, including myself, on the irrational antibiotic usage. And I wrote that Indian medical community should be ashamed of the antibiotic resistance. And I was wrong. I was terribly and horribly wrong in my understanding. That was not my understanding. That was understanding of the scientific community at that time. Then we realized we doctors are not the main reason for antimicrobial resistance. 70% of the antibiotic usage is in animals for a growth promotional purpose. And you know which antibiotic they're using most popular? Cholesterol. The holy water in medicine is cholesterol antibiotic, the most powerful. That's used as a growth promoter. And then in 2018 we did a study. We analyzed the fresh poultry samples, vegetable samples from the country, and we found half of them are cholesterol-resistant bacteria because of extensive usage in the poultry. We convinced the government, and government banned that in 2019. That is one policy that has made the most impact in the AMR field in the country. The reason is 85% of the cholesterol used in the poultry in the country is imported from China. And China has banned it in 2016 and still exporting to various countries, and we were importing. So this particular rule literally stopped that ban. No importers have the courage to import a banned product and get the import license cancelled. They are business people, they need the import license. Because of that, a policy change alone, without working on the ground, it helped. And you know the impact it made? Until 2019, the cholesterol resistance in Indian hospitals was, or in other countries also, was increasing. There was a time I used to see a cholesterol resistant bug in patients, 2 to 3 patients a week. Today, not just in my hospital across the country, it's difficult to see cholesterol resistance. Microbiologists, how often do you see cholesterol resistance today? Rare. Uncommon. I would say rare. I see 1 to 2 months, 3 months. I used to see 2 or 3 a week. That's because of the cholesterol ban in the poultry. We did work, we did research, identify the genes responsible, how it transmits from poultry to human. That's one policy work. But again, what we need is innovation. It's easy to say doctors should not use antibiotics. It's not our fault. We see 100 patients a day. What is the time? And we need rapid diagnostic to help us. And during that 10-year longitude journey, we analyzed 250 applications from startups and companies across the world. Amazing work. The way people think, the people innovate is amazing. And that made my perspective change. It's not just policy making. We need to provide solutions. It is not enough. Policy making is not enough. We need to find solutions on the ground. And today, I rarely attend AMR meetings. There was a time I was half my life into AMR. Still I work in the field of AMR. But not policy making. Policy making is important. Surveillance is important. What is much more important is innovation. We need, hand hygiene. We know how important is hand hygiene. It's difficult to implement. We need new technology for educating people on the importance of hand hygiene. So what I do, I support startups, Indian startups who work on AI tools which help the doctors to improve the hand hygiene compliance, to help the doctors and the hospitals monitor the hand hygiene compliance. Similarly, we need innovation in infection control. In animals, yes, ban antibiotic usage as a growth promoter. It will not happen. What is going to happen? Other antibiotics is not happening. Because we need to provide alternative technology, innovation to farmers, to doctors, to veterinarians, to agriculture. Everything where there is a component of AMR, we need innovation. Not just AMR. Take any healthcare problem, any problem anywhere in the world, any global warming or poverty or anything, water shortage. What we need is innovation. And who is doing innovation in the medical field? Engineers, not doctors. Clinical, your students. It's my message to students. We people are old. You are young. You have got a young mind. And we need that perspective change among youngsters. Who is doing innovation? Not doctors. Biotechnology, engineers, IT professionals, not doctors. Who's taking patients? Us. We know about the problems the medical community faces than anybody else. Why are we not innovating? We are doing, yes, medical practice is a wonderful job, noble job. Teaching is a wonderful job. Research is a wonderful job. Not enough. We need to be innovators, technology, ideas. We need to provide solutions. That's our job, not just that of engineers. So what we need to do, from medical students onward, doctors should come forward and become innovative entrepreneurs. Starting a hospital is no innovative entrepreneurship. Starting a new clinic is no innovative entrepreneurship. That is called as conventional entrepreneurship. Selling, writing a book and selling it is no innovative entrepreneurship. That is conventional entrepreneurship. Innovative entrepreneurship, that innovate new technology, idea. That's called innovative entrepreneurship. What doctors need to do, form startups. Register small companies, collaborate with biotechnology, collaborate with AI experts, develop AI tools to find solutions for your specialty. It should be your company. So what? Yes, in private, easy for me. Last year, I registered a consulting firm for Umbrella. It's not to make money. Yes, it's a private company. I helped a lot of medical technology startups. I'm helping them to develop technology. You know what I'm doing? I'm registering, I'm the process of registering my own biotechnology startup. Is it to make money? Not really, but it's a for-profit organization. Why am I doing it? I'm a full-time practitioner. I do my clinical work from 7:30 in the morning till 6 p.m. in the afternoon. I did all my work, I did all my policy work after that. I'm doing my entrepreneurial work after that. Full-time doctors can do it. It's private, it's easier. We have got the freedom to do that. We need that kind of freedom for the government employees. IIT is doing it. IIT professors have the right to become spin-off. They're doing wonderful job. IIT Chennai, IIT Delhi, all others. They got spin-off. We need that kind of policy change, even for government doctors, employees, to have spin-off, to work there, have their startups to innovate. And our country needs innovation. And our country needs innovative entrepreneurship as a part of Make in India campaign. Make in India campaign is helping a lot to help Indian companies, Indian startups to develop technology. And that's the way our country can progress. So, as doctors, as medical students, in fact I'm writing to NMC, I'm communicating with the NMC senior members. We need to make innovative entrepreneurship a part of curriculum for MBBS, for postgraduate. We should have even an MD or DM in innovative entrepreneurship, where you should have a startup with your friends. Your startup may fail. After 5 years, your startup may fail. Doesn't matter. It's a big lesson. There's a lesson, life lesson. It's not the success that matters in entrepreneurship. It's the lessons that you learn. And you will be the right person to lead an innovation center. You will be the right person to manage a hospital, along with the clinical practice. We need innovative centers, incubating centers. IITs have that. Delhi IIT has got, most of IITs have incubating centers. We need innovative centers, incubating centers, every medical school, every university. And encourage students to be a part of it. Register companies, innovate, and be entrepreneurs. That's what our country needs. Thank you.
Dr. Ghafoor has tried to give the insight of what innovations are required or what is Make in India campaign to do that. He has tried to sensitize the youngsters for taking the task ahead. So definitely we would become wiser. We will also make a task force in our institute. Maybe Dr. Dhruv will take the lead for putting up some SOPs for AMR. So thank you very much, Dr. Ghafoor, for coming to our place and enlightening us on this topic. Thank you very much.
Thank you very much, sir. On the behalf of everyone present here, I
Thank you,
sincerely...
Dr. Ghafoor.
Sir, कुछ बोल रहे थे sir? Sorry to interrupt.
I was just thanking Dr. Ghafoor.
Yeah.
Thank you for the nice presentation.
Yeah, thank you very much, sir. So I sincerely thank Dr. Abdul Ghafoor for delivering such an insightful and engaging presentation on antimicrobial resistance. Your expertise and valuable insights have deepened our understanding of this critical public health challenge. We truly appreciate your time, effort, and dedication in sharing your knowledge with us today. Thank you once again for your valuable contribution to the research conclave. Now, I request our chairpersons, Dr. S.K. Singhal and Dr. M.J. Vashish, to felicitate our keynote address speaker, Dr. Abdul Ghafoor. Dr. Abdul Ghafoor, please come on the dais. Ladies and gentlemen, please give a big round of applause. He has highlighted how important the antimicrobial resistance is. It's very, very essential to adopt antibiotic stewardship. Whenever you prescribe antibiotic, please be careful. Prescribe only when it is necessary. Thank you very much, sir. So now I request Dr. Dhruv, sir. Boliye, sir.
I think that one of the messages, if irrespective whether you're a medical student, you are a dental student, you are from the pharmacy, physiotherapy, important part is that we need to innovate. And I can give you a very small story. Dr. Singhal is here. During COVID, people had come to us for the diagnosis of lung cancer before that. And we converted that app in terms of diagnostics as far as making a clinical decision-making tool for COVID. And you will be surprised that we did it in more than 600 patients. And we have presented that data. We were able to pick up from home nearly 26 people who had a severe COVID without putting a load on it. So it's that sort of a thing which is required. What is important for us in the medical curriculum, both are there, and along with other colleagues, think lateral, observe, and that's where the innovation progress is there. Conventional research is fine, but it's a lateral thinking which will lead to think you out of box, which will lead, and that is what is the message, if you want me, from this place there. And I hope my dear colleague and our Honorable Director and Dr. Madan Gopal both will agree with that, and that's the way forward for all of us. And thank you so much, sir, for giving your time to us. And I hand it over back to Dr. Manjunath, so as to continue. Yeah.
So now it's time to felicitate our chairpersons for their valuable contribution in this deliberation. So I request Dr. Dhruv Chaudhary, Dean Academic Affairs and Dean Research and Developmental Cell, and also request Dr. Pushpa Daya Madam to please come on the dais for the felicitation of our wonderful chairpersons for this important topic on antimicrobial resistance. Please give a big round of applause, ladies and gentlemen. It's a very, very important topic. Our chairpersons have given their valuable time. Take a wonderful picture. Thank you very much, sir. So we come to the end of this keynote address. And since because of the paucity of time, we'll move forward with the Young Faculty Research Awards. And to continue the proceedings, I would like to invite Dr. Preeti Gehlot and Dr. Umesh Yadav on the dais, please. Dr. Umesh and Dr. Preeti, please continue the proceedings.
Good morning once again. A very warm welcome to the Young Faculty Award session. It's time to felicitate young faculty members of various departments of the constituent and affiliated colleges of University Health Sciences, Rohtak. Today, we gather to celebrate the dedication and innovative research contribution of our young faculty members.
नमस्कार। आज का ये अवसर हमारे इन युवा संकाय सदस्यों के अनुसंधान में किए गए सराहनीय कार्यों को सम्मानित करने का है। इन शोध पत्रों का चयन एक विशेष वैज्ञानिक समिति द्वारा किया गया है, जिसमें शोध की नवीनता, प्रासंगिकता और व्यवहारिक उपयोगिता को ध्यान में रखते हुए मूल्यांकन किया है। जैसा कि हमारे माननीय प्रधानमंत्री जी ने भी कहा कि जय जवान, जय किसान, जय विज्ञान, और उसी में जोड़ा जो चौथा जय अनुसंधान, तो उसी अनुसंधान की भावना को सम्मानित करते हुए जो हमारे जवान युवा फैकल्टी मेंबर्स हैं उनको सम्मानित करने के लिए शुरू किए गए इस यंग फैकल्टी रिसर्चर्स अवार्ड में आप सभी का हार्दिक स्वागत है।
For the felicitation of this deserving young faculty members, may I please invite on stage Dr. Naveen Kumar, Director NIV Pune. Sir, please come on the stage. Sir, we need you to felicitate our young researchers. Dr. Simmi Tiwari ma'am, in charge Division of One Health, NCDC New Delhi, ma'am, kindly come on the stage. Dr. Abdul Ghafoor, Consultant Infectious Disease, Apollo Hospital, Chennai. Our worthy director, sir, Dr. S.K. Singhal.
Sir.
Sir, please come on the stage to kindly present the certificates and awards to the deserving young researchers of our University Health Sciences, Rohtak.
अवार्डों की श्रृंखला की शुरुआत करते हैं। कृपया आप सभी से अनुरोध है कि तालियां बजाकर इन सभी फैकल्टी मेंबर्स का अभिनंदन जरूर करें। डॉक्टर भावना वर्मा फ्रॉम कॉलेज ऑफ फिजियोथेरेपी, PGMS, Rohtak. She published the growing scope of tele-rehabilitation in spinal cord injury, a feasibility trial published in Indian Journal of Natural Sciences from College of Physiotherapy. सर, फ्रंट रो से तालियों की आवाज़ आ रही है, कृपया पीछे रो वाले भी तालियों से अभिनंदन कर।
पढ़ दिया टॉपिक्स है क्या क्या है उसके बारे में बताना पढ़ दिया ताकि इसे सर आने। मैम आप दोबारा फ़ोन कर दो, मैं आपको बोला सर शुरू हो गया है। May I call upon Dr. Charu Agarwal, Associate Professor, Pathology, ESI, Faridabad. She is not here. Her representative, her student will come on the stage. She has done a research work on prognostic role of tumor infiltrating lymphocytes, tumor budding, tumor border configuration, and tumor stroma ratio in colorectal carcinoma, which has been published in Index Journal of Surgical Oncology, Indian Journal of Surgical Oncology. So all these research articles had particular criteria which was given to the faculty members, and there was a special jury who has selected all these research articles, and one of the criteria was of course to be published in a indexed journal. That has been followed.
So next we have Dr. Dimple Chaudhary from College of Physiotherapy, PGMS, Rohtak. She published therapeutic putty-based hand strengthening exercises to improve hand function and quality of life in patients with chronic rheumatoid arthritis. Published in a reputed national journal. Please, a huge round of applause. कृपया तालियों में थोड़ा सा जोश लगाएं। अपने अपने गुरुजनों को तालियों के साथ हौसला अफजाई करें।
Next, I invite on stage Dr. Deepti Sidam, Department of Pathology, ESI Medical College and Hospital, Faridabad. Madam is not here. Her representative student is coming on stage to take the certificate on her behalf. She has conducted a study on diagnostic accuracy and utility of Bethesda system for reporting thyroid cytopathology 2017 in an Indian scenario, a tertiary care appraisal. This study was published in a national indexed journal.
Dr. Deepti Sidam from Department of Pathology. Next we have Dr. Jitendra Wadhwani from Department of Orthopedics, PGMS, Rohtak.
He published a prospective randomized study for comparison of modified proximal femoral plate with dynamic hip screw system. The original article published in a reputed PubMed Index journal. A well-deserved award. Please जोरदार तालियां. जस्ट इसके बाद लंच सेशन है, so please तालियों में कमी ना रहे.
Now I call upon Dr. Jyoti Deswal, Regional Institute of Ophthalmology, PGIMS Rohtak. I request Dr. Jyoti Deswal to kindly come on stage, or any of her representative if somebody is around. She has conducted a study on awareness and attitude towards eye donation among first-year postgraduate students in Medical College in Haryana, which was published in National Indexed Journal. Dr. Jyoti is not here, so we'll move on to the next candidate.
Next we have Dr. Manish Thal from College of Pharmacy, University of Health Sciences, Rohtak. He published the preparation and evaluation of Meloxicam chewable tablets for better oral delivery in a National Index Journal. You can contact the faculty members if you feel any need or any guidance regarding the same topics. Dr. Manish Thal from College of Pharmacy, University of Health Sciences, Rohtak.
Now I call upon Dr. Mohammad Mukarram Ali, Pediatric Surgery, PGIMS Rohtak. He has conducted a study on analysis of clinical characteristics and comparison of survival of inborn versus outborn cases of esophageal atresia with tracheoesophageal fistula. This study was published in International Index Journal. Please appreciate Dr. Ali with some applause for him.
In the last research conclave, we had 12 entries from the faculty, and this time the number has gone up to 30 plus. So it's a huge achievement for the faculty members also. Next we have Dr. Monica from Department of Anesthesiology, PGIMS Rohtak. A perioperative analgesic management in patients with bladder exostrophy. A clinical study published in Asian Journal of Medical Sciences, a national indexed journal.
May I now call upon stage Dr. Pradeep Kumar from Anesthesiology Department, PGIMS Rohtak. He has conducted a study on comparison of
We request our worthy Vice Chancellor Dr. H.K. Agarwal sir to kindly join us on stage.
And I request all the audience to please welcome our Honorable Vice Chancellor Sir Dr. H.K. Agarwal sir on stage. Sir, thank you for your kind presence. Dr. Pradeep Kumar. He has conducted a study on comparison of optimal doses of prophylactic dexmedetomidine for preventing post-operative shivering in patients undergoing elective laparoscopic cholecystectomies. This was published in a National Index Journal.
Next we have Dr. Priyanka Gupta from Department of Pediatrics, ESIC Medical College and Hospital, Faridabad. We request one of their students to kindly come on the stage. Learning agreements for teaching communication skills to postgraduate students in pediatrics. Dr. Priyanka could not join us, so from the ESIC faculty, some students have joined us. The message to all the medical colleges across the state.
May I now invite Dr. Renuka Verma, Department of Pathology, Pandit B.D. Sharma, PGIMS Rohtak. She has conducted a study on diagnostic utility of bone marrow aspiration, trophine biopsy, and flow cytometry in the evaluation of various hematological and non-hematological disorders, a cross-sectional study from the northern India, which was published in a National Index Journal.
Next we have Dr. Ruchi Singhal. Dr. Ruchi from Department of Perodontics, PGIDS Rohtak, published a paper on treatment outcomes of lip taping in patients with non-syndromic cleft lip and palate a systemic review and a meta-analysis. An international PubMed index journal.
May I now call upon Dr. Shikha Madan from Department of Obs and Gynae, PGMS Rohtak. She has conducted a study on nurturing new beginnings, a quality improvement journey to enhance early breastfeeding initiation rates, which was published in National Index Journal.
Next we have Dr. Shilpi Moore from Department of Pathology, again from ESIC Medical College and Hospital, Faridabad. Again the students will be joining to take the award on their behalf on the fully automated gene expert BCR ABL1 assay versus standard non-automated BCR ABL1 real-time reverse transcription polymerase chain reaction quantitation, a study from Tertiary Center Institute in India.
Next, may I call upon Dr. Smriti Anand, Department of Obstetrics and Gynecology, PGMS Rohtak. I request Dr. Shikha Madan to please collect her certificate on her behalf. She's conducted a study, a quality improvement journey to enhance early breastfeeding initiation rates, which was published in International Index Journal. May I now call upon Dr. Surendra Kumar, Pediatrics Department, MAMC, Agroha, Hisar. He has conducted a study titled Impact of an Educational Measure on the Quality of Medical Certificate of Cause of Death at a Tertiary Care Teaching Hospital, a pre-post interventional study, which was published in an international PubMed Index journal. Now I call upon stage Dr. Umesh Yadav from Department of Orthopedics, PGMS Rohtak, my co-host. He has conducted a study titled Failed Osteosynthesis of Humerus Shaft Fracture, our experience of 12 cases with refixation and bone graft. This was published in an international index journal. May I now call upon Dr. Vandana Arora from Department of Anesthesiology, PGMS Rohtak. She conducted a study on effects of normal saline versus isotonic balanced crystalloid on acid-base balance and renal functions in patients undergoing intracranial tumor resection surgeries.
Dr. Vandana Rani from Obs Gynae Department, PGMS, published a title paper, Clinical Profile of Respiratory Distress in Obstetric Admissions to Intensive Care Unit at a Tertiary Care Center in Northern India, a National Index Journal.
May I now call upon Dr. Vasudha Govil from Department of Anesthesiology, PGMS Rohtak. She's conducted a study titled Influence of Different Head and Neck Positions on Oropharyngeal Leak Pressure with the LMA Protector Airway, a crossover study. This was published in a national indexed journal.
And now it's time for the medals and the winners of the session. So for third position, we have first winner Dr. Deepti Anand from Department of Periodontics, PGIDS Rohtak. She bagged a joint third prize on topic effect of scaling on serum high sensitivity C-reactive protein levels and periodontal parameters in systemically healthy women of reproductive age group with gingivitis. I think only the researchers themselves are clapping for themselves, so कृपया बाकी लोग भी उनके लिए एक बार तालियां बजाएं. A medal, a certificate, a reward, accomplishment, achievement.
Now may I call upon the second joint third place winner, Dr. Aparna Singh, Department of Pathology, ESI Medical College, Faridabad. She's not here. I request her student representative to please collect her certificate and medal on her behalf. She conducted a study titled International Academy of Cytology Yokohama System for Reporting Breast Cytology and the ACR Breast Imaging Reporting and Data System, BIRADS, Are They Concordant? This was published in an international PubMed Index journal.
Congratulations to the winners. The second prize goes to Dr. Amrish Bhagol from Department of Oral and Maxillofacial Surgery, again from PGIDS Rohtak. A comparative evaluation of conventional versus dynamic elastic therapy for close treatment of unilateral mandibular subcondylar fracture, a randomized controls trial. Published in Indian PubMed Index Journal with an impact factor of 0.8 to 1. A achievement for the whole of the university as well as PGIDS. A great task achieved by Dr. Amrish Bhagol. Congratulations, sir.
Now it's time for the first award winner. I invite Dr. Neeti Mittal from Department of Pharmacology, PGIMS Rohtak. She conducted a study titled Longitudinal Trends in Inpatient Antibiotic Consumption according to the WHO axis, Watch, Reserve, that is aware antibiotic groups and cost, and analysis of data at a National Antimicrobial Consumption Network, NACS-NET site in North India over 7 years from 2017 to 23. This was published in an international PubMed Index journal. No wonder she's done a great job and a very well-deserving first prize.
So just one, Dr. Jyoti Deswal, a faculty from I.
She's joined us.
She just arrived, so we'll request just spare 2 minutes. Dr. Jyoti Deswal, she published on the awareness and attitude towards eye donation among first-year postgraduate students in a medical college in Haryana, in a PubMed National Index Journal. So congratulations to all the young faculty and young faculty award winners. Thank you.
I thank all our dignitaries on the dais for sparing their valuable time and for honoring all our young researchers. I hope this will take a message for all of them to be encouraged and further involve themselves in more research and academic activities. Thank you. Thank you, chairpersons. I request everyone to kindly proceed for lunch break, and then we meet again for more interesting sessions, oral paper presentations, and so on. The lunch will be served in the basement on the outside. Thank you.
Good afternoon, everyone. So we are going to start with session 5, the post-lunch session, oral presentation session for in today's research conclave. We have speakers, 8 speakers. I request all the speakers to stay focused to the time. Time allotted is 5 minutes. 2 minutes are for question and answer session. Please don't go beyond your time. This will affect your marking and ultimately will affect your ranking.
So with this, we are going to start with our oral session, and may I request the chairperson for this session. First of all, I'd like to invite Dr. J.C. Pasi, who is currently Dean, cum Principal and Professor in ENT Department at World College. He has been the former Dean and Director of Maulana Azad Medical College, New Delhi, and he is an alumnus of our college of 1974 batch. A big round of applause for this gentleman. Thank you so much, sir. I'll call upon Dr. Aparna Parmar. She is Senior Professor and Head, Department of Microbiology, looking after various labs. And I believe so कि आज का जो One Health topic है, she is the person who is going to get benefited the maximum. And she is also looking after so many virology lab, HIV lab, and many other BLS3 lab is going to open.
So with this, we will going to start our first presenter of the day. And I again request the respected chairpersons that the time allotted for each speaker is 5 minutes, and the 2 minutes are for question and answer round. So we request every person, every speaker to just focus and remain time constrained. The first presenter is Dr. Richa Verma. Please come.
Hello. So the time is automatically being kept, no? We'll know at the end of 5 minutes. Yes, start please.
Good afternoon. The topic of my presentation is effect of ethinyl estradiol norethistone acetate combination with and without scaling on periodontal status and HSCRP levels in PCOS women having gingivitis, a randomized control trial. Now, gingivitis and PCOS have both been linked to elevated level of CRP. In gingivitis, bacteria invade the circulation through ulcerated epithelium, causing an increase in levels of CRP. In PCOS, reactive oxygen species formed due to hyperandrogenism cause increase in level of advanced glycation end products, which in turn raises the level of pro-inflammatory cytokines locally and systemically. The COC in the present study is a low-dose composition consisting of 30 micrograms of ethinyl estradiol and 1 milligram of norethistone acetate. These low-dose COCs have been found to raising serum CRP levels in systemically healthy females as well as PCOS patients. However, their impact on gingival inflammation is conflicting. Although no study has yet been conducted on this particular combination, so the hypothesis formulated was that being a low-dose COC, this combination may affect local and systemic inflammation in women with PCOS, and hence this randomized control trial was conducted. Coming to the inclusion criteria, females 15 to 40 years of age having generalized gingivitis and newly diagnosed with PCOS were included, who had to be age and BMI matched. Exclusion criteria were presence of any chronic, systemic or local disease that could affect the inflammatory status of the participants, also history of smoking or alcohol intake, and usage of oral contraceptives or antibiotics within 3 months prior to study were considered as exclusion criteria. Now, women having PCOS and gingivitis were randomly divided into 2 groups. Test group consisted of PCOS patients with gingivitis on this particular COC who received scaling along with oral hygiene instructions, that is OHI. Control group 1 consisted of PCOS patients on this COC having gingivitis who received only OHI. Control group 2 consisted of age and BMI matched systemically healthy females having gingivitis who received scaling along with OHI. Periodontal parameters, anthropometric parameters, serum HSCRP levels, gingival biotype and PCOS phenotype were assessed. All the parameters were assessed at baseline, 3 and 6 months follow-up, while HSCRP was assessed only at baseline and 6 months. Periodontal intervention in test group and control group 2 consisted of full mouth scaling in 2 sessions with 24 hours gap between both the sessions. Medical treatment consisted of this COC given to test group and control group 1 patients. Medical treatment and periodontal treatment were begun simultaneously. Sample size was calculated and appropriate statistical tests were applied. Coming to the results, at baseline data was found to be homogeneous. Coming to intragroup comparison, serum HSCRP levels in all the periodontal parameters were found to be decreased significantly in all the 3 groups. Coming to intergroup comparison, serum HSCRP level decreased to similar extent in all the groups. Mean decrease in gingival inflammation from baseline to 6 months was significantly higher in test group as compared to control group 1, while change in all the other periodontal parameters was not found to be significant. Coming to discussion, this is the first randomized trial to have been conducted to observe the impact of scaling on periodontium of PCOS patients having gingivitis and consuming this COC. Talking about serum HSCRP levels, slightly higher but not significant improvement in HSCRP was seen in test group, which could be possibly due to very less reduction in HSCRP, as gingivitis is a very mild form of inflammation. Also, COCs have been known to be contributing to increased systemic inflammation in PCOS patients. In test group and control group 1, there was significant difference in change in gingival inflammation, that is GI. However, HSCRP was reduced by similar extent, possibly due to the effect of this COC in reducing the systemic inflammation by regulation of hormones. Also, reduction in GI in test group was significantly higher from 3 to 6 months as compared to systemically healthy females, which throws light on the fact that it could be due to the synergistic effect of this COC and scaling in reducing systemic inflammation and gingival inflammation by regulation of hormones. Coming to gingival inflammation, decrease in gingival inflammation was highest in test group. Also, comparable decrease in GI was seen in control group 1 and control group 2, suggesting no detrimental effect of the COC and GI. Further, from 3 to 6 months, decrease in GI was higher in both the groups of PCOS patients as compared to systemically healthy females, it being significantly higher in test group as compared to control group 2, which could be possibly due to the role of this COC in decreasing GI in test group patients. Now, the suggested mechanism for impact of the COC in systemic and gingival inflammation is as follows. PCOS patients having oligo or amenorrhea have decreased level of serum estradiol, which makes them more susceptible to periodontal destruction and raises the level of interleukin 6 and TNF-alpha in such patients, which in turn raises their CRP levels. This progesterone in this combination, upon absorption from GIT, converts to its active form NET, which then partially converts to estrogen, which compensates for the deficiency of estrogen in such patients, leading to decrease in gingival and systemic inflammation in the patients. Strict exclusion and inclusion criteria, BMI matching, systemically healthy women added as controls, and randomized control method of trial added to the strength of the study. The limitations were that only single marker of systemic inflammation and no local markers of inflammation were assessed. To conclude, this low-dose combination of EE-NETA has no detrimental effect and might have a protective effect on gingival inflammation. Also, this COC alone and in combination with scaling might be effective in improving systemic inflammation in PCOS patients. These are my references. Thank you.
How many cases you did in both control and the other group?
Sir, in first group, there were 28 patients. Second group, we had 26 patients till 6 months, and 25 patients lasted in the third group.
Now that you have done this 6 months trial, are you continuing with this same trial in your department, or it is stopped?
No, sir, we are not continuing it further.
Okay. All right. So, what is your one-line gist of your research work, effect of these hormones on gingivitis?
About this study, sir, this combination of steroids did not have any negative effect on gingiva of the patients, which is in contrast to previous studies that have been conducted on majority of previous studies that have been conducted on low-dose COCs. So it can be given in patients of gingivitis and would not cause any harm to the periodontal gingival status of the patients.
Good work, Richa.
Thank you. Thank you. Thank you.
So we call our next speaker, Ajay Verma. He will be speaking on oral microbe dysbiosis of polypyromonas gingivalis in oral leukopelia, oral SCC, and radiation-induced oral mucositis.
Good afternoon, everyone. The title of my topic is Oral Microbiome Dysbiosis of Porphyromonas gingivalis in Oral Leukoplakia, Oral Squamous Cell Carcinoma, and Radiation-Induced Oral Mucositis, a qPCR-based immunohistochemical study. So oral microbiome, consisting of 687 species, plays a crucial role and has been associated in various disorders like Helicobacter pylori in gastric and Streptococcus angiosus in oral and esophageal cancers. OSCC, which is the most common head and neck cancer, is usually preceded by OPMDs, and thus an early detection is important. Progression of this OSCC and bacterial dysbiosis is seen to be associated with the inflammation produced by the bacterial endotoxins. However, lesser studies has been done in the past. Also, the microbial ecosystem is disrupted in the patients which are undergoing radiotherapy for the treatment of oral cancer and suffering from the radiation-induced oral mucositis. So, the Porphyromonas gingivalis, a periodontal pathogen, has been associated with OPMD and OSCC, and it's a gene called as FIM-A1 gene causes adhesion and colonization. However, lesser studies has been done in the past. This bacteria P. gingivalis, it also enhances the carcinogenesis module by modulating various signaling pathways like the increasing the mesenchymal trait, increasing the cellular proliferation, and inhibiting the apoptosis. So, the aim of the study was to evaluate and quantify the microbial load of this bacteria in various groups, and the objective was to quantify, to compare, and to correlate these the level of bacterial load within the various groups. Material and method. A total of 6 groups were there, divided into 16 sample size each, which includes healthy non-smokers, healthy smokers, periodontitis, leukoplakia, OSCC, and radiation-induced oral mucositis. And in this DNA, after taking the oral swab, DNA extraction followed by RT-PCR was done. And in the group of leukoplakia and OSCC, immunohistochemical expression of BCL2, Ki67, and beta-catenin was done. Coming to the result, as we all see in the graph, the level of the bacterial load was significantly higher in the radiation-induced oral mucositis, followed by the oral squamous cell carcinoma, then periodontitis, normal, and leukoplakia. And also to eliminate the bias of the periodontitis and to eliminate the confounding bias of the tobacco, we applied Pearson correlation and multilinear regression analysis, and we observed that the leukoplakia and OSCC, they are significantly correlated, and 1 unit increase of bacteria in the leukoplakia leads to an increase of 3 units in the OSCC. In the IHC result, we can see in the first 4 tables that the expression of Ki67, the BCL2, and the beta-catenin significantly increases as we move from the oral leukoplakia to the oral squamous cell carcinoma. However, the result was statistically insignificant when we compared the bacterial load with the immunohistochemical markers. So in the previous studies, in the periodontitis, healthy smokers and healthy non-smokers, the expression of this FIM-A1 gene was significantly lesser. This can be attributed to the fact that in the previous studies, all of the findings were done on the complete FIMBRE gene. However, in the current study, the sampling technique was different because we only focused on the FIM-A1 gene. Also, there was a methodological difference because we only see these site-specific cases. So the level was different. In case of the oral leukoplakia, previous studies have found an increased P. gingivalis level in the oral leukoplakia. However, no study was done in the FIM-A1 gene. In the current study, the level of the bacteria was lesser in oral leukoplakia because it might be contributed to the fact because the leukoplakic lesions, they are usually superficial in nature. Thus, the bacterial penetration is impossible. In OSCC, we found second highest load in the groups, and this can be attributed that the bacterial influence, it is stronger in the presence of dysplastic or the malignant changes. In the radiation-induced oral mucositis group, we found the highest level of bacteria. However, in the past, no studies has been done which detected the level of this bacteria in this group. So it can be attributed to the reason that radiation-induced oral mucositis associated mucosal damage allows higher microbial colonization, leading to further progression of the disease. When coming to the markers, all these markers were increased when we go from the leukoplakia to the OSCC, and further previous studies have also reported the same, and it can be attributed that these markers, they are attributed to causing a higher level of OSCC when we proceed from the leukoplakia to the OSCC. Coming to the conclusion, this study, it demonstrates a significant association of P. gingivalis with OSCC and radiation-induced oral mucositis, and the elevated bacterial load along with the higher immunohistochemical expression of the markers suggest that P. gingivalis contributes to tumor proliferation, apoptosis resistant, and EMT. However, the lack of correlation with the tobacco use challenged the prior assumption, highlighting the complexity of this microbial interaction. Our findings emphasize that P. gingivalis can be a potential biomarker for early detection and the therapeutic target. Future longitudinal studies and larger diverse cohorts incorporating the next generation sequence could provide deeper insights, and clinically, microbiome targeted strategies such as probiotics, antimicrobials, and immunomodulators, which offer promising results to curb the cancer progression and manage the radiotherapy complications, can be done. These are my references. Thank you.
Good. I have just one query from you. Why was the need for including leukoplakia in your study? When everybody knows that it will not penetrate, so we do not expect any microorganisms to be developed in these lesions.
Sir, because the OSCC usually proceeds from the oral potentially malignant disorders, and leukoplakia is one of the most common OPMDs. That's why, sir.
No, that's all right, but then you did not find anything in your study, no?
Yes, sir. The results were lesser, sir.
And the sample size is?
Sir, 16 for each group.
It's also on the lower side.
Sir, actually it was a cost factor because running RT-PCR, it costed around 1,200 rupees for running a single sample of RT-PCR.
Anyway, thank you.
Sorry, ma'am.
You plan to work further on this?
Ma'am, if get a chance, definitely.
Okay, thank you.
Thank you, ma'am.
May we now call upon the next speaker, Rahul Sharma.
A very good afternoon to all of you. So the title of my study is to determine the effect of allograft and collagen membrane combination on periapical healing and labral bone regeneration in apicomarginal defects treated with endodontic microsurgery, a randomized controlled trial. So coming to the introduction part, apicomarginal defects are the bony defects which are characterized by localized loss of alveolar bone spanning over the entire root length. So till date, a total of 4 studies have been conducted on such defects, 2 animal studies and 2 human studies, but neither of them evaluated the periapical healing with the help of a 3D CBCT scan. So far, no study determined the same healing of such defects with the help of a 3D CBCT scan. The research question was, do patients with such defects undergoing endodontic microsurgery with the help of guided tissue regeneration with a combination of allograft and a bioresorbable collagen membrane in comparison to patients undergoing endodontic microsurgery with no use of guided tissue regeneration, whether they show increased clinical or radiographic success when followed up for the next 12 months. So the population comprised of patients over the age of 16 years with radiographic evidence of apical radiolucency in non-vital anterior tooth and a concomitant deep pocket present. The intervention group or the test group had allograft and a bioresorbable collagen membrane combination placed, whereas the control group was treated with no use of guided tissue regeneration. The outcome measures were to compare 2D healing using Rudd and Malvin criteria. 3D healing was assessed using the modified Penn 3D criteria after the surgery was done in the patients with apicomarginal defects, and these patients were followed up for the next 1 year. Also, labral bone regeneration was also taken into account as an outcome measure. So post-operative preparation was done with the local anesthesia followed by flap reflection, and osteotomy was done using the round burr. Root end resection, which was the apical 3 mm of the root, was resected and preparation was done using ultrasonic tips followed by MTA placement. In the test group, we had used DFDBA allograft along with a collagen membrane, whereas in the control group, no use of guided tissue regeneration was done. Flap was repositioned and the suturing was done with the help of a 5-0 monofilament polyamide suture. Post-operatively, the patient was advised to do chlorhexidine mouthwashes and the suture removal was done in the next 4 to 7 days. Coming to the sample size for the present study was 30, 15 in each group, and the subjects were assigned to either of the group with the help of randomization, and blinding was also done to eliminate any sort of bias on the part of the investigators and to balance the number of patients between both the groups. Statistical analysis were done with the help of Shapiro-Wilk test, chi-square test, Fisher-Exact test, and logistic regression was applied to observe any association between independent and dependent variables. So these were the clinical or the radiographical findings for the test group, in which we can see the placement of the allograft, and later on it was covered with the help of a collagen membrane, and the suture was done with the help of a 5-0 monofilament suture. These were the photographs for the control group, in which
we have used no means of any guided tissue regeneration. The flap was raised, the lesion was curated, and the flap closure was done with the help of 5-0 suture. This is how we assessed the generation of the labial bone, in which we had taken two landmark points. One was point A, which tells you about the apical extent of the generated labial bone to the crestal level. Point B tells you about the length of the root, which is from the apex to the cemento-enamel junction. Coming to the results, comparing the 2D outcomes, in the study group, it was 100% for both the groups, and it was 86.6% for the control group. Coming to the 3D outcome evaluation, it was 80% in both the groups, whether it was test group or the study group or the control group. Coming to the labial bone assessment, a total of 8 patients showed labial bone regeneration in the test group, and a total of 2 patients showed labial bone regeneration in the control group, which was found out to be statistically significant. At the 1-year follow-up, the study findings indicated that the use of allograft and collagen membrane in GTR significantly improves labial bone regeneration in apicomarginal defects treated with endodontic microsurgery, but there was no statistically significant difference in the healing of the periapical bone formation, whether it was about the test group or the control group. Future recommendations for such studies include extended follow-up times for better healing assessment for uncertain healing, and may utilize advanced imaging techniques like micro-CT or digital subtraction radiography for more precise evaluation of periapical healing. Thank you.
Which allograft exactly you used in your study?
Sir, we had used DFDBA, which stands for Demineralized Freeze-Dried Bone Allograft, which was obtained from Tata Memorial Hospital, Mumbai, sir.
How much cost?
Sir, it was available for 1750 per vial. Per vial of 0.5 cc, and the graft size was greater than 1040 microns, sir.
So who was bearing this cost?
Sir.
Your patients?
Yes, sir.
Not the department?
Sir, whosoever was eligible was able to afford it. It was done by the patient side, otherwise we had done it.
And what about the collagen material?
Sir, the collagen membrane was available in the form of periapical GTR.
How did you procure that?
Sir, it was commercially available, sir.
Again, a costly item?
Sir, no, sir. It was for around 800 per membrane, sir.
So you did only 20 cases
sir, 30
in
cases,
each group?
Sir, 30 cases.
30 in each group. Still on the lower side. Anyway, it's a good presentation. Thank you.
Thank you, Rahul.
Thank you.
Next we have Pooja.
Good afternoon, everyone. The topic of my presentation is interplay of hypoxia, angiogenesis and immunogenic potential in periapical lesions and immunohistochemical study. Hypoxia in periapical lesions leads to tissue necrosis and abscess formation. Hypoxia-inducible factor 1 alpha is stabilized under hypoxia and promote pro-angiogenic factors like vascular endothelial growth factor. VEGF promotes new blood vessel formation and tissue repair. It also recruits macrophage, which contribute to lesion progression. Macrophages are of two types. M1 is associated with pro-inflammatory reactions and M2 is associated with anti-inflammatory reaction. Conflicting findings has been seen in M1 and M2 macrophage in periapical lesion. A thorough search of literature revealed that no study has evaluated the combined effect of hypoxia, angiogenesis and macrophages in pulp and periapical lesion. So we aim to investigate the expression of HIF1 alpha, VEGF and quantify macrophages in periapical granuloma, radicular cyst and pulp. We also correlate hypoxia with angiogenesis and macrophages in the study groups. A sample size of 17 cases of each of the groups were taken and IHC was performed, following which data was analyzed statistically. For HIF1 alpha marker, total score was calculated. For VEGF, total immunopositive cells were counted, and for the macrophages, positivity index were calculated. Coming to results, expression of HIF1 alpha was seen to be highest in periapical granuloma, followed by radicular cyst and pulp. For VEGF and CD68, highest expression was seen in radicular cyst followed by granuloma and pulp. And all the findings were seen to be significant. In case of CD163, highest expression was given by granuloma. Upon intergroup comparison of the markers, we found significant results in pulp and granuloma and pulp and radicular cyst. For pulp and radicular cyst, we saw significant result only in case of CD68. Upon intragroup correlation of these markers, we saw a significant correlation between HIF1 alpha and CD163 and VEGF and CD163. These images shows positive immunoexpression of the markers in the study groups. Coming to discussion, this table shows the comparison of HIF1 alpha expression in the past studies of pulp and periapical lesions. Based on our findings, we could hypothesize that higher HIF1 alpha expression in periapical granuloma than radicular cyst is due to its acute inflammatory environment, increased metabolic demand, and fluctuating hypoxia. These are the comparison of VEGF expression within the past studies of pulp and periapical lesion. Here we hypothesize that higher VEGF in radicular cyst is due to chronic inflammation and epithelial driven VEGF, and in case of granuloma we see inflammatory cell driven VEGF. These are the comparison of the markers of CD68 and CD163 in the past studies. Upon calculating the ratio between CD68 and CD163, we saw highest in radicular cyst and least was in case of periapical granuloma. This suggests that M1 macrophage was seen more in radicular cyst and M2 macrophage were more in the periapical granuloma, which suggests that the radicular cyst is linked to persistent infection and necrosis and promote M1 macrophage polarization for pathogen elimination. And in case of granuloma, it is associated with a later tissue repair stage favoring M2 macrophage for inflammation resolution and healing. Upon correlation of the markers, we saw that in case of radicular cyst, on increase of hypoxia, there was increased VEGF-driven angiogenesis. And in case of periapical cyst and granuloma, on increasing hypoxia, there was increase in M2 macrophage polarization. Coming to conclusion, our study was a pioneer attempt to correlate the interplay between hypoxia, angiogenesis, and immunogenic potential in periapical lesion. The findings highlight the crucial role they play in the development and progression of periapical lesion, which could provide a foundation for novel therapeutic approaches. HIF1 alpha and VEGF inhibitors can provide potential non-surgical strategy to reduce bone resorption and enhance tissue regeneration. Also, VEGF inhibitor can control angiogenesis and bone loss. Combination therapy can be given using antimicrobial, which can also accelerate the lesion progression. M1 and M2 macrophages can be used as prognostic marker. Also, immunomodulatory therapy can be developed to enhance the M2 macrophage polarization, which can help in tissue regression. These are my references. Thank you.
What is the usual line of treatment for these apical and pulp lesions that you have mentioned? You have not used the word pulp in your title of your presentation.
Yes, sir. The usual treatment we go is endodontic treatment, RCT we go for them. We go for surgical approach and we do not go much for non-surgical approach.
What about immunotherapy? Have you started in your cases?
We have not yet started. If this following test, we will develop strategies and use them.
And combination therapy, that's going on?
We give antibiotic in the beginning, but we have not combined it with any inhibitors like VEGF or HIF. We have not used it as far. We only go for antimicrobials in the beginning before doing RCT.
Okay.
Thank you, Pooja.
Thank you.
Next we have Ritika.
Good afternoon, everyone. Good afternoon, everyone. The topic of my presentation is association of apical periodontitis with glycated hemoglobin levels, that is HbA1c, and systemic inflammatory markers in the patients with type 2 diabetes. It is a cross-sectional study. The first picture depicts the apical periodontitis, while the second obvious is the cause of diabetes. So introducing my topic is, type 2 diabetes mellitus is a group of metabolic disorders which is prevalent worldwide related to progressive loss of function of pancreatic B cells, which further leads to insulin resistance and chronic hyperglycemia. So I want to tell you the association between these two. Diabetes is causing impairment of innate immunity, which predisposes the patient to chronic inflammation, which further increase the serum pro-inflammatory cytokines, that is IL-1, IL-6, HSCRP, TNF-alpha, which further decreases the repair capacity of tissues, delays healing, and increasing the prevalence of periodontitis in such patients, means diabetes patients. The same protocol has been shown with the patients in apical periodontitis, in which the bacterial flora and products which are causing apical periodontitis, they trigger inflammatory response, which further increases the serum pro-inflammatory cytokines that was involved in the same procedure as in case of diabetes, which worsens insulin resistance and aggravates hyperglycemia. So there had been many studies which has till date shown the effect of type 2 diabetes mellitus on apical periodontitis. However, only 2 human studies have been done which has studied the effect of apical periodontitis on type 2 diabetes mellitus. It means if the patient is having dental disease, that is apical periodontitis, one study says that it has a negative feedback on diabetes progression, while the other study says there is no difference with the presence of apical periodontitis in such patients, or presence or absence does not make any difference. So we aimed to investigate whether this presence of apical periodontitis had an effect on markers of systemic inflammation, that is IL-1, IL-6, TNF-alpha, HSCRP, as well as on HbA1c in patients with type 2 diabetes mellitus. This is the material and methodology. The flow chart shows 280 patients were assessed for eligibility, in which 256 patients were included, 128 patients were systemically healthy, and 128 patients were diabetic. And these two groups, they were age, gender, and BMI were matched for both groups. Now these two groups have further been divided into 2 groups, with apical periodontitis and without apical periodontitis, 64 in each group. And baseline evaluation of all the 4 inflammatory markers has been done using ELISA reader and washer in our own lab. Sample size has been depicted on the basis of previous 2 studies, 80% power and 0.05 alpha level with a mean difference of 0.91. A sample size of 58 per group was calculated, and we have taken 70 patients per group, so that anticipating 20% dropout. Now inclusion criteria for diabetes was greater than 6.5 HbA1c, while for apical periodontitis the PAI score should be greater than 3. Statistical analysis, normality was checked. For comparison of 4 groups, quantitative analysis, Kruskal-Wallis test was used. When we were using the quantitative analysis between the 2 groups, we used Mann-Whitney test, and the correlation analysis was done using partial correlation analysis for evaluating the association between these markers and their association with HbA1c, as well as presence of apical pathology and the size of apical pathology. And after getting to know the correlation analysis, we applied this multivariate regression analysis to know the possible influence of various variables on HbA1c as well as inflammatory markers. The baseline data showed us that HbA1c, IL-1, IL-6 and TNF-alpha as well as HSCRP, all these were greater in patients with diabetes with apical periodontitis compared with that of only diabetes patients or control with periapical or only systemic healthy patients. These were our results, which shows partial correlation shows size of periapical lesion showed strong positive correlation with all the inflammatory markers as well as HbA1c. Similarly, multivariate regression analysis also shows presence of apical pathology and lesion size. They both were significantly predicting the elevated levels of HbA1c as well as 4 levels. Discussing, I would like to say very few studies have noted this raised levels, but this much sample size nobody has used, and this conclusion nobody has drawn. Strength was large sample size, while limitation was it is a cross-sectional study. Because it is a preliminary part of a project going on, we are doing intervention in all these patients which are having apical pathology. So concluding, I would like to say, we conclude that both the presence of apical pathology as well as the size of periapical lesion, they both are contributing to elevated levels of markers as well as HbA1c levels in diabetic patients. Thank you so much.
Good. You have a good number of cases, 256 you did.
Yes, sir. Thank you, sir.
Did you measure the size of the lesion?
Yes, sir.
You are talking about
Yes,
the
sir.
variation.
We have measured the area of the lesions in millimeter square using Corel Draw software.
Okay, so you observed that the larger the size of the lesion, more were the markers. I mean,
yes, sir.
in
Yes, sir.
their
More
intensity.
were the value of markers, as well as HbA1c level was also correlating with the size of lesion.
Thank you. Nice presentation.
Very good, Ritika. Thank you so much.
Thank you, ma'am.
Next, we have Himanshi.
Good afternoon, everyone. I will be presenting my paper on potential effects of non-surgical endodontic treatment on inflammatory marker and kidney function indicators in chronic kidney disease patients with apical periodontitis. So the first thing which comes to our mind is how the apical periodontitis is related to the systemic disease like CKD. So apical periodontitis is a localized inflammatory condition of the periradicular tissue surrounding the tooth. However, although it is confined to the apex of the root, evidence suggests that it can spread from the root canal into the bloodstream and may trigger the immune responses of the other organ and may affect other organs and tissues, hence worsening the systemic inflammation. Both of these conditions have high level of pro-inflammatory cytokines like interleukin-6, TNF-alpha, which can cause the tissue damage. The impaired immune responses associated with systemic disease, be it chronic kidney disease or diabetes or cardiovascular disease, all can affect the reparative response of the dental pulp and the periapical healing. Also, one study has observed the significant positive relation between the number of diagnosed teeth with apical periodontitis and serum urea level of 4.3 milligram per deciliter increase in the urea level could be expected per 1 unit increase in the number of teeth. So we can say that by improving the oral health through non-surgical endodontic treatment, we may improve the systematic inflammatory status and renal function of the patient. So the aim of this study was to determine the effect of non-surgical root canal treatment in CKD patients and healthy patients with apical periodontitis, and to see whether these treatments are helpful in reducing the markers in patients or not. So this was an interventional study which was done in our department. 37 patients in each group was calculated by considering the mean difference in the serum HSCRP level in patients with apical periodontitis before treatment and after treatment. The inclusion criteria for CKD patient was the patient must be in stage 3, 4, 5 or 5D with mature permanent teeth. All other inclusion criteria were same for both the groups, that is the patient should be 18 years or older, should have more than 12 natural teeth, and the periapical index was used to assess the periapical status, and the patients with PI score 3 or equal to 3 were included. The exclusion criteria was the patient should not have any other systemic disorders other than the chronic kidney disease. Stage 3 and 4 periodontitis were also excluded, pregnancy, lactation and contraceptives, and patients taking antibiotics, statins, corticosteroids and aspirin, which can affect the level of inflammatory markers in the past 1 month. So this is the methodology. The patients were recruited after meeting the eligibility criteria. 2 groups were considered, CKD group and healthy group. After that, the primary non-surgical root canal treatment was done. Then at baseline, the measurements was taken for inflammatory marker, that is HSCRP in both the groups, and kidney function indicators, that is urea and creatinine, were checked only in the experimental group at baseline 3 months and 6 months. After collection of the data, statistical analysis was done. First, the normality was checked, and it was shown that the data was not normally distributed. Hence, non-parametric tests were applied. Mann-Whitney test was used to see the changes in the markers between the group, and Wilcoxon signed rank test was used to see the change in the inflammatory markers within the group. Also, the multilinear regression was applied to assess the effect of independent variables on the blood urea, serum creatinine, HSCRP and EGFR. And the results showed after 6 months there was significant improvement in the blood urea level. However, the serum creatinine and EGFR showed improvement throughout the study, but they were not statistically significant. And in case of HSCRP, both the groups show significant reduction after the treatment, and it was also shown that the level of inflammatory markers, that is HSCRP, was very high in the CKD group as compared to the healthy group. So given this inflammatory burden, the management of apical periodontitis may play a crucial role in mitigating the systemic inflammation by lowering blood urea and serum creatinine level, hence enhancing the EGFR and potentially decelerating the progression of CKD. So apical treatment may offer broader systemic benefits beyond oral health. However, the cause and effect relationship cannot be made because the study design did not include a control group of CKD patients without root canal treatment to evaluate the changes. Additionally, the CKD patients were receiving symptomatic treatment for anemia or calcium phosphate imbalances or metabolic acidosis, which may have contributed to the observed reduction. Thank you.
What exactly we do in non-surgical treatment for your endodontics
Sir,
issues?
in non-surgical, sir, we do the root canal system. We open the tooth and remove the pulp tissue, which is dead now and is causing the inflammation. So
Can you go closer to your mic?
Sir, we remove the pulp tissue from the tooth because as it is necrotic due to the infection and it is continuously spreading the infection. So we remove that pulp tissue and seal the area so that the inflammation does not spread further.
Okay, so these CKD patients that you did also in non-CKD cases.
Yes,
so
sir,
what exactly difference you found?
Sir,
The levels of the inflammatory markers was much higher in CKD patients than the healthy patients.
Yes, sir, they were much higher in CKD patients because they have uremic toxins accumulating in their body and their kidneys are not working, so they get accumulated continuously and are not filtered out, which continuously increase the level of pro-inflammatory cytokines. That's why they have more inflammation.
So this is a very good study which is suggesting that if you treat these infected cases of the roots of the teeth,
yes, sir,
you can reduce the symptomatology of the kidney disease as such.
Yes, sir.
So are you continuing with this project in your department?
Yes, sir. This is my thesis topic. It's done, sir. We are now applying results and seeing further.
Okay, thank you.
Good, Himanshi. Thank you.
Thank you.
Next we have Janvi.
Good afternoon, everyone. The topic of my presentation is Impact of Periodontal Treatment on Masticatory Dysfunction and Psychological Distress in Stage 3 and 4 Periodontitis Patients. According to Global Burden of Disease, periodontitis is a major public health challenge affecting over 1 billion people worldwide. The global incidence, prevalence, and disability-adjusted life years of periodontal diseases have increased twofold in the last 3 decades. The chronic destruction of tooth-supporting apparatus renders the tooth weaker and the patient is not able to apply forces enough to chew. Although there are limited number of studies regarding the effect of periodontal status of teeth on masticatory performance and the possible improvement after periodontal therapy. There is increasing evidence regarding association of periodontal diseases with psychological distress, namely depression and anxiety, which also account for the highest causes of years lost to disabilities. Various links have been explored between periodontitis and psychological distress, namely neuroinflammatory pathway and the psychosocial effects of periodontitis on the psychology of patient. Recent systematic reviews and meta-analysis have also found an association between periodontitis and depression and anxiety. But what remains unexplored is the influence of periodontitis on patients' psychological status, specifically through impairment in masticatory function over time. We also assess the potential improvement in psychological outcomes following non-surgical periodontal therapy. Based on sample size calculations, we recruited a total of 84 patients, 42 with generalized stage 3 and 4 periodontitis, and 42 age-matched participants forming the control group. Periodontal parameters were determined using probing depth, clinical attachment level, bleeding on probing. The masticatory function of patient was assessed both subjectively using a questionnaire and objectively with the help of optoelectronic assessment of the color mixing ability of two-colored chewing gum. The psychological status was assessed using a validated questionnaire, hospital anxiety and depression scale. The treatment was given to patients suffering from stage 3 and 4 periodontitis following the European Federation of Periodontics stage 3 level clinical practice guidelines. After 3 months of completion of treatment, the patients were re-evaluated for the outcome parameters. Given the data distribution non-normal, we used Spearman's correlation analysis to the pooled data followed by linear regression analysis in 3 models. We also applied causal mediation analysis and logistic regression model was fitted to calculate the natural indirect effect, direct effect and the percentage mediated by masticatory dysfunction. In the results, we can clearly appreciate decrease in the periodontal parameters after treatment. Along with that, masticatory function of the patient improved significantly with a marked improvement of 9.2% in subjective assessment and 30% improvement in objective assessment. The psychological status of the patient also improved 3 months after treatment. There was a strong correlation of masticatory performance with periodontal parameters as well as psychological status of the patient. The mediation analysis revealed that clinical attachment level affects the psychological status of patient specifically through subjective masticatory dysfunction. The findings of our study suggest that advanced periodontitis patients not only exhibit compromised masticatory function but also tend to have elevated levels of psychological distress as evidenced by higher depression and anxiety scale scores. Resolution of periodontal inflammation enables repair and regeneration, thereby improving the quality of reduced periodontium. This improves the stability of the teeth and makes them better able to withstand the masticatory forces. Our study observed a significant resolution of 76.2% in the periodontal inflamed surface area, and it contributed to the improvement in masticatory efficiency as well as the psychological parameters of patient. While the impact of periodontitis on masticatory function and psychological distress has been investigated independently, our study is the first to appraise the mediating role of masticatory dysfunction in this relationship. We found that subjective masticatory performance was the most influential factor predicting the total score of hospital anxiety and depression scale, while anxiety trait was found to be contributed by bleeding on probing. To conclude, I'd like to say that a holistic understanding of periodontitis is essential, recognizing its implications on patients' overall well-being. Thank you.
Dr. Janvi, you did not define various stages of periodontitis. You talked about 3 and 4, but you did not give us in the introduction itself. Can you do it now?
So there are 4 stages of periodontitis based on bone loss of patient. Stage 1 and 2 do not include tooth loss, and while in stage 3 and 4, these are advanced stages of periodontitis where the patient has already suffered from tooth loss. In advanced stages of periodontitis, although there have been various studies which have said that the tooth loss causes masticatory dysfunction, but no study has yet determined the effect of remaining teeth on masticatory dysfunction. So we try to assess stage 3 and 4 periodontitis effect on the masticatory dysfunction of patient.
Okay.
What was the age group of your patients?
Ma'am, the age group was, patients were 30 to 50 years old.
Okay, thank you.
Thank you.
Next. And the last one is Priyanka.
Good afternoon, everyone. The topic of my presentation is impact of bruxism on the outcome of subgingival instrumentation for the management of stage 2 and stage 3 periodontitis. Starting with introduction, periodontitis is a chronic inflammatory condition that impacts the periodontal tissues, and managing periodontitis, especially in its moderate to severe stages, requires a comprehensive approach. Bruxism is a parafunctional habit involving teeth grinding and clenching is one such factor that imposes excessive occlusal forces on the periodontium. And this is a notable risk factor for the progression of periodontal diseases, especially in the advanced stages. Bruxism contributes to the increased occlusal trauma, intensifying the damage to periodontal tissues by amplifying mechanical stress on the inflamed and compromised structures. Subgingival instrumentation is a non-surgical intervention to eliminate biofilm, calculus, and toxins from the root surfaces. The effectiveness of the periodontal therapy is influenced by individual patient factors such as systemic health, genetic predisposition, and behavioral habits, which play a critical role in determining treatment outcomes. Now, objective of our study is to explore the mechanisms by which bruxism affects the periodontium and to assess the impact of bruxism on the outcome of subgingival instrumentation for the management of stage 2 and stage 3 periodontitis. Now, this was a comparative interventional study which recruited total of 73 systemically healthy patients with generalized periodontitis stage 2 and stage 3. All the patients were informed and written consent was obtained from all the participants. Out of 73 patients, we recruited 35 patients in group 1 and 38 in group 2. Out of 73, 58 patients completed the follow-up period of 6 months. The mean age of group 1 was 36 and 38 was for group 2. Female to male ratio was 19:10 for group 1 and 20:9 for group 2. Materials and methods are detailed periodontal evaluation of periodontal parameters such as plaque index, gingival index, bleeding on probing, pocket depth, and clinical attachment level and tooth mobility were evaluated at baseline at a period of 6 months. Now, the group 1 was the patients with periodontitis and bruxism, and group 2 patients were with periodontitis only without bruxism. To diagnose the bruxism, we used a recently introduced tool that was Brux Screen. We did subgingival instrumentation in both the groups and reported the results after a period of 6 months. We stratified the results based on probing pocket depth categories, that is less than or equal to 3 mm, equal to 4 mm, equal to 5 mm, or greater than or equal to 6 mm. These are the clinical photos that are showing pre and post treatment. These are my results. This table 1 and graph showing the intergroup comparison of periodontal parameters at baseline, and table 2 representing intergroup comparison of changes, that is improvement in periodontal parameters at 6 months. Now this table represents the intergroup comparison of PPD and CAL at baseline and improvement, and this graph showing the improvement in both groups. Conclusion, this study provides evidence that bruxism significantly improves the therapeutic outcomes following subgingival instrumentation in patients with periodontitis. Stratification based on the probing depth, buccal or lingual or interproximal sites demonstrate that similar adverse impact of bruxism on clinical outcomes in management of periodontitis stage 2 and stage 3 through subgingival instrumentation. Although both groups demonstrated improvements over 6-month study periods, the group 2 represented more improvement than group 1. This disparity suggests that mechanical forces associated with bruxism, such as excessive occlusal wear and strain, disrupt the regenerative capacity of periodontal tissues. Now, future direction, interaction among occlusal forces, tooth mobility, and progression of periodontitis need to be investigated, as contrast findings are observed between these parameters with reference to different grades of tooth mobility in present study. These are my references. Thank you.
Very good work, Priyanka. I don't think I have any question.
Thank you.
Commendable work by all the participants, but as is the rule, we have to judge, so we will be marking them. Let's wait for the result.
like to extend my gratitude to all the organizers, especially Dr. Pushpa Daya, for inviting me. It's an honor. Thank you.
Sir, felicitation, please. Hello. Thank you so much, sir. And I believe, sir, Dr. Pasi sir, जिस तरह से मतलब सवाल पूछे तो थोड़ी देर में तो मुझे भी लगा कि सर ने ENT के साथ साथ MDS भी कर रखी है. क्यों सर? Yes, yes. And may I request Dr. Tiwari sir to please join on the stage to felicitate our speaker. Thank you so much, sir. May I request Dr. Sudhir Atri sir, please join us on the stage for the felicitation of the chairpersons. A small token on the behalf of the third University Research Conclave. And it's always heartening to sir, see you again on the stage. And sir, मैं देख रहा हूँ सर टाइम के हिसाब से आपके सवाल ना और ज़्यादा गंभीर होते जा रहे हैं सर. Right, sir. May I request Dr. Tiwari and Dr. Sudhir to please do the honors. तालियों में कमी ना रखें. Thank you. So we are coming to the last talk of the research conclave by none other by Dr. Shankar Prija. Can we have his slide and the Zoom link? Has he connected? Yeah. So we are going to start in 2-3 minutes. It's going to be a Zoom link. Since he has some commitment to do, so he couldn't join us physically, but he will be joining us through a call. Join कर लो। Hello, good afternoon, sir. Are we audible? Can may I request Dr. Shankar Prinja sir, please unmute yourself and your video also, if we can see you. एक बार मिनिमाइज करना तीनों का
Yellow and I can speak and maybe it will be able to hear now. I know, maybe I got मैं तो म्यूट था ना पहले. टेबल अगर ऑन करके वीडियो होल्ड किया हाँ ठीक है. But I can't hear you from there. Nobody from there.
Can we remove the silent button?
Yes, yes. I can hear you now.
Yeah, that's better, sir. Thank you so much. So we are trying to connect him digitally. Let's see our digital technology work this time for the next half an hour. And may I request the chairperson for this session, First of all, I'd like to welcome Dr. Kuldeep Lalad sir, who is Dean PGIMS and Senior Professor and Head Department of Cardiology also, to please chair the session. May I request you to please join us on the stage. I'll take this opportunity to also welcome Dr. Ashok Chauhan, who is Senior Professor and Head Department of Radiotherapy. And I have seen sir in various portfolios in the form of sir, ex-Medical Superintendent, Dean Academic Affairs and many others, sir. And may I request the chairperson to please introduce today's speaker.
Good afternoon, everybody, and I welcome to you this session to be addressed by one of the eminent scientists of the country and our eminent alumni of our institute. I am happy to have you with us, Dr. Shankar. And many of the achievements you already seen on the screen. And just to add that he is a professor of health economics at PGI Chandigarh, and he has number of achievements, awards. So let us, and he is going to apprise us on the burning issue, that is the air pollution, which is especially of interest to us, especially those in the northern part of the country, right? So with these words, we welcome Dr. Shankar Prinja to present his, or to deliver his talk. Thank you.
Thank you very much, sir. It's an honor to have been invited, and my sincere apologies to Professor Dhruv Chaudhary and the organizers of this conference that I could not make it in person because of another meeting that came up here. So I think somebody needs to allow me to be able to share my screen because I'm not able to share my screen. So somebody will have to, from that side, make that. Yeah, I can see now. So, if you can confirm that you can see my slide in full view. Okay, thank you very much. So, as I was saying that, thank you very much, first of all, and it's an honor to be presenting in this August gathering, and my sincere gratitude to the organizers of the conference, Professor Dhruv Chaudhary and all other, the chairs. So I saw the agenda, and considering that it's a topic which is on One Health and several other speakers were speaking on diverse issues that were related to One Health, I thought I'll try and cover an area which is also of equally significant importance from One Health point of view, and that is around environmental interventions. And this work that I'm going to present to you is based on a recent study that we completed, which was commissioned by the Ministry, Government of India, and the UNDP, where we were trying to look at in two cities, Amritsar and Gurgaon, that what is the extent of current levels of PM 2.5 or air pollution, and what can be done if some of the standard well-known interventions that are part of the National Clean Air Program, if they are put in place, then what is going to be the kind of health impact and what are going to be the economic returns on making those investments. So as I said, that there is no denying the fact that there is a very significant role that the environment plays in the overall health of the population. And among the different risk factors that have been identified from the One Health lens, air pollution is one of the important risk factors that is attributable. And while air pollution can be measured in different ways, one of the standard ways in which we measure air pollution is in the extent of the particulate matter 2.5 levels. And we have certain classification matrices that if the PM 2.5 levels are above a certain level, then it is considered as polluted, heavily polluted, or kind of. And we know these days that there are so many regulatory interventions, even judicial activism coming in place, and interventions such as GRAP, which are being applied in many of these metro cities, especially the National Capital Territory region, where even vehicular traffic restrictions are put in place if the levels of air pollution rise above a particular level. Now, the context is that air pollution is said to be one of the leading causes of disease and mortality across the world. And it is reported to contribute to nearly 9 million premature deaths annually. And the reason why this becomes even more important is because the individuals who get affected more often by air pollution are the ones who move out of their houses. And these are the ones who are mostly in productive age group. And when these people face premature mortality, then it also means that there is an immediate economic loss, because these individuals who are in the productive period of their life, they die prematurely and they're not able to contribute. So as a result, there is a significant economic burden of this premature mortality. At the global level, it has been estimated to be as high as nearly 6.2% of the global GDP, which is a very, very significant figure. And in India, some estimates have reported the loss due to ill health contributed by air pollution in economic terms as about 1.36% of the gross domestic product. So that's a very, very high figure. So you can think of it this way, that in our country, the government spends about nearly 1.3 to 1.4% of GDP on healthcare. The entire amount of money that the government invests on healthcare, and this is, I'm talking only the government contribution on healthcare, is some of that much amount of money actually is lost annually because of the premature mortality that is attributable to air pollution. So from that lens, if we look at it, we can consider how serious the situation is. And to address this problem, the government of India in 2019, they introduced a program at the national level, which was called as the National Clean Air Program, the NCAP. And the NCAP was originally introduced to cover about 131 cities, with a kind of a long-term aim to have a number of different interventions which should be put in place such that there is an improvement in the levels of PM 2.5. And these interventions are a lot of those interventions that are beyond actually the purview of the health department. So these fall, let's say, on regulation of industry, on vehicular traffic, on some kind of smart cities, how you build smart cities through sustainable ecosystem, having green belts, etc., plant more trees, etc. So, and there could be other interventions around agricultural residue burning, etc. So a whole range of interventions that have to be done outside of the health sector, but which eventually contribute to the well-being of the people from the health point of view. But when you make those decisions on choices of interventions that can be adopted to mitigate the impact of air pollution, there are a variety of different factors that play a role. The first factor obviously is that if you think about, let's say, saying that we want to do away with all the diesel buses and we want to introduce electric buses, the question is, what is the effectiveness? Effectiveness means, with the introduction of electric buses, how much is going to be the reduction in PM 2.5 levels? Or, you said, for example, in the city of Delhi, they introduced what is called odd even. So you on certain days it will be just the odd numbered vehicles, registration vehicles that will ply on the roads, and on other days there will be even number vehicles that will ply. But what exactly is going to be the effectiveness of introducing such a odd even kind of a strategy for vehicular traffic regulation on the levels of PM 2.5? So first consideration that decision makers, policy makers have is some estimated measure of how much effective it is going to be, or intervention is going to be on the overall improvement in air pollution, and then obviously on the health of the population. Second is feasibility. That okay, we want to do something, but the thing that we want to do is such that it imposes a lot of organizational constraints to be able to implement that intervention. So automatically such an intervention is gone. So for example, you want to have a strong monitoring system, but to have that kind of a stringent monitoring, you do not have enough people who can monitor on the ground. So even if you want to do something which is effective, it's not feasible because you don't have that kind of a manpower to be able to monitor. The third is that you want to introduce an intervention, but you also consider the scale of the intervention. So you want to introduce, let's say, electric buses, but can you completely replace all diesel operated buses in 1 year time frame across all cities, or at least even within a given city also? So maybe that may require a lot of budget, a lot of scaling up of resources, etc. So on those grounds, such an intervention may fall flat. But finally, one of the criteria that kind of combines the effectiveness, combines the cost, etc., is what is called cost effectiveness, where we basically see that what is the value for money that we are going to spend. That means with intervention A, B, or C that we have, there is going to be some impact on PM 2.5. There's going to be some impact on improving the health. But eventually, it's also going to cost the government certain amount of money. So given the amount of money that we are going to spend, what are going to be the returns on investment? That is what we mean by value for money. And we would like to invest in those interventions and choose those interventions that offer that are the most cost effective, that offer us the best returns on the money that we spend. So the whole objective of this entire assessment that we did in these two cities of Gurgaon and Amritsar was to assess the economic value of different sector specific strategies that could be used to mitigate the ambient air pollution. So that was the overall objective of this particular study, where we undertook a variety of different steps. And this is at a glance what we did. In the first place, we basically had a lot of stakeholder consultations, and we did literature review to identify that what are the potential interventions that can be rolled out in these two cities, and what is the kind of published evidence on the effectiveness of these interventions. The second, we tried analyzing that if these interventions are put in place, then what is going to be the reduction in PM 2.5 relative to the levels that exist as of today. So that's the second step that we had. The third step that we did was, okay, with this much reduction in PM 2.5, what is going to be the impact on health? That means what is going to be the reduction in diseases, and what is going to be the reduction in mortality that will happen with the reduction in PM 2.5. And finally, we then, from the health point of view, we converted the reduction in incidence or the reduction in mortality into one single measure, which is called as quality adjusted life year, or QALY. I'm sure in the audience, all of you over there would be aware that there are two very common metrics that are used to define the burden of any given disease. One is called a DALY, the other is called as a QALY. DALY is disability adjusted life year, which is kind of a negative connotation. That means DALYs are all the years that are lost because of either premature mortality or because of ill health or disability. Whereas QALY is a kind of an indicator with a positive connotation. That means you gain quality adjusted life years. That means you add more years to life and you gain more life years if you have some interventions that are able to improve the health. So that's what we did by combining the effect of interventions on the morbidity and mortality both. Finally, we converted this into monetary valuation. So we said that, okay, with this health gain, what would be the gain in terms of the money terms, And then we also determined what is going to be the cost of implementing these interventions. And once we had the cost of implementing the interventions and the economic impact of the health that we gain, then we said, okay, then what is the net economic value of these interventions? So these are the kind of, at a glance, the different steps that we adopted. So coming to what were the interventions that we tried evaluating, we looked at interventions that were across different sectors. So we prioritized 4 different sectors. So first was transport sector, second was industries, third was the reduction in the road dust, etc. And fourth is agriculture. Now, it's extremely important for all of you to also understand that one of the important things that we need to understand when we adopt any intervention for addressing the problem of air pollution is that we need to understand that what exactly is the in those people who work in the field of environment, they know they use a term that is called as source apportionment. So what we mean by source apportionment is that if, let's say, there is a 100% increase in the level of air pollution, then of that 100% increase in the level of air pollution, what is the contribution of, let's say, vehicular emission? What is the contribution of, agricultural residue burning? What is the contribution of industry? What is the contribution of, something else? And interestingly, one of the things that, so while a lot of, news items and a lot of, media reporting continues to focus on agricultural residue burning, but the extent to which agricultural residue burning has been shown to actually contribute to the level of air pollution is not as high as much as the kind of non-exhaust emission because of the vehicular, when the vehicles run on the road, the dust that the vehicles, the dust on the road that gets into the air, which is circulated because of the movement of the vehicles on the road, that actually is the single most important cause. So even when we say the vehicles should be restricted on the roads, it's not even the exhaust emissions, the emissions from the exhaust, but actually the dust that gets unsettled and goes in the air, which leads to a higher pollution level that is one of the major components of air pollution, or PM 2.5 level. The reason why agricultural residue becomes very important is because agricultural residue burning occurs at a time when there's a lot of climatic conditions also that prevent any kind of flow of air within the. So it usually happens during the onset of winter season, when there is cloudy weather conditions, no rain happening, and there's hardly any kind of windy conditions. So there's no wind, there's no air movement, and there's cloud above, no rain. And in such a situation, whatever exhaust or whatever emission comes out, it kind of settles there. It kind of stays there. It doesn't get dissipated. So air pollution is not just a phenomena of the emission of the exhaust of any kind of an particulate matter, but it is also strongly it is associated with the weather phenomenon. So if something happens during the winters, its effect is going to be more. So it gets exacerbated. The effect gets exacerbated, but the overall source apportionment is not too low. So, but cutting the long story short, what we actually looked at are a range of different interventions which are shown here: transport, industry, road dust, and agriculture. And these are the interventions that we tried evaluating. So, for example, shifting to these BS norms which are at the level of 6. Shifting to electric 2-wheelers or 3-wheelers, or modal shift from private vehicles to electric buses. Similarly, in the context of industry, we looked at shifting the industries to cleaner fuels, or enforcing the industry to have better air pollution control devices. So these are some interventions like road green belt development, etc., and then integrated agricultural residue burning. So these are different interventions in different sectors that we evaluated. And what we considered was that we had two scenarios that we modeled. One is business as usual. So let the situation be as it is right now, and let it continue to let the PM 2.5 remain as they are right now, versus you have an intervention scenario. Intervention scenario is you have either of these interventions being applied, and with these interventions being applied, there is a certain reduction in PM 2.5 that happens. So this is what we basically did. And we considered that, okay, what happens if you have a 5-year implementation of these interventions? And we basically study that what is going to be the impact 5 years from then. So in a way, what we are looking at is a time frame in 2035 from today, when if we implement over the next 5 years these interventions, then what is going to be the situation in 2035 is what we are trying to model. And from the literature, existing literature, we try to derive what is going to be the reduction in PM 2.5 levels in Gurgaon and Amritsar, with different levels of targets that are being met for each of these interventions. So it's more of a what we call as decision modeling. And to make you understand a little bit more in simpler terms, what we mean by decision modeling, it is like, for example, during COVID, all of us remember there used to be models that used to be developed which predicted that, okay, in the next 3 months, when will the peak happen, or what will be the number of cases that will rise? And these models basically guided us to evaluate that how much would be the kind of requirement for ICU beds, oxygen, or other such resources. So this entire analysis is also something which draws on those principles of decision modeling. So in a way, we're trying to compare the two scenarios. So 2023 to 2028, assuming that there is going to be either a business as usual, that means there is the interventions are as it is that are today, versus you have an intervention scenario. There are going to be some PM 2.5 levels in either of the two scenarios. And depending on the relative risk of the interventions, there is going to be some change in the age-specific disease burden. And this change in the age-specific disease burden is likely to then contribute to some kind of economic burden also. So this is what we tried doing. And in order to do this kind of disease burden modeling, there are some very well-established exposure response curves. What do these exposure response curves they tell us? So these are kind of established, relationships between certain level of PM 2.5 and what is the risk of developing, let's say, a certain disease. And it also gives us a sense of that what is the extent of association between that disease and the level of PM 2.5. And based on that, you predict that what is going to be the number of cases that will happen in the community. And then for the intervention scenario, you apply certain level of effectiveness of the intervention. So this is the effectiveness of the intervention. And then based on that, you determine what is going to be the reduction in PM 2.5, which then gives you a certain reduction in the disease burden. Now, I've been trying to say a lot that diseases will be predicted, disease burden will be modeled, etc. So the question is that which diseases are we looking at? So the diseases that we considered in the analysis in our modeling were a set of these 6 diseases which have one of the strongest known association with the levels of air pollution, specifically PM 2.5 levels. And while there are other diseases also that are known to be associated, but these are those diseases for which the level of association is also reported to be quite high, and the degree of causal attribution is also known to be much stronger. So in a way, the level of confidence that we have that PM 2.5 leads to these diseases is pretty much high. So that's why we only restricted to this set of diseases, but not to say that there are not other diseases that may also be associated with levels of air pollution. So these diseases included the occurrence of stroke, ischemic heart disease, diabetes, chronic obstructive pulmonary disease, lung cancer, and ALRI. So these were the diseases that we modeled. And then what we did was that then we had some standard steps, and these are standard steps that you follow in any kind of decision modeling where you use these Markov models. And these are some standard methodological characteristics of these modeling. So this is just to give you a glimpse of how we model these diseases. So we basically develop these health states in which individual could be once you develop, let's say, angina or you develop stroke. So there could be, so these are drawn from, basic understanding of the disease and pathophysiology. And then you apply certain probabilities of people who develop, for example, angina to eventually have myocardial infarction, and from that to post-myocardial infarction, etc. There could be some probability that a person may die because of disease, and there's also a probability that there could be an all-cause mortality as well. So these are some standard, these are called as Markov models that we developed. For each disease, we developed these, for example, stroke, ischemic heart disease. Then we had a model that we used for diabetes and modeled the future complications that may arise due to diabetes. So for example, if you look at diabetes, we did not only say that, okay, if there's a person who develops diabetes, that's the end of it. But then we modeled that what over the lifetime of an individual who develops diabetes, what are going to be the complications? And we modeled both the microvascular and the macrovascular complications in terms of, things like, for example, retinopathy, blindness, and then stroke or kidney disease, or we looked at the cardiac complications of diabetes, as well as any kind of, microvascular complications such as diabetic foot, and then leading to any kind of amputation. So in a way, we try to model over the lifetime of an individual who today develops the disease, what is going to be potentially any subsequent complications of that disease also, and tracing it up to the person's life. And similarly, we did for COPD and also for lung cancer as well. And we also had a certain model that we used for ALRI, the lower respiratory infection. So eventually, based on after having done that entire thing, we also estimated what are going to be the cost of implementing the interventions. So when I say cost of implementing the interventions, we basically had stakeholder consultations with each of these departments, whether it is industry, whether it is agriculture, whether it is the municipal corporation with whom we wanted to have estimation of for the costs that might be involved, for example, in green belt development, etc. So essentially, the purpose of having these consultations with them was to understand what is going to be the cost of implementing or scaling up these interventions that are part of the National Clean Air Program. So each of those 10 or 12 interventions that I explained earlier, we had these detailed discussions, deliberations, and identified what resources are required in order to implement these interventions. And based on that, we estimated what is going to be the cost of implementing. We not only estimated the cost, initial cost of capital cost, but also the annual operating cost and maintenance cost of these interventions. And to an extent, we also, considered, for example, let's say I said, one of the intervention was that you do away with the diesel buses and introduce, let's say, electric vehicles. So if the diesel buses are gone, then what happens to that? There's certain scrap value of this diesel bus. So that scrap value was also kind of a kind of revenue to the government. So that was also attributed. So this is just an example to just illustrate the same point, saying that what if there is a total vehicular fleet and you replace certain number of vehicles from diesel vehicle to electric vehicle, then there's a certain cost of the electric vehicle, which is in terms of capital cost as well as incremental operation cost. But then there are certain scrap benefits, that means some scrap value of the diesel buses also that you will be able to get. So net cost is after deducting that scrap value. So finally, we combined the outputs of all these things. So from the health valuation side, we were getting how much are the diseases getting prevented, how many deaths are getting prevented, and we tried combining both those two things into one single measure, which is called as quality adjusted life year. We also estimated what is going to be the cost savings in terms of the treatment costs that are averted, because you have lesser morbidity. So if lesser morbidity is there, then that means that there are going to be less costs. And then we said that, okay, how much is the cost of implementing these intervention? And if you deduct that, these savings from the cost of intervention, then you get the net cost that you actually have are to face. And so the return on investment is the net benefit divided by the net cost. So if this ratio comes out to be more than 1, then that means that for every 1 rupee that you're spending, you're gaining more than 1 rupee. Then that means that it is a kind of a cost-saving intervention. Whereas if you have a ratio that is less than 1, it means that for every 1 rupee that you're spending on an intervention, it leads to a return of less than 1 rupee. So which means that it's an intervention where you're going to spend more and you're going to get less in terms of economic values. So this is the final result that we had for these two cities. So now if you look at these two, so what we are showing here is that there are bars. So the x-axis represents the total benefits, and total benefits are quantified in terms of rupees in millions. And so the entire length of the bar that we show here shows the extent of the economic return on the intervention that you are trying to do. So if you look at the Amritsar, the intervention that has the highest return on investment is development of roadside green belts. Second, you have an intervention like shifting the industries to cleaner fuel. That has a high return on in terms of the cost, the value of the benefits. And then we also show within that bar also, we break it down in terms of that within that total economic value of the benefit, what is the value that is added because of the health that you gain, by the costs that you avoid because of ill health, or the indirect costs that you avert, which means in terms of productivity losses, etc. And so this is also that we attribute. But interestingly, if you look at another city like Gurgaon, in Gurgaon, the extent to which each different intervention may have potential benefit in economic terms. And the reason why it may not be exactly the same is because of two reasons. A, the overall level of pollution that is there in the baseline, that determines the return on investment. And second, within that total pollution that is being caused, what is it that has a bigger, overall contribution to the overall level of air pollution? That's why an important lesson that we also have from this assessment is, and the recommendation that we also gave were that ideally you should have tailor-made strategies to combat this problem of environmental pollution, air pollution, or PM 2.5 levels across different regions. It should not be like a kind of a single size fit all kind of a strategy that can be applied, cut across all regions. But you should have such analysis that could guide the choice of interventions that the decision makers actually adopt. And so overall, if you look at the return on investment, considering the cost of implementing and considering the value that it offers, we tried looking at so these are all the interventions that we evaluated, and these are for two cities, Amritsar and Gurgaon, that we had. For all the boxes that you see in green color, these are the ones where you have a return on investment that is more than 1. That means these are cost-saving interventions. That means these are interventions that offer you the highest value for money. The ones that are shaded in red are the ones where you are going to spend more with that intervention but get less output out of that. So it's not a very cost-effective intervention to be done in that particular region. So if you look at Amritsar, almost all interventions are cost-effective, have a high value for money that we are going to spend, except for just one, which is the modal shift from of private vehicles to buses, which is not going to be cost-effective in either Gurgaon or Amritsar. But interestingly, in Gurgaon, there are 3 other set of interventions which are not as going to be as cost-effective. But one important lesson that we definitely had from this is that certain interventions like shifting the industry to cleaner fuel are perhaps the one that has the highest value on value for money that we are spending. So mind you, the previous slide that I showed you was only showing the value, the economic value of the health benefits that we have. Whereas this slide now accounts for how much we are going to spend on a particular intervention and how much was the value of the health benefits that we had, which is from the previous slide, and then it tries to combine. So this is like the final sort of indicator. And so if I was to communicate this to a decision maker in Amritsar, I would say all the interventions are going to be cost effective, all interventions are going to be good, but the one that you should choose the first is perhaps the shifting the industry to cleaner fuel, having greater control emissions in industry, because these are offering you the return on investment which are in the range of 7 to nearly 9, which means for every 1 rupee that you spend on tighter controls on emissions in industry, it offers you 7 rupees in return, 6.5 rupees, and similarly 8.5 rupees for if you shift them to cleaner fuels. Similarly, if you develop green belts in Amritsar, for every 1 rupee that you spend on green belt development, you get a return on investment of about 6 rupees 30 paise. So this is a very strong advocacy tool or piece of guidance for decision makers, policy makers to guide on choices that could be adopted for mitigating the air pollution problem. And finally, as I told you, we tried also plotting this entire analysis and results into this kind of a landscape where we said, okay, just showing the return on investment in terms of benefit cost ratio is not the only thing. There could also be something like ease of implementation also that is important. So if you move up the x-axis, there is a greater, the ease of implementation is more. If you are low down, ease of implementation is less. So for example, when you go to Amritsar or Gurgaon, perhaps an intervention that is not very easy to implement is this agricultural residue burning control. So this is not an easy thing to control. And the return on investment is also not too great. The benefit cost ratio is also relatively lower. So what I'm trying to also in a way highlight is that the extent of emphasis that sometimes we place on this particular one thing may specifically not lead us to better outcomes in terms of air pollution, etc. But moving to the top right box, which shows basically interventions that have high benefit cost ratio, that means these are the most cost effective, and these are relatively easy to implement also. These are the things that policymakers should adopt in the first place. Or if you want to go further, then come down to the box that is down below, which has again high benefit cost ratio, and it has a kind of a medium ease of implementation. These are things like green belt development or mechanical road cleaning, etc. So this is the kind of final summary that we showed to the policymakers there. And finally, we gave these recommendations that what should you do. So the first thing that we recommended was action around industry. Second was the action that needs to be taken at the public level in terms of promotion of use of public transport, etc. and all that. And certain things that we advised that this is what perhaps the government stakeholders could potentially do. So I think I'll stop here. And this is the final report that we ultimately submitted to the ministry. And this was a work that we did jointly in collaboration with the Center for Chronic Disease Control. And there were some other partners who helped us with the collection of data. This entire work was ultimately funded by the UNDP. So I'll stop here. Thank you very much. And I'll be happy to answer any questions if you have. Thank you.
Hello, good afternoon everyone. Thank you very much Dr. Shankar Prenja. You have covered this topic very widely and made us all richer in this knowledge, in this area. The topic is rightly labeled as investment case for air pollution reduction strategies in northern India. And it is the time that, rather maybe already we are late, that there should be focus on the environment and health. And this should be taught to the children from very beginning, because in our lifetime also we have seen a lot of changes in the environment, like increasing heat, more number of warmer days, decreasing like cold days, winter is getting shorter, decreasing rainy seasons, less rainfall, and this is affecting everyone, all human beings, animals, even plants. So this topic is very pertinent to all of us. I congratulate Dr. Shankar Pranja to cover it very nicely. Thank you.
Dr. Shankar, good afternoon and good evening. Dr. Dhruv Chaudhary here. We miss you, but I also want to share that Shankar is also one of our alumni. He did his post-graduation in community medicine from PJ Rohtak itself, and we are extremely happy and proud that he's in fact working at a policy level, especially Ayushman and health economics. And Shankar, thank you so much. But you see, the question is, I think one area which we have failed to focus actually in air pollution is its cardiovascular mortality. Because people are scared of sudden death. That's what they look at it. They feel that respiratory will, till they suffer it. And secondly, the impact of it on the pregnant ladies and the newborns and the mental retardation which is coming up there. I think those are the points which probably, besides the respiratory, we need to further, I think, highlight. Probably sometime you need to use that portion of scandalizing thing, though that's not a right word. But sometimes you need to put that forward besides breathlessness or other things which people are scared of. Everybody's scared of heart attack. Probably for an asthma, as long as you're scared, but you get out of it. I think that is one part which is underreported as far as the cardiovascular and genital effect on the newborns or intra-utero effect of the pregnancies. That is point one. Secondly, I want to know about is that, as Dr. Lalit very candidly put it, that point the forward. Yes, in our childhood we used to see large, at least 3 months of winters. We used to see good amount of rains. In fact, so-called Sawan ki Jhadi, we have just forgotten it now. We used to see as children, and over the last 80s we have not. So the question to you is, we are talking in terms of One Health, and that is where, besides zoonosis, how much emphasis we need to put in this, not only air pollution, but also pollution which we are facing in our food stuff which we are eating today. Therefore, the sustainability of the mankind. What's your brief comment on these things?
Yeah, thank you very much, sir. I think excellent points and things that we need to continue to work on. Just quick reflections on two important points that you raised. There was a bit of an echo, but I've heard them correctly. So I do recognize that the point that you make, that there are other health conditions also, like pregnancy, child health, neonatal conditions, etc., that are going to be neonatal outcomes that are going to be impacted by levels of PM 2.5 and air pollution. And I did mention that there are other health conditions beyond the sixth one that we modeled, which have also been shown to be associated. But we chose these ones in particular because these were the ones that for which estimates of association in terms of relative risk or odds ratio were perhaps the highest, and the degree of causal attribution was also much more stronger. Not to say, however, that there are other health conditions that are also associated. But in a way, if you look at it that way, then one can always say that whatever estimates that we generate for advocacy based on this study are rather more conservative. And so, which means that the true impact of the interventions that can potentially reduce air pollution is going to be even higher than what we are reporting. So, in a way, one can take it that way. But yes, more work can be done to do that. And I also agree that sometimes the narrative also becomes extremely important. So saying that how many cardiovascular cases, the chest symptom, the heart attacks or ischemic heart diseases that you prevent is sometimes, in terms of having the narrative, is sometimes very powerful. So that's a point well taken. The second point that you mentioned, sir, I think I also agree that there are many other aspects in terms of pollution that are equally important and are having significant health consequences also. For example, as you mentioned about the pollution, the contamination within the food items. So I think those are those are equally important issues, and they also need to be addressed in the overall holistic attempt towards addressing this problem from a One Health lens.
Thank you. In fact, we did one study with Dr. Lalar's department in the adults as well as in the children. And what we found was the use of air purifiers. And we found that even the 2 weeks when we took it away, Dr. Ashwini did the velocity, PV velocity with us, for us. And what we found out was that use of air purifiers improved the cardiovascular outcome within a short period of 2 weeks in children. That means if they are exposed over a period of time, for an extended period of a time, what sort of a consequence? Thank you so much, Shankar, but we miss you here. We would have loved to have you here, and I hope the purpose for which you stayed has been fulfilled. Thank you so much.
Another important area of pollution is also related to excessive use of plastics these days, and it is polluting our water supplies. It's going through the, say, rivers, even polluting the seas, and the aquatic animals are suffering hugely on this account. So plastic environmental pollution is also one very important area, needs to be taken care of. Thank you very much.
So thank you very much, and thank you, Dr. Shankar Prinja sir. I think it was a very meticulous study that you have done. I think in layman terms, everybody keeps on speaking on news ki parali jala di, khatam kar do. It's, as you said, that it's kind of a low implementation and also benefit to ratio, it's very less. Again, the model that you have suggested will vary from district to district, no doubt about that. But as you have shown the way, I am very much keen to know that how many districts further, and it takes a lot of, I think, energy also. I think you have showed a way to the world that how the answer should be, I think how the question should be answered, and they should have a multi-pronged view to the same problem, and you have also given us some practical approach how to address the problem. So with this, we thank you very much, and we have, I think it will be a crime on our part if we don't say that Dr. Shankar Prinja is among the top 2% of scientists globally in public health research as per the data revealed from Stanford University, and he deserves a big round of applause for this, just because of the researches you are doing. And the claps you must be hearing, that you are really a person worth deserve, and in top 20 global researcher in universal health coverage, which is also very close to your heart. And with this, we thank you very much for joining us. And I'll request Dr. Sanjay Tiwari sir, and I request Dr. M.G. Vashish sir to please come on the stage to felicitate our chairperson for this session. Thank you very much. So we covered zoonotic diseases, we discussed viruses, we discussed a lot of things today. It all depends in which thing attracts you the most, and the one part which was missing was the environment, which was covered in the last session. One Health is just the beginning. When you will grow up, I believe so that One Health would be the most important topic that will be taught in the medical curriculum. May I request the volunteers for the felicitation ceremony of the chairpersons? Rather, it is the future. So it has been an exhaustive academic feast for one day. Sir, कई बार तो हम पूरे महीने में इतना नहीं पढ़ते जितना आज हमने ज्ञान ले लिया है. वो है, it's like chewing the curd. देखते हैं कितना हम implement कर पाते हैं. But every speaker has some impression that has been laid on our mind. And now we are proceeding to the valedictory session. May I request all of you to kindly inform your friends who have presented posters and paper, because the valedictory session will also include the prize distribution for the best paper and posters. So we are going to start in 2 minutes.
So please give us 5 minutes of time to arrange the things for the valedictory ceremony. I request everybody who are all the participant delegates, staff members, to please come inside the auditorium, particularly the registration committee. who are working tirelessly since morning in the front desk. Our request.
नहीं पहले भैया कैमरे वाले उन्हीं को फोकस कर, इनकी स्माइल बड़ी अच्छी थी, जो हमारे देश का फ्यूचर है। दोबारा फोकस करना उन्हें एक बार भाई। इन बच्चों के लिए जोरदार तालियां, जो बेचारे सुबह से बैठे इसको सुन रहे हैं। हाँ, अपने लिए जोर से तालियां बजा सकते हो। हाँ, एंड इट इज़ ऑल रिकॉर्डेड, यू विल गेट अ यूट्यूब लिंक। आप अपने घर पे भी भेज सकते हो कि आज सच में आपने पढ़ाई करी है। ओके, वी विल शेयर द यूट्यूब लिंक विद योर CRs। हाँ ये कौन सा बैच है? कौन सा? हाँ, डॉक्टर तिवारी सर, सल्यूट, द लास्ट मैन स्टैंडिंग। अच्छा सर। और पीछे जो बैठे हैं एक बार भैया और पीछे फोकस कर रहा है, जो उधर बैठे हैं। हाँ जरूर से। हाँ, ये कौन सा बैच है? दीपिका। वेरी गुड सर, ये तो सॉलिडारिटी सी दिख रही है, ध्यान रखना यूनियनिज्म ना हो जाए। उधर तो प्रेजेंटर लग रहा है मुझे। प्रेजेंटर है उधर भी भैया, फोकस कर रहा है जो उधर बैठे। आपका चेहरा जरूर आना चाहिए, आखिरकार यूट्यूब लिंक है। आप अपने आप को बाद में देखकर कहें कि यस आई एम इन लाइमलाइट टू। हाँ, हेलो कर दो यार, हेलो। हाँ इट ओनली एक्चुअली समटाइम इट हैपेंस द वैलेडिक्टरी सेशन में ना, बस एक दूसरे को मोमेंटो देने वाले ही रह जाते हैं। आप बैठे हो तो हमारा भी मनोबल बहुत बड़ा हुआ है। थैंक यू सो मच फॉर बीइंग सो पेशेंट ऑडियंस।
Thank you again, Dr. Tiwari, as well as I think I sometimes feel little uncomfortable or disquiet when I don't see MBBS students. In fact, if you see today, I understand कि टेक्निकल में कई बार दिक्कत पड़ती है, पर तुम अगर एक चीज़ रियलाइज़ करोगे कि अगर ओवरऑल सारा देखोगे तो आप सबके जीवन पे ये चीज़ें कहीं ना कहीं छाप छोड़ती हैं, चाहे आपकी हेल्थ के लिए, चाहे इन्फॉर्मेशन के लिए, चाहे नॉलेज के लिए है। सो आई थिंक दैट इज़ वेरी इंपॉर्टेंट। और ट्रस्ट मी, आप लोगों को जो आज आप लोग आए हुए हैं, जिनके बारे में आपने सुना है, इनको एट द लेवल ऑफ द नेशन एंड द इंटरनेशनल लेवल पे लोग बुलाते रहते हैं, करते रहते हैं। जो चीज़ें आज हमें यहाँ बैठ के मिल रही हैं, मोर देन अंडर ग्रेजुएट्स, मुझे ऐसा लगता है कि हमारे पोस्ट ग्रेजुएट्स, उनको आने की ज़रूरत है। और डॉक्टर सिंगल सर, इसीलिए मैं बार बार रिक्वेस्ट करता हूँ कि हमें ओरिएंटेशन प्रोग्राम्स बच्चों के साथ बार बार करने हैं, ताकि उनको ये रियलाइज़ हो सके कि वी मीन गुड फॉर देम, एट द सेम टाइम वी ऑल्सो अंडरस्टैंड देयर प्रॉब्लम्स एंड इश्यूज एंड चैलेंजेस। थैंक यू ऑल ऑफ यू हु आर सिटिंग हियर, एंड आई एम सर्टन कुछ अंश आप इसका सीख के गए होंगे, समझ में आएगा। और ख़ास तौर पे एयर पोल्यूशन में, इन्फेक्शंस में, इनोवेशन में। इनोवेशन डॉक्टर तिवारी का मैंने खुद करते देखा है कि अगर कोई चीज़ ख़राब हो जाती है तो खुद लग के आपका कभी एयर कंप्रेसर ठीक कर रहे हैं, कभी मशीन ठीक कर रहे हैं। सो दैट इज़ व्हाट इज़ नीडेड एंड रिक्वायर्ड। इनोवेशन के लिए कोई हर चीज़ बड़े औजार नहीं चाहिए। इट्स द थॉट प्रोसेस एंड दैट प्रॉब्ली टचेज ऑल ऑफ अस एंड इन्फेक्शंस ऑल ऑफ अस। नाउ आई हैंड ओवर, आई वेलकम बैक आवर ऑनरेबल वाइस चांसलर प्रोफेसर H.K. Agarwal, our director Professor S.K. Singhal, and all my colleagues who are sitting here, including my dear friend and our dean Dr. Lala, Dr. Madan Gopal, we are all class fellows, Dr. Chauhan, whom I succeeded as a dean academic, thank you sir, Dr. Chauhan, Dr. Savita, everybody who is around, and the young smart good looking ladies sitting here, welcome you and thank you so much whether it is Preeti, whether it is Savita, whether it is Urmil, and other our colleagues, Madam Tiwari and everyone. Thank you so much. I hand over to them. And yes, Bhavna and Dimple too.
Thank you so much, sir. And we are proceeding with our valedictory session. For this, may I request on the stage all the eminent dignitaries. And may I start with our Dean PJMS, Dr. Kuldeep Singh Lalad, sir. Our Dean Student Welfare, Dr. M.G. Vashish, sir. Dr. Chauhan, sir. Sir, you have been our former Dean Academic Affairs, but Senior Professor in Radiotherapy. You always grace the occasion, and I always believe the best dressed professor and the head of PJMS Rohtak. I'll take this opportunity to invite on stage Principal Dental College, Dr. Tiwari. I'll request Principal College of Physiotherapy and Senior Professor in Orthopedics, Dr. Roop Singh. May I request our Director, Dr. Suresh Singhal, sir, our Vice Chancellor, sir, Dr. H.K. Agarwal, sir, and may I request Dr. Dhruv Chaudhary, Dean Academic Affairs and Organizing Secretary, to please escort them on the stage. And last but not the least, the backbone, or rather I would say the mother of this whole function, big round of applause for Dr. Pushpa Dhaya. She has taken so much pain to make this conclave a reality, and the efforts have been seen from since morning. So may I request you to please take the chairs. Yeah.
Esteemed dignitaries, respected faculty, dear delegates, and my dear friends and colleagues. After a lot of brainstorming and thought-provoking deliberations, along with oral and poster session by faculty and students since morning, we are here to reflect and recognize the efforts of researchers through this valedictory ceremony. On the behalf of the organizing committee, I extend a warm welcome to one and all to this valedictory ceremony. The third research conclave is resultant of hard work, dedication, and commitment of various committee members, because of which we are able to organize this wonderful event successfully. Please give a big round of applause to all the members of various committees, ladies and gentlemen. These committee members were the backbone of this third research conclave. They worked day and night, brought quotations, did comparative statements, did all the planning, strategy, hard work. Day and night they worked. It is the resultant of the hard work of all these committee members. We began with a compelling session on the One Health initiative in India and the National Center for Disease Control's pivotal role in integrating human, animal, and environmental health was highlighted in the morning session, in the inaugural session by Dr. Naveen Sharma. Discussion on antimicrobial resistance underscored the urgency of collaborative action in stewardship and policy reforms. The air pollution reduction case study provided valuable lessons on sustainable intervention for cleaner air. Dr. Dhruv Chaudhary sir also emphasizing on the cleaner air. So with the use of the air purifier, so most of us use air purifier in our homes as well, which is good. Each session reinforced the need for evidence-based strategies to address these pressing challenges in the modern times. It is important here to highlight the research initiative of Pandit B.D. Sharma University of Health Sciences, Rohtak. Our university has a medical research unit which is called MRU, established under ICMR, and Dr. Sanjay Kumar, Professor of Pathology, is a nodal officer of MRU. University has an institutional ethics committee and a research project advisory committee under the chairmanship of Dr. Sanjay Marwa, and myself being the member secretary of this committee. University also received research grant by Government of Haryana of 5 crores per year. A faculty research grant of 2.5 lakh per person is also given to the faculty to conduct various research. Additionally, under the university undergraduate research scheme, UURS, and all the young minds who are sitting here, they make use of it. Still it is open. I think last day is May 31st, Dr. Neeti, if I'm not wrong. 5th May is the last date. So like all the young researchers, MBBS, BDS, pharmacy and nursing students to submit the projects. All the research initiatives of the university is held under the leadership of Dr. Dhruv Chaudhary, Dean Research and Development Cell. Under the UURS scheme, every young researcher is given an amount of research grant of 30,000 rupees, and it is very, very essential to make use of this golden opportunity. It will be very, very useful for you if you want to apply to any postgraduate courses in the abroad university and the foreign universities. Very, very essential. Or if you want to apply for house jobs. This publication research is the valid point, and it will help you to get the job as well. I extend heartfelt gratitude to all our esteemed speakers, chairpersons, jury, and researchers for the contribution. Let us carry forward these learnings to drive impactful change in the public health and environmental sustainability. Now I'd like to invite none other than Dr. Dhruv Chaudhary, sir, Dean Research and Development Cell, Pandit B.D. Sharma, University of Health Sciences, Rohtak, for providing his thought about this third research conclave. Ladies and gentlemen, Dr. Dhruv Chaudhary, sir, please.
Good evening. Good evening. Jor se, good evening. Now everybody is awake now. Thank you. Honorable Vice Chancellor, Professor Agarwal, our Director, Professor S.K. Singhal, my colleague, my friend, our Dean PGI, Dr. Lalad, Dr. Tiwari, Dental Principal, Dental College, Dr. Roop Singh, Principal of Physiotherapy, also Dr. Ashok Chauhan and Dr. Madan Gopal Vishesh, who is the Dean Student Welfare, also Head of the Department of Surgery, and none other than Professor Dr. Pushpa, who has been the backbone of this conclave which we have done it today. First of all, I express my gratitude to all the persons who are sitting on the dais, because without their help, support, it would not have been possible for us to look at it. When I went to Dr. Agarwal in the month of February, I said, we need to do it. He just said, who is stopping you? Why don't you go ahead? That's what was there. The only thing we wanted to do at that point of time in 14th, but it was a holy, so we shifted it up. I know dominantly people who are sitting here are from, students are from dental, but nevertheless, today, medical sciences, dental sciences, veterinary sciences, all there is a train which meets at some of the other places. The university has committed and is bound by its ethics and ethos for, besides patient care, teaching and training, to the principle of research. And already our Honorable Vice Chancellor has announced right in the morning in his address that we are going to start in full throttle way the PhD programs, which are going to be change the scenario in the coming years. Also, we're going to improve not only the constituent institutions, we have number of institutes who are affiliated to us. Total number is 144, out of which now 10 are medical schools and nearly 14 I think are the medical schools, 9 are our dental schools, and along with it, we have number of other pharmacy, physiotherapy colleges are there. Medical sciences, if I think as a medical man I can do it, answer is capital no. It requires collaboration, it requires involvement of multiple places, multiple organs, multiple institutes, as well as multiple disciplines. That is why when Dr. Sharma was showing us, health is not only we see the disease, but at the same time it is equally important for us, the preventive or the public health aspect of it, and seeing it that people fall less and less ill or diseased. But nevertheless, that's easier said than done. So your participation of all of you is essential, needed, required. And one or two things which I could actually conclude from what we have deliberation is, and looking at the way the Government of India is Thursdays, and our director was also telling me that he was attending DHR meeting for the 2 days, like yesterday and today also. At least I straight away propose how to act on it is, I think we need to do it. One thing I think probably what my learning point from this is that we need to consider, if our Department of Community Medicine agrees, microbiology agrees, and other stakeholders agree, to have a chair on One Health in the University of Health Sciences, because that is the beginning. We need to march ahead and look beyond 20, 30 years ahead where the things are going. And when I say chair on it, Universities have the inherent autonomous power to create it, and I think this can set a ball rolling, which can have a zoonotic, which can have a pollution, and other things are part and parcel of it. That is one thing I can conclude. Second conclusion which I get is that we need to engage with our younger generation, whether they are undergraduates, postgraduates, and equal amount of nurturing and engagement, which sometimes is needed and required with our faculty also. I am little disheartened looking at the number of faculty which is there, especially is not as what we would expect them to be, and I'm saying it up front. I think it is very important is that we are trying to expand and giving the engagements, but somewhere nobody likes at this switch and time and place to say something which is unpleasant. But nevertheless, it is extremely important for us, for the purpose for our youngsters to learn and move ahead, is that as a faculty we become a role model for them, because administration people will forget, but they will never ever forget the impact of the teaching and the teacher which we make it up on the students. And I think all of you will agree with it. And also, I would like to give you one, not sermon, one story of a girl, Vanishka, who presented the paper today. It's not only, yes, she wants to go to US, no doubt about it. She did an ICMR Dr. Agarwal project with us. This project, obviously when we sent it up, we simply looked at very simple thing. You don't need hi-fi things. What are the barriers to take preventive therapy in tuberculosis? She did it in 3 districts. We learned collaborating with the Department of Health, Government of Haryana. We did it in 3 districts. This girl did it in 373 cases, found out the data. We then, once it was compiled, we submitted to the ICMR, it was accepted. Because after acceptance, then she got rupees 50,000 as a scholarship and award on behalf of that from ICMR in STS. Looking at that, we have started for you also for last 2 years, undergraduate schemes where we have giving rupees 30,000 for those who accepted. So my request to all of you is participate and the teachers to come forward to mentor and guide them. The story doesn't end here, my dear friends. She applied and she sent that abstract of that study to International Union Against Tuberculosis and Lung Diseases. It accepted it. And do you know where the conference happened? It happened in Bali. How many of you would like to go to Bali? Raise your hands. Bali agar mauka mile to kitne log jana chahenge? Sorry, that's fine. This girl got that chance. और अगर फ्री में जाना मिल जाए तो कैसा लगेगा? बहुत अच्छा लगेगा. So what I am trying to make is IUA2LD gave her the free registration, free transportation, free boarding and lodging, and 5 days of stay in Bali. That if you put it from your pocket will cost you anywhere 1.5 to 2 lakhs. That is not the money which is important. She presented the paper there. And today she did it here also, our request in one of the sessions. Look at it. And today wherever she is applying, this is being taken up. Another story I'm telling to youngsters, that's true that girl also wants to go to US. Her father is working with the government, Dr. Singhal knows them. She worked 2 months observership post-internship with us. We were working on silicosis. And Dr. Agarwal, the best part which was coming up was, father himself is an officer in the labor department. I'm sharing it here. This is another interesting story. People who have got the silicosis, they get compensation from the government and they get the pensions throughout their life. What we found out that those who should not have gone back, they again went back to the same working conditions in terms of mining industry. And they were taking compensations from there. So it was contradictory things. And what we found out, they had no additional skill sets. They didn't know anything else except mining. Even the father, who happens to be a labor officer, he himself was surprised because that is where you find out the problem. This is what the problem came up. Now the solution we have to find out. So every problem comes up with a solution. The answer I gave you these 2 stories is that it is not a hi-fi research which was done, but it was simple questionnaire-based cost-effective thing with telephonic calls following it up. Within 6 weeks, we were able to find out, and now that paper has been written and being sent for it. That is the second part of it. All of us have to learn. Whatever you have done, it has to be written, has to be published. Otherwise, that tends to get lost. So it is fundamental which you have to do. So for writing, you don't need to go to final year of dental, final year of medicine. Start doing it from the beginning. It will help you evolving as an individual, and obviously you will learn the collaboration and the role of teamwork. I will not go beyond that because then it becomes sermonizing. It's already becoming late. Thank you very much for patient listening. But at the same time, I am grateful to all my colleagues, younger colleagues who are sitting it here. Apologies whose name I couldn't take at that point of time. I also become a little emotional seeing my friends. And please, sitting up here, please forgive me for that. Nevertheless, I assure you that next year we'll do better. But one thing with the one promise, that each one of you will get 2 of your friends, and to my colleagues, that they will ensure it, that they keep on encouraging us, especially whether it is the Vice Chancellor, Director, Dean, etc. We all, whatever, do it, but we are nothing without you. And at the same time, if we have to progress, we have to progress with hand in hand. And my young colleagues, especially faculty, probably will come forward so that we again take this institution ahead. Thank you very much.
हाँ, तो आप में से नेक्स्ट कौन जाना चाहता है बाली? सारे जाना चाहते हैं? तो फिर ऐसी रिसर्च करिए जिससे लोग अपने आप आपको बुला कर कहें कि प्रेजेंटेड. इट्स जस्ट टू, बट अगेन सर हैज सेड कि यस, पीपल वांट गुड रिसर्च, एंड जो यूथ की एनर्जी अगर वो चैनलाइज हो जाए रिसर्च की तरफ, तो स्काई इज द लिमिट. सो विद दिस आई विल रिक्वेस्ट now I would like to request, my apologies. Now it's time to recognize and appreciate young researchers who have won best paper and best posters in various categories. First of all, जितने भी participant थे उनके लिए एक बार तालियां जरूर बजाएं. It is worth mentioning that we received more than 765 registration, and young researchers submitted 350 plus abstract, out of which 300 abstracts were selected for oral presentation. Out of them 39 were oral and rest were poster presentation. And now it's time to announce the prize winners. It was a tough competition and the jury had a tough time in selecting the winners. May I invite on stage, these 2 people have been the backbone from starting from day 1, and Dr. Pushpa Dhaya will vouch. All the academic activities, oral posters, selections and their segregations into various domains was not possible without undying efforts of Dr. Harneet Singh and Dr. Neeti Mittal. A big round of applause for these 2 people. Stage is all yours.
Good evening, respected dignitaries on the dais, and good evening to all of you. So I won't take much of time, we are already late. So Young Researcher Award goes to Dr. Harneet Singh and Dr. Neeti Mittal. Yes, indeed, it was a difficult task because going through 350 odd abstracts, scrutinizing them, then sending it back to the teachers, getting their critical reviews back, then finalizing them into papers and posters was a tough ask. And I thank Dr. Neeti for being a good team. I thank the Vice Chancellor Sir, Dr. Dhruv Sir and Pushpa Ma'am for trusting on us. So congratulations to all of you, first of all. And I guarantee you, जितने यहाँ बचे हैं उन्हीं को certificate और checks मिलेंगे. Please, ma'am. So we'll start with the undergraduates first because they had put in a lot of efforts. Some wonderful papers and wonderful posters came in. So undergraduates, I would like request Dr. Neeti to please announce the UG poster prizes.
Okay, so for UG poster award session, we have first prize for Nikita Malik, MBBS student.
Nikita Malik, if you are around, please भाग के आ जाओ. Which college? PGIMS Rohtak, sir. The second prize goes to Rachita, again from PGIMS Rohtak. Please give a huge round of applause because they are the... I would like to request the dignitaries to please come in front. UGs के लिए नहीं है. We appreciate the efforts of all the undergraduate students for sending their abstracts. Although we don't have the cash prizes for them, but their appreciation and blessings are the need of the hour right now. Check-in का नहीं है सर, UGs का नहीं है, UGs का नहीं है, PGs का है, अगले साल से. So coming on to the best paper, yes, UG's best paper, oral paper awards.
The first prize goes to Rishika from PGIDS Rohtak. Congratulations, Rishika. And the second prize goes to Bhavesh Goyal, also from PGIDS Rohtak.
Congratulations to all the undergraduate students. So as we had around more than 250 abstracts for the posters, and it was the most challenging task even for the coordinators who were among the screens. So एक बार coordinators के लिए भी तालियां बजा दो, the faculties and the postgraduates, the residents who were there coordinating since morning, all 3 sessions. So the prize winners for the posters, it was a tough competition. We have a consolation prize for the posters as well. Dr. Kritika Jain from ophthalmology. He is not here. This is for medical posters. We have 3 categories, medical, dental and paramedical. So the second prize, medical poster, best poster goes to Vaishali. Radio diagnosis.
And the first prize for medical posture goes to Dr. Rahul. Probably they are not here.
Yeah.
So we can proceed further.
Yes. Coming on to the dental prize winners, the second prize goes to Dr. Muzaffar from Department of Endodontics. He is the first person जो पैसे लेने आ गया. So he wins rupees 4,000. And the first prize goes to Dr. Kalpana from Department of Public Health Dentistry. And she wins rupees 8,000. Sir, क्या पता?
Dr. Kalpana.
तालियां बजा दो. Next time you could be here as well, winning all the prizes. So from paramedical courses, the second poster prize goes to Kirti from physiotherapy. Is Kirti here? नहीं है. The first prize goes to Zafar. नहीं है. चलो.
जो नहीं आ रहे इनके पैसे रख लो.
हाँ. And again, we had some exhilarating oral paper sessions. So we were actually, it was a difficult task to give away the prizes or not give away the prizes. So we had a couple of consolation prizes as well. So the second consolation prize goes to Himanshu Gautam from Department of Radio Diagnostics, PGIMS.
And the first consolation prize for oral award session goes to Ms. Deepika Sangwan from College of Nursing, PGIMS.
जाओ चलो. हाँ हाँ कोई बात नहीं, पैसे नहीं दे रहे. Okay. So going for some good huge amount. The third prize in oral paper presentation goes to Dr. Ritika Dhamija from Department of Endodontics. And she has won the prize of 8,000 rupees.
वो जब उसने प्रेजेंटेशन करी थी तब से अब तक खांस रही थी, तो पहले इन पैसों से ना एक अच्छा सा कफ लॉजेंसेस लेने हैं, ठीक है? But it was a very good presentation. She put every heart and soul into the presentation at that time.
The second prize for oral award session goes to Dr. Akansha from Department of Radio Diagnosis, PGIMS.
And she wins the prize of rupees 10,000. Ritika. नाम लिखवाना है पीछे. I request all the cash prize winners to please get your names registered on these checks backstage. A huge round of applause for Dr. Akanksha.
And the first prize for oral award session goes to Dr. Satya Ranjan Mishra from the Department of Pharmacology, BPS Kanpur. But he has left and so we will not be able to give him the certificate.
Is there any representative from Kanpur who can collect the check? He has won the prize of 12,000 rupees. Koi to aa jao. Thank you so much to respected dignitaries as well. Please take the check.
Thank you so much.
Thank you so much. Listen, 2 minutes. May I request all the dignitaries to please take their seats. And may I request Dr. Pushpa Dhaya ma'am, organizing chairman of 3rd Research Conclave, to please give the valedictory vote of thanks.
कोई नहीं नीचे गिरा हुआ था. No, ये छोड़ दो ऐसे. Good evening, everyone. Now, as we come to the end of this enlightening 3rd Research Conclave, it's my distinct pleasure and proud privilege to be here to deliver the vote of thanks on behalf of students and university faculty of this country. First and foremost, I would like to thank our chief guest, though he has left now, Dr. Naveen Kumar, for accepting our invitation and delivering a talk on One Health initiative in India. What I feel is the talk which he gave were commendable. His words of wisdom, the experience which he shared with us have made us more wiser. His talk was very lucid and understanding of the problems he told us, the understanding of the problems which the scientific world is facing today would undoubtedly is going to inspire all of us. It's my pleasure and duty to extend a heartfelt thanks to Dr. Simmi Tiwari for sharing her expertise and valuable insights about the NCDC role in bridging human, animal, and environmental health. Her talk was also very lucid and he must have inspired and enriched all of us. I'm highly thankful to Dr. Abdul Ghafoor and Dr. Prinja though Dr. Prinja was not able to come here, but he delivered a very nice talk online. And he enlightened us on the challenges in antimicrobial resistance by Dr. Abdul and air pollution reduction strategies and how we can overcome these problems. Because this is the burning problems a common man is facing nowadays, and even the government all over the world, we are stressing more and more on One Health. All these talks which we have heard since morning will definitely have a great impact on all these young researchers who have attended this research conclave since morning, and it's going to have a great impact on the complicating issues which are going on nowadays. My special thanks to our Vice Chancellor, Worthy Vice Chancellor, who gave me this opportunity to be the chairperson for this third research conclave. I'm very much thankful to you, sir. Dr. H.K. Agarwal is having an unwavering leadership and dedication to our university. Sir, it's your vision and guidance which is truly instrumental in making this event a great success. The whole organizing team is thankful for your continuous support and meticulous planning about this research conclave. Sir, your close observations and efforts behind the scenes, they have ensured that everything is being done and achieved well in time, smoothly, and I think that is being reflected in today's event. I am thankful to you, sir. It gives me immense pleasure to thank Dr. S.K. Singhal, our worthy director, Dr. Dhruv Chaudhary, the Dean Academics of the university, for their continuous support in all possible ways to make this event a great success. It's my proud privilege to thank Dr. Kuldeep Lalat, the Dean PGIMS, and Dr. Kundan Mittal, the Medical Superintendent of our hospital, for their valuable inputs and encouragement for this academic activity. A big thanks from the bottom of my heart for the Principal PGIDS, Dr. Sanjay Tiwari, for overwhelming and unconditional support as ever, for his contribution, for motivation, even in the night when I came in the evening just to have a look for this. Even at that time, he was very much concerned. In the evening also, he was there to find out whether I need any sort of help at that time also. I'm thankful to you, sir. Under your able guidance, our dental institute is continuously on the path of excellency in dentistry. The whole team is grateful to our faculty, the judges who were very much there at 8:30 sharp for judging the e-posters. I am really thankful from the bottom of my heart that everyone was there in time and we were able to finish this, complete my endeavor well in time, thanks to all the faculty members, because their unbiased judgment has added sparkle to this event. Now, because any event cannot be done so smoothly without the help of all the committees which were there with me. A big thanks to the catering committee, Dr. Jyotsna Sen, and Dr. R.K. Sharma, Dr. Sumit Sachdeva, for enriching our taste buds, for each and every participant, and they were being appreciated by all the delegates. Your efforts, they have added a special touch to our celebration. Thank you so much. Later on. I'm thankful to Dr. Manjunath and his team. They deserve special appreciation for their untiring efforts which they have put in managing the stage. I am thankful to Dr. Sukhbir Singh, Dr. Harneet, Dr. Varun, Dr. Niti, because they have made an extra efforts for scientific also and for running for each and everything. Whenever I am in trouble, I have to call either Dr. Harneet or Varun. Can you please help me? And they are always there on a call. Thank you so much, Dr. Harneet and Varun. What I feel is I cannot do anything whenever this research or foundation or convocation, I think, is there without Harneet and Varun. So it's, and Dr. Neeti and Manjunath, because they are the one who just manage the stage. And it's a very difficult job to do each and everything. So I'm thankful, really, I'm thankful to all of them. Thanks to Dr. Savita Verma and her team for managing the registration desk very efficiently. There were no any problems were there. All the participants, the registrations, they went very smoothly. Thank you so much. I am thankful to the media and public relations team, Dr. Sujata, Dr. Umesh, for spreading the word so nicely that nearly around 760 registrations, they were there, and so many participants, the abstracts were there, because we were able to communicate and spread the word through the media very nicely. Thank you so much. I will be failing my duty if I don't do the appreciation about Dr. Preeti Gehlot, Dr. Urmil, Dr. Umesh, Dr. Manjunath, Dr. Varun, because they have managed the stage so beautifully that I don't have to say anything, and everything went so smoothly. Thanks a lot. I would acknowledge the support and extent of all the principals and deans of our affiliated colleges who were there and their students, because of them only they motivated their students to be there. And that's why we have seen that it's not only the PGIMS or PGIDS students who got the prizes, even the one student from the Faridabad, one from Kanpur, they also got the prizes. So because they motivated their students to be there. I am thankful to the accounts department, Mr. Manocha, Mr. Rajesh Navinder, because they were very helpful. They very promptly processed all the various proposals well in time, and we didn't have any sort of problem this time. And I know that why it was there, because our leader is so strong that they cannot say anything. So immediately, the moment I have to say, immediately they said, okay, the work will be done. So I am really thankful for the ministerial staff of the administrative branch, because they were able to handle the thing so well that everything went so smoothly with their help only. And finally, I think it's a time that I have to thank each and every one of you, the students, the faculty, because no event can be successful if the participants, they are not there. So thanks each and everyone, and I feel that you are going to forgive me if I have unintentionally, I have forgotten the name of anyone, any of the participant, or the contribution of anyone. So thank you once again. But I would like to call the subcommittees, chairs of the subcommittees, so that we can appreciate them by a floral bouquet. So I think Dr. Jyotsna is not, Dr. R.K. Sharma is there. Sir, I would like to just say, we will give the bouquet. Bouquets are there, can you say? मैं उनके नाम कहाँ रखे थे? नाम से हाँ दे देंगे. नाम बुक्के वाला काम दिया. सबके नाम बोल देना प्लीज.
So on the behalf of Food and Catering, Dr. R.K. Sharma sir. Dr. Jyotsna ma'am is not here, but Dr. R.K. Sharma sir. सर ये बात पीछे आ रही थी कि गुलाब जामुन में उतनी मिठास नहीं थी जितनी आपकी वाणी में. तो कई लोगों ने गुलाब जामुन खाया नहीं है, तो डॉक्टर आर के शर्मा सर को देख लो, वो भी उनसे ज़्यादा मीठे हैं.
So now okay. Thank you, Dr. R.K. Sharma.
कुछ तो ये भी कह रहे थे कि आप आइसक्रीम जितने ठंडे भी हो.
नहीं ऐसा नहीं है. So now I would like to call upon Dr. Manjunath, Stage Management Committee, for his untiring efforts, and he was also there till late evening for doing his job. And I think all this stage management he conducted so well.
डेंटल के स्टूडेंट कहते हैं कि सर की टाई देख के पता चल जाता है सर का मूड कैसा है.
So, I think now I would like to call the Dr. Savita Verma, Reception Committee Chair.
नीडलेस टू से ये 45 इयर्स तक का यंग फैकल्टी अवार्ड था, वरना मैडम जितनी क्लिनिकल रिसर्च कर रही है मैडम भी अवार्ड के लिए. आप लग नहीं रहे हो 45 के, मैं ये शेयर नहीं करना चाहता, बट शी हैज़ डन अ वंडरफुल जॉब बीइंग द रिसेप्शन चार्ज ऑफ रिसेप्शन कमेटी. सही बात.
Now, the next I would like to call upon the scientific committee, Dr. Harneet and Dr. Neeti Mittal, because they did.
My team also, because I want to thank my team because Dr. Bhavna, Dr. Vipul and Dr. Shelley, because of their backbone and their efforts, I would not have been able to do it. So thank you to them. Yeah. Thank you.
Because I have called the chairs of all subcommittees. So Dr. Harneet and Dr. Neeti Mittal, because they were looking after the scientific part. Then the next is about the audio visual. Whatever you are saying all around or sparkling, everywhere the things went so smoothly, it is because of Dr. Varun only, because he was looking after the audio visual part. Because I think the first time we did the online lecture and it went so nicely, so smoothly, there was not even a single minute intervention. Thank you, Dr. Varun. I think the publicity committee chairperson, Dr. Sujata Sethi is not there. So I really appreciate her work, Dr. Sujata Sethi and Dr. Umesh. And the website management committee, Dr. Vivek Malik. So I really appreciate the work which is being done by the subcommittee. And I am really thankful to all the...
There are two prize winners. Sorry to interrupt in between, but as the matter of money has spread, so we have got the prize winners coming in. So there is... we have the first among the posters from Paramedical Sciences, Zafar. He's won the prize of 8,000 rupees. Can we please have the certificate?
और आधे पैसे डॉक्टर हरनीत को ट्रांसफर करने हैं, ठीक है? अरे सर कोई दूसरा भी है? हाँ सर
नहीं. And Dr. Kritika, she has won the consolation prize in medical posters. Please clap for Dr. Kritika as well. Everybody will take a group photo along with the dignitaries. Everybody will come to the group photo. Thank you.
So, take sir photograph for the backstage team.
So my team have worked day and night, sir. Dr. Shubhi, Dr. Jagruti, all my residents and interns. So I'd like to have a photo along with all the dignitaries, please.
May I request all the faculty member also? Dr. Sudhir, Dr. Preeti, yes. Please join. Dr. Urmil Chawla, ma'am. गायनी डिपार्टमेंट के स्टालवर्ड्स बैठे हैं उधर, डॉक्टर मीनाक्षी, डॉक्टर सविता सिंगल मैम, डॉक्टर वंदना.
Dr. Kiran ma'am, Dr. Kiran Preet ma'am, please come up.
डॉक्टर किरण प्रीत मैम और भी जितने फैकल्टी वाले हैं सब आ जाओ, ताकि कल ये फोटो आप लगाकर बोल सके कि हम ही प्रेजेंट थे, बाकी नहीं थे. हाँ इधर आ. I request the team members, एक बार team members आ जाए. बस 2 मिनट और खत्म कर रहे हैं. 2 मिनट बस. डॉक्टर तिवारी ने कह दिया इन सबके रोल नंबर नोट कर लो, इन सबको एक्स्ट्रा मार्क्स मिलेंगे. सर हाँ या ना? हाँ. जो बच्चे लास्ट तक बैठे हैं उनकी भी एक फोटोग्राफ होगी सारे सबके साथ, सही है नहीं? हाँ. यू डिजर्व इट, यू हैव अर्नड इट. स्टूडेंट्स इसके बाद ऑल द स्टूडेंट्स ज्वाइन फास्ट फॉर द स्टेज. बैग वहीं रख दो, बैग वहीं रख दो, फटाफट आ जाओ. यू हैव अर्नड इट. अच्छा मैं भी हो गया.
आगे जाओ.
अच्छा बैठ जाओ, सारे आगे आ जाओ. जो आगे बढ़ते हो उसकी ज़्यादा अच्छी है. सारे अभी दिनेश जी हैं सामने.
दिनेश जी
पूरे सामने
जो बैठे हुए हैं,
वो जो पीछे वो शर्ट में वाइट शर्ट.
जो बैठे हुए हैं.
हाँ उन्हीं को अभी मैं बुला रहा हूँ. थैंक यू. और अभी आपसे अनुरोध है आप आराम से जाकर अपनी सीट पर खड़े हो जाएं ताकि सर नेशनल एंथम इज पेंडिंग. नेशनल एंथम रिक्वेस्ट प्लीज. Thank you very much. I request all the students to kindly stand and all the faculty members to please stand up in attention in respect of our national anthem. चलिए.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे तव शुभ आशीष मांगे. गाहे तव जय गाथा. जन गण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
Thank you everyone. Thank you our Honorable Vice Chancellor, our directors and all the